Good morning, everybody here in the audience, everybody online, and welcome to the Climate Classroom and the session on climate change and health. So this will be a joint exercise with our lovely colleagues from UNCC Learn, who have just informed us that WHO and Health is the longest standing partner, or the consistent partner, in the Climate Classroom since they started at COP22. I think you said. So the purpose of this session is to give a brief introduction very quickly on climate change and health, but I think everybody in the audience who's listening online is probably already an expert on climate and health. But more relevantly for this discussion, to bring people up to speed on what we are doing as WHO and the wider health community in relation to the negotiations. Effectively what we're doing here at COP27 and what we're trying to achieve. Because we know that the climate negotiations can be confusing, disorientating. Health people are often new to these consultations and need to often benefit from some briefing on the relationship between the two. So if we could have the next slide, please. So this is almost the only slide that I wanted to show on the health impacts of climate change. So people like me who have been working on climate change and health for longer than sometimes we care to admit, started off maybe about 20 years ago, a few years earlier in a few people's cases, telling people that they need to be concerned about the health impacts of climate change. Health impacts of climate change are coming. We were doing projections of the health impacts of climate change, but these were reports from Geneva, from experts around the world saying this is something you need to be aware of, something you need to worry about. Our experience over the last 20 years has just been watching that, unfortunately, come true in front of our eyes. And so we were talking about the health impacts of extreme weather events, so heat waves, more extreme heat waves, more extreme floods and storms. We were talking about the health impacts of infectious diseases, so the fact that a warming, wetter climate makes it easier to transmit dengue or malaria or diseases transmitted by other insects. We were talking about waterborne disease, so diarrheal disease, mainly transmitted through water and food, was also going to get worse from climate change. And we were also pointing out that for some parts of the world, climate change, the long-term effects of climate change, such as sea level rise, would actually make whole countries uninhabitable and force people to move, and that would be a climate disaster. So that's what we were saying 20 years ago, and we're now getting those reports back directly from the field. So that on the right-hand side, you see our member states carrying out vulnerability and adaptation assessments and reporting what the health impacts that they are already seeing or they're concerned about. And there were even ones on there that we were not really aware of or didn't even project 20 years ago, such as mental health and climate change, which is now a really big issue reported from our countries, particularly around young people. So that's the first fact that I wanted to get across. The second, if we can have the next slide, please. You will hear many things within the negotiations about climate justice and the need for fairness and equity in response to climate change. We would say that health is the best example or the worst example of that inequity. And this is work, again, that we did years ago at WHO, which documented the numbers of deaths attributable to climate change, even in the year 2000. And the bottom part of the graph is regions of the world expanded or contracted according to the severity of those impacts. And on the top part of the figure, you have where the carbon emissions have come from. So the world is expanded or contracted depending on where the carbon emissions have come from up until now. And you can see that it's almost the inverse. So really those populations which are most impacted by all of the effects of climate change, including the health impacts, are not the ones that emitted the carbon. And we say this, in fact, not to point blame, but to make clear that there does need to be a joint global effort to protect those who are most vulnerable, because unlike many other health issues, this is absolutely not of their making. So next slide, please. And one of the messages that we have been saying for several years, and it's the reason that we keep coming back to COPs and expanding the health presence in the COPs, is that for everything that we do around health and protecting people's health in the World Health Assembly or other health meetings, we actually acknowledge that the most important health treaty of the century is not something negotiated at the World Health Assembly in Geneva, it was the Paris Agreement. And the reason that we say that is because unless we are able to get on top of climate change, to cut carbon emissions, and to protect the environmental and social services on which health depends, all of which depend on a stable climate, then it almost doesn't matter the other things that we do in health negotiations if we're not able to protect the climate. So we are consistent in saying the Paris Agreement is a public health agreement, and it's probably the most important public health agreement that we have. Next slide, please. And I have to say it's been quite a long battle on climate change and health, or to get health more centrally into the climate negotiations. We have all sympathy for the negotiators here. They have a really difficult job. They have the job of trying to negotiate the agreements that will drive down carbon emissions, that will support adaptation, which will generate finance, and so on. Basically, these are busy people who don't want any more complication than they already have. And that's been the sort of passive resistance, we would say, on giving a greater role to health. But the offer we're making from health is to say that, in fact, health is your best argument for driving down carbon emissions, for generating finance for adaptation and so on, because health matters to people. And that has started to change, and we're starting to get more acceptance, active acceptance of that message from the negotiations. And we had real progress in COP26 under the UK presidency, where we had the first ever health programme under a COP. And so that had four main initiatives. You see them here on the slide. I won't read out the titles, but we were also able to ask countries to make commitments on the top two of these around committing to build climate resilience into their health systems, and also to look at whether they could drive down carbon emissions within their health systems, because health is 10% of the global economy. It's about 5% of carbon emissions. It has more carbon emissions than Africa or aviation, so it's a really important emitting sector as well. And so we want to take forward how we can drive down emissions at the same time as improving universal health coverage and the effectiveness of health services. So we had a big step forward, I would say, at COP26. Next slide, please. And just to bring us up to speed on what we're trying to achieve here, it's at COP27. So over the past couple of years, we've tried to be more systematic about how we approach health, how we approach COPs as a health community. And as the health community has expanded, we have many more allies in this space, from NGOs, civil society, really importantly, ministries of health, national governments, academics, and so on. And so we aim to engage with the negotiations, or at least keep an eye on what the negotiations are doing. We have high-level side events, the UN System side event. We have training sessions such as this training session, but also the many conversations that we have with people in ministries of health and so on. And for the second year now, we have this health pavilion, which I don't like to boast, but it is the best pavilion in the whole COP. And it's, as you can see, an absolutely beautiful and meaningful work of art. If you weren't here for the opening, I'll just give you the brief introduction. This wonderful sculpture is in the shape of human lungs. It's from recycled car parts, I think, certainly from recycled materials. If you touch it, it vibrates at the same frequency as a human body. And that's basically, we've had a dream, and our boss has had a dream for a couple of years, to bring lungs into the center of the climate negotiations, because that's where we're paying the price of climate change. And so we have a full program in this amazing session. Next slide, please. But as we build up the sideshow to the actual negotiations, we're also aware that we need to pay more attention to the negotiations themselves. So building up that community, talking amongst the converted on health and climate change is very useful, because it builds a coherent health voice. builds capacity and so on. But it does really matter what's going on over in the negotiations. So some of the key topics under negotiation are things like loss and damage. We have loss and damage for the first time on a COP agenda, discussion about financing. Adaptation, which for us basically means public health, protecting people from the health impacts of climate change. Mitigation, which for everybody else here is about tons of carbon dioxide averted from the atmosphere, really important. But for us, it's also about air pollution averted in the atmosphere, more sustainable and healthy diets, all of the great health gains that will come from climate action, and so on down the negotiating agenda. And hopefully you can see that each of these has direct connections to human health. And so what we've tried to do more systematically this year is to produce briefs making that connection, to make it easy for the climate negotiators to understand what health is bringing to these negotiations. So we have briefs on each of those topics. Next slide, please. So at the high-level side event, which took place a couple of days ago, don't worry if you missed it. Well, congratulations if you were there. It's a great side event. But if you missed it, the main message that we wanted to get across is that all of those health commitments that were taken last year, all of those, now more than 60 countries signed up to build more climate-resilient health systems and help work to decarbonize their health systems. We now have a mechanism in place to discuss, to bring partners together to support those, so that those commitments don't just stay on paper. And so we now have the Alliance for Transformative Action on Climate and Health, which is convened by the UK government, the Egyptian government. UAE is being brought on board for next year, and it has working groups around climate resilience, health systems, decarbonizing the health sector supply chain, and finance. And so I'd encourage particularly member states, but also the wider community to attach onto the attach, because that's the vehicle we're using to support countries to make sure that those commitments don't just stay on paper. Next slide, please. We're also engaging in youth activities as well. It's been brilliant to see over the past week or so how youth have, in the most positive way, almost taken over the negotiations. So we have a really strong youth engagement across the board, and that's, I would say, we're fully following that up from the health community. So for many years, for example, the International Federation of Medical Students Associations, for more than a decade, have been some of the best health campaigners in the climate negotiations. And we have broader outreach to other young health professionals who, unlike people of my generation who have had to learn about climate change and had to be convinced, they've grown up with this, they've been born into this, and the mobilization around this issue comes very naturally to them. And I'll just point out, again, as a positive offer to the climate negotiations, that the most trusted profession in the world, some people think it's doctors. Doctors, in fact, second place. First place, nurses. So we have, in the health team, we have the most trusted voices on the planet. And if you're somebody who wants to push for climate action, you want a nurse on your television screen telling people they need to act for climate change. And we've got a whole new generation of young health professionals for whom this comes very naturally. So we also, I'll just point out that you may be aware that there's the first ever President's Youth Envoy for COP27. She's a medical doctor. She's from IFMSA. She's an old friend of ours, and I can think of nothing better than having a young female doctor being the voice of youth at COP27. So that's the kind of full spectrum engagement that we're promoting from the health side. Next slide, please. Okay, this is one which is very dear to my heart, just to give some of the stories around the mobilization that we see from the health community, and we do see this from around the world. But I'll just tell this one story as a really good example of that. Last year, in the run-up to COP26, we were contacted by a group of pediatricians from the UK, from Great Ormond Street Hospital, from some of the other famous children's hospitals in the UK, who said, we've organized, as pediatricians, we see children sick all of the time, including from air pollution. And we treat them, and they do a brilliant job. But they're saying, but we've recognized that this is not enough in the face of the climate crisis. So they had decided they were going to cycle from London to Glasgow over a week to deliver a letter signed by organizations representing 46 million health world to ask for stronger action on health and climate change. And when we heard this from WHO, we thought, that's brilliant. Tell you what, we'll do a prologue, and got Tedros to sign the letter, put it in a bag. I cycled it over to London, and they cycled it up to Glasgow. And we followed it up this year. Ride for Their Lives, this campaign has followed it up this year, organising community rides around, particularly between hospitals around 3 continents. And a couple of those doctors in May cycled back from London to deliver that message to the World Health Assembly, to Tedros, to get him to sign it as we kicked off the World Health Assembly. And then in October, they set off from Geneva, aiming to get here. But it's a bit too far and there's no safe land route. They made it to southern Italy, carrying this message in a blue satchel, which is just made its entrance to the COP negotiations. So it had to be couriered over from Napoli to here. And I did the ceremonial cycling from my hotel to COP this morning with the blue satchel, which is our message as health professionals. It's now our delivery mechanism for pretty much all messages that we have. And that's just one example of how health professionals are really motivated now to go above and beyond all of the brilliant things they're doing, even in their day job, say that's not going to be enough if we don't fix the climate crisis, and we will step up and act on that. Next slide, please. So I think coming to the end of my bit, and this is the key health messages that we are taking to COP27. As health professionals and as environmental health professionals, we're completely on board with recycling. So these are very similar to the same messages that we took to COP26. And that is deliberate. We think that there is a merit in having a consistent voice, a consistent set of messages on climate change and health. So we are asking countries to commit, as they continue to recover from COVID, to recognize that COVID was a disaster, but that's nothing compared to the disaster we will have if we don't make the right investment decisions as we recover from COVID. We ask them to make these commitments that we have asked countries to sign up to, and we're getting more countries to sign up to harness the health benefits of climate action, from improved air quality and so on down the list. And as you can see, this is a list which we think should work whether you're taking it to the climate negotiations or whether you're taking it to a health meeting. All of these things are great for health and great for climate, and it's the agenda we think we need in order to meet this common challenge, this overarching challenge of climate change to health. Next slide, please. And this one should need no introduction. You're sitting in it, and as you can see, I mean, the photo's quite nice, but it's even better in the flesh. And so, we, in order to convene that family that we now have on climate change and health, and with the support of the Wellcome Trust, who are providing financial support to the Pavilion, this beautiful space has been created to have a natural space for the health and climate community to come together, to learn about the issue, to have these direct conversations that you may be having in the back or outside, just to make clear that our space is also here at the heart of the climate negotiations. Next slide, please. I think this is the point at which I hand over to Christina from UNCC Learn to talk about work that we're doing jointly to, again, try and equip health professionals to come to make constructive engagement with the COP negotiations, but also to brief the climate change and the COP family as to what they can learn, what they should know about health. So over to you, Christina.
Thank you very much. Good morning also from my side. I'm Cristina Recacavas from the UNCC Learn Secretariat based at UNITAR, the United Nations Institute for Training and Research. And I'm delighted to complement this great presentation delivered by the ARMID by providing an overview of this newly updated course on climate change negotiation and health we jointly developed with WHO. As some of you may know, this course was actually launched last year in preparation for COP26, And this year it has been fully reviewed and updated in preparation for COP27. It has just been launched. This course is free of charge, is self-paced, and can be taken at any time. It is available online in English and takes around 3 to 4 hours to complete in average. It is primarily designed for delegates attending COP and participating in the climate change diplomacy, as well as for professionals involved in the development and implementation of national climate change and health policies. It is, however, very relevant to anyone who is interested in learning more about the promotion of climate change and health, especially in the context of the climate change negotiations. The overall objective of the course, then, is to support all participants in addressing health in the climate change agenda, as well as in considering climate change in the health agenda and in health policies. The course comprises 6 lessons that are self-standing, so can be taken individually and separately. Each one of them has specific activities, exercises, videos, case studies, and a multiplicity of links to additional resources where you can learn more and gather more information. Next slide, please. You can see here an overview of these 6 lessons. So the first lesson provides an introduction to the nexus between climate change and health. It highlights the risks arising, the health risks arising from climate change, the impacts of these risks across multiple communities and groups, and also possible health responses to climate change. The second lesson focuses on the key milestones in climate diplomacy, discussing in particular the structure and the functioning of the UNFCCC, the Climate Change Convention, the Kyoto Protocol, and the Cancun Agreements. The third lesson introduces the objectives and key provisions of the Paris Agreement, as well as the purpose, key characteristics, and reporting mechanism related to the NDCs, the Nationally Determined Contributions. Lesson 4 discusses the outcomes of the most recent COPs, namely COP26 and COP25. Lesson 5 is the one lesson that has been completely overhauled in this new updated version of the course. It explores how climate change and health priorities can be promoted during the climate change negotiations, identifying key entry points, as well as highlighting WHO recommendations and priority for actions here at COP27. And finally, the last module presents the impacts on our health and societies of the COVID-19 pandemics and introduces the WHO Manifesto for a Healthy and Green Recovery from COVID-19, including 6 prescriptions and practical steps that can be taken. So all of this is covered in the course. These lessons, as I mentioned, are available online, but they can also be downloaded as PDF documents for offline learning, or if you want to refer to them while disconnected from the internet. The participants who go through the course and want to test their knowledge have access to a quiz at the end of it, and if they pass, they are successful in passing the question of the quiz, they are automatically awarded a certificate of completion from the United Nations. In addition, I would like to mention that with the launch of the course, we also organized a series of webinars focusing on the COP27 negotiations and entry points for promoting health priorities, but also on the negotiation skills and techniques beyond a specific content. So the recordings of these webinars are available as well on the course webpage. So all these materials, all the resources are available at the website that you can see at the bottom of the slide, unccelearn.org, the UNCC e-learning platform. These are widely available. Please feel free to access them and widely disseminate as you see fit. And thank you very much for your attention. Should you have any questions on the course, don't hesitate to let me know. We are now opening the Q&A for questions about the course, but also for questions about the previous presentation delivered by the ARMID. Thank you. If there are any questions, please feel free to raise your hand.
Thank you. Those are wonderful presentations and resources. Do you think there's any value, or have there been any efforts in bringing in other health professionals? Specifically, I'm a veterinarian and represent the American Association of Veterinary Medical Colleges, the global consortium of veterinary colleges, and we're moving into this area of education and trying to connect the veterinary profession with climate in many different ways. The medical profession is one step or two steps ahead of us. So has there been any, we talk about planetary health and One Health, what types of really intentional efforts are being made, or how can we contribute to the efforts that you're making to provide resources and bring attention to climate and health as a planetary health issue?
Thanks very much. It's a great question, and it's obviously really important to not try and be exclusive or to have hard silos around particular communities engaging on climate change or on climate change and health. And of course, it's one of the unfortunate lessons of the COVID pandemic, which people are starting to learn and to react to, is that whereas we have talked about One Health for a while, we've talked about planetary health for a while, there is an acknowledgement that not only does human health entirely depend on stable environmental systems, water, sanitation, and so on, but that some of the greatest risks that we have come from mismanagement of the natural environment, and that includes risks that come from outbreaks of infectious diseases. And I'm sure you will be aware that there is very good indicative evidence that new emerging diseases tend to come from places where we have strong environmental disruption, rapid land use change, and much of that will come in through the animal route and from the veterinary route. So in theory, we have the collaborations in order to do that, but I would say that they do need strengthening. Still, most of what the health community does is still treatment and trying to deal with these things after they've got out of the box. And yeah, the unfortunate lesson of COVID is that we do need to be better joined up with the sources of these diseases and the drivers of these diseases. So there is increased political support, as you're probably aware, behind One Health and trying to be a bit more serious about it. I would say that we have probably we haven't yet done very much about connecting up with allied professions, but we would be very keen to do so. So we'll be very pleased to follow up that conversation with you around you and the organizations that you represent about how we can build links. And I think it is important, we talk a lot about breaking down silos, and that's true, we do need to break down silos to some extent, but I think we also have to recognize that there is work that veterinarians are best placed to do as veterinarians, and health professionals are best placed to do as health professionals. So it's not just breaking down the silos and everybody sort of hugs and says we're all in this together. It's also about sort of allyship and supporting each other, and to say, we'll be really happy as health professionals to know that veterinarians are doing a really good job and getting the support they need in order to collaborate and have the links, but to do a great job of being veterinarians which are helping to respond to the climate crisis, as well as wherever possible where we have an actual problem that we have to solve together, to work actively together. So it's, I guess, yes, we'd be very keen to continue the conversation, but also just to support each other. Thanks.
Hi, thank you. That was a really educational presentation. I'm Fiona Smith-Layton from GSK Global Health. And my question is a little bit linked to this silos. Where do you think it is helpful and appropriate for the pharmaceutical industry, with its knowledge of doing research and its doctor-rich workforce, to actually step in and support and amplify the efforts around health and climate change?
Okay, yeah, well, I have to say it's fantastic to see that mobilization of across the board, and so there's clearly a massive role for pharmaceutical companies in this space, just as there is a massive role for mobilized nurses or for community health workers in Africa. One way or another, we're all going to have to step up. And to connect it to the previous point, we have to support each other, I think, and that's absolutely across the board. It's not just allied health professions close to our own, but it's climate justice activists, the people arguing for gender and so on. All of us have to support each other. But I think, yeah, we do have to think, well, what can I also do in my day job? Where do I have direct control of what I, in my own sphere of influence? And I think for pharmaceutical companies, I mean, you'll be aware of this, that carbon emissions from healthcare are important, are significant, and the estimates vary a little bit, but we think somewhere around 70% of carbon emissions in healthcare come from the supply chain. And so pharmaceutical companies are a significant part of the supply chain. So it really matters that they're doing whatever they can to drive down their carbon emissions. But I think there is also, we would encourage pharmaceutical companies to work with each other because we want healthy competition amongst pharmaceutical companies to raise environmental standards. And we'd also encourage them to collaborate even with regulatory agencies, because the buyers. So, I mean, you're from the UK, or okay? So, I mean, you all know NHS England has the strongest commitments, doing fantastic stuff, and they are also pushing pharmaceutical companies and all of their suppliers to raise their standards, and that's going to have to be a negotiation. But we think it should be a friendly negotiation where to try and raise standards as much as possible. So that's the really obvious the really obvious entry point. But I'm sure there are others as well. As you say, you have a doctor-rich world. That means you have a large workforce, which is a very trusted workforce, which has a whole series of connections as well. And you're also big industry. I mean, you're a significant part of the 10% of the global economy. So it really matters what you say. And there are quite a lot of countries where healthcare is the biggest growth industry, or one of the bigger growth industries in the economy. So when that kind of sector sends a signal that we're serious about this, then everybody takes it seriously.
Thanks very much. It's kind of a quick observation and then a follow-up question. I think that it's really interesting that with the health sector here, like, if you look at the objectives of the Paris Agreement and achieving climate neutrality, you have all these sectors who need to be kind of dragged by the ear, and here are things you don't really want to do, but you have to do them. Whereas the health sector is the one that turns up and goes, what can we do to help? Which I think is a very interesting dynamic. And touching on that, I think the course you have is a very interesting one, and I think it's really useful for anybody working in the health sector to arrive here and go, how can I add value? And I had two questions on that. First of all, how often does the course run? And second of all, have you thought about having a similar course where health professionals can look at their own domestic situation and where the hooks for, like I said, there's a lot of sectors who need support to get buy-in for measures like transport or whatever it might be, and there are hooks for the health sector, the health argument, to support those things. And is there any thought to maybe running a course that looks at the same issues and applies them in kind of domestic policy contexts where possible? Thank you.
Thank you very much. Just go back to the center for the camera. So the course is available all year long, anytime. So it's a self-paced course. It can be taken anytime, it can be started anytime and concluded anytime. It's available on this e-learning platform that actually hosts 50 different courses on many other climate change related topics. There are 2 courses specifically on health, this one and another more introductory on the connection between health and climate change. But you can also find many other topics. Of course, it's developed in collaboration with various UN agencies. So this is all one UN content. Just to give you an idea, another course on children and climate change is developed in collaboration with UNICEF, a course on climate change and agriculture developed in collaboration with FAO, and so on. All these courses are available there, and health is also mentioned across other courses. And in addition to that, UNCC Learn is a program that has other projects at the national level. We actually work with 30 countries, and in this framework we organize more tailored training, including face-to-face training, where the content that is available at the global level can then be customized. Feel free, as I mentioned, to refer to any of these resources to further promote it across your audiences and network. They're really available as public resources. I hope this answers the question. Are there any other questions? Perfect.
I have questions for both of you. So first off, I'm really interested in the circularity aspect of the green transition. I'm just wondering, is it even possible in the health sector? Because circularity is all about reuse, repair, etc. And there are certainly health implications of reusing things. Also, with fossil fuel complete decarbonization, there are certain implications with you can do surgeries without anesthetics. So yeah, how do you think about those difficulties around achieving net zero? And on the course, how can maybe people here at COP promote the uptake of such trainings? Yeah, what more could be done, I guess, to promote them and make them more visible?
So I can maybe take the first part and then Christina the second. I think it relates a little bit to the previous comment from Colin, that whereas many other sectors do feel they need to, well, it seems like they need to be dragged into this. In many countries, at least, I would say across the health profession, that isn't the case. One of the wonderful things about health professionals is that they have a value system. They're signed up to protect people. They're highly educated, all of them, and they can read a temperature chart, whether that's a patient's temperature chart or a planetary temperature chart. So you don't get many climate skeptics amongst health people. What has been the case up until now is that it's been more sort of passive support, that climate change is terrible, we've got very important, very demanding day jobs, we don't get enough resources, we really hope somebody takes care of this. And that's what's changed in the last couple of years, is that in many cases they're saying, well, this is no good, people aren't taking care of it, well, I guess we're going to have to step up and try and do our bit as well. And the support amongst the health profession to work on this is very high. And so that's been the big defence against anybody who has put any pressure on, for example, NHS England to say, why are you doing this? They will say, well, the public wants us to do it, and they've got the polling data, and our workforce wants to do it. So the questions you're asking about, can it really be done in the health sector? All of those implications you're talking about, reuse and so on. We can't really answer that from Geneva. We don't have the depth of technical expertise. But if you talk to nurses in Great Ormond Street Hospital in England, they've put in place the campaign that's cut glove use in half. You talk to the anaesthetists, they know anaesthetics, they want to help. So they'll look at their anaesthetics and say, actually, we could use this one, not this one, cut. That's actually quite a strong, they have strong greenhouse gas effects. And as soon as you've got that mobilization of the health workforce to think, okay, I want to save the planet, but what do I do with the day job? Then it starts to take care of itself, as long as they're motivated and feel they can actually contribute. And then they also make the connection between what they're doing in their own sphere of influence and contributing to the whole, and we'll talk about it. And as soon as you've got nurses and midwives talking about this issue to the people they talk to, you've got a very long way, I think. So would they tell us that the answer is yes, that these things can be done? Anything about reuse recycling, so on. And these people would never take a decision that puts the patient's health at risk. So they will only make a change if it maintains the same service or improves it. So they're your guarantee of quality. And we trust them, everybody trusts them, so they think it can be done and they're prepared to do it.
Thank you. With regard to the promotion of the courses, well, as I mentioned, these courses are available to anyone, and we do as much as we can to make everyone aware of these courses. We have over 600,000 alumni already who have taken them, and to promote them, we engage, of course, through various communication channels, but also through our partners. Actually, UNCC Learn is a partnership of 36 UN agencies, so we try to broadcast this information through our partner agencies, so that they can reach also other communities. For instance, in this case, the health community, which is not our main community, and also with our partner countries. I mentioned we work with 30 countries, so in advance of COP, we send information about the latest courses, especially the trainings also we organize on climate diplomacy. This one is an example, but we also have other series of trainings. Here at COP, one way we further try to promote the visibility of these resources is this series of climate classrooms you are attending today. This is just one of 22 classes we are having throughout the 2 weeks of COP, covering many topics. We have another one, for instance, this afternoon on climate change communication, something completely different. Next week we have topics ranging from climate change and gender equality to climate change adaptation, early warning systems, and so on. The purpose of these classes are to provide an introduction to these key topics, but then there is always a list of additional resources you can access to learn more. Even for this class, if you go on the Climate Classroom website, you can find the classroom page with a description of the class and a series of additional resources beyond the course that I presented. Feel free to refer to them as well. Great. If there are no other questions?
If there are no other questions, we're in fact bang on time. Thanks very much for your participation and the questions. As you said, all of the materials online. We'll be here all week. Make this your home, and yeah, be happy to see you for the rest of the negotiations. Thank you.
Thank you. Thank you very much.
Good morning, everyone. Good morning, everyone. It's an incredible pleasure to have all of you this morning to our event, Advancing Development of Climate Resilient and Low Carbon Health Systems through ATACHI. ATACHI is the Alliance for Transformative Action on Climate and Health. That's led by WHO. It brings together partners working in the climate health nexus. My name is Mqoli Sispanda, and I work as an advisor on climate change at the Commonwealth Secretariat, and I will be moderating our session this morning. I have an incredible lineup of people that will speak to us about the work that they do that contributes to the aims and the objectives of ATACHI. The Commonwealth and WHO have a memorandum of understanding, and one of the things that we're working together with and a part of is climate change and health. So we are very delighted to be co-hosting this event and bringing ATACHI to talk about partners, ATACHI partners, to talk about the different elements of work that they're doing. Many of you don't need an introduction as to the health impacts of climate change. We all know that climate change brings incredible challenges that impact on the health outcomes of people across the world. And so through this panel, we'll showcase some of the work that's being done and hopefully bring on board more of you to partner with us through ATACHI. To open this event, we have our Senior Director, Dr. Ruth Katumuri, at the Commonwealth Secretariat, from the Commonwealth Secretariat, who will give us some opening remarks. Over to you, Ruth.
Thank you, MX. So my job is to just welcome you all. I think when I'm in the Southern Hemisphere, I can say a warm welcome, being from the Southern Hemisphere myself. So a warm welcome to all of you, and we look forward to this meeting. It's actually lovely to see an almost room full of people here. And so let me start. Let me just go right into some of these numbers, which then really are why we are now thinking of that climate and health should be at the center of everything that we do with respect to mitigating and adapting to the crisis and disasters that we are in. The connection between climate change and the health of humanity is proven and profound. Non-communicable and infectious diseases, malnutrition, threats to mental health, and premature deaths are all increasing as a result of the climate crisis, with vulnerable populations most at risk. Air pollution causes 7 million premature deaths globally each year, and extreme heat kills another 5 million annually. Health systems are responding to the impacts of climate crisis, but all are also responsible for 4 to 5% of total global net emissions, equating to 2.4 gigatons of carbon dioxide equivalent. I'm sure our panelists are aware of these figures, and that's why they're here. Now, when I say this 4 to 5% of total global net emissions, let me put it in context. Everybody thinks that aviation is the worst emitter. But in fact, health systems, supply chains, and the processes by which we require these health systems, this is why health systems contribute more to carbon emissions than the aviation industries. And in addition to that, it's also the fact that each one of us, every single one of our 8 billion population requires some form of health care. And that will only escalate this problem faster. And this is why this discussion is important. I'm not going to waste too much time. I'm not going to talk about IPCC report or the other facts that we already know. let me just say, or the NDC synthesis report, which reveals that 65% of parties identify health as an adaptation priority, or the UNGA resolution, which declares clean, healthy, and sustainable environment a universal human right. But let me refer to a few things. The Commonwealth Charter, which was signed by the Queen, Her Majesty Queen Elizabeth II in 2013 and predates the Sustainable Development Goals, recognized the necessity of access to affordable health care, clean drinking water, sanitation, and emphasizes the importance of promoting health and well-being in combating communicable and non-communicable diseases. And this aligns with the IPCC report. And so what we did was earlier this year, we've been working in partnership. We've developed a partnership with WHO, and I'm really delighted to be co-hosting this event in partnership with ATTACH, and we have a representative from ATTACH here. I don't know if you're part of ATTACH as well, but also we have on our panel our member countries, Canada, UK, NHS England, and Egypt Healthcare, our host. So we're really delighted to be here together. So in the MOU that with WHO, our key priorities are strengthening global health security, promoting universal health coverage, including primary health care, promoting healthy environments, and promoting the health of vulnerable groups. And in Kigali, we launched the Living Land Charter, which is to respond to these multiple crises, which also responds to the multiple crises of climate change, biodiversity, and land degradation, all of which will be exacerbating the climate crisis and health, the interactions between the two in the coming years. And hence, I think with that, I will just stop here, and I really look forward to listening to our panelists and hearing their experiences and perspective from their own institutions. Welcome once again, and thanks to all the panelists.
Thank you very much, Ruth, and for those. Yeah. Sorry. Okay. Apologies, we can't close the door, but I'm sure with the PA system, we will all be able to hear each other this morning. Like I said, we have an exciting panel. Our program this morning would be a number of presentations, and then in addition to that, we will have a panel discussion, and then on the back of that, we will have a couple of questions where we will allow you as the audience to ask our distinguished panelists to answer some interesting questions. So I want to encourage many of you to listen attentively and where possible, be ready to engage at the end of this. To start us off, I'm delighted to welcome Helen. Helen Yaxley is the Climate and Health Policy Lead at the FCDO of the UK, and so she will talk about ATTACH, with whom we co-hosting this, and we actively involved in the work of ATTACH. So over to you, Helen.
Hello. Good morning, everyone, and thank you for inviting me and to be able to talk about ATTACH. Today, I just wanted to recap at COP26 last year. The UK, the WHO, and with our civil society partners, we took health we developed a health program with a view to amplify the voice of health practitioners in the climate change space, and also to demand more research for adaptation and resilience to climate change effects and impacts on health. as well as encouraging countries to make commitments to develop climate resilient as well as low carbon sustainable health systems last year. I'm pleased to say that around 50 countries at COP26 made those commitments, and since then we've been continuing to encourage countries to come on board, and we have now over 60, I think it's 62 countries who've signed up to make those commitments, and many more who are interested in coming on board. But at last year at COP26 we also heard from many of our partners that they wanted a platform where they could engage with each other, where we could collaborate and we could coordinate our efforts to deliver upon those commitments. And so since then, what we have done is work to develop a new alliance for transformative action on climate and health, ATTACH. We hope this global alliance will be able to fulfill that demand that we heard from last year, where we can coordinate our efforts, we can deliver together, we can learn from each other, we can identify best practice and disseminate that amongst ourselves. But also where we can collaborate, we can come together and push collective action on things, on items where no one country itself can make progress alone. And for example, greening the supply chains, where we do need to work together to shift the dial, and where accessing finance we know is a challenge, particularly for low and middle income countries, and where we need to bring together global health funds, development funds and climate finance to work in conjunction with each other to deliver against these objectives, but helping partners and agencies and countries to be able to access that and much more fluidly and easily. So this was the main purpose of ATTACH. We launched ATTACH in June with a high-level meeting, and we hope those high-level meetings will occur every year to continue that political momentum on this agenda, not just against these objectives, but growing the agenda, thinking about co-benefits in the future. But we'll get there. That's where we're starting. We're starting from those commitments right now. We have since also created technical working groups looking at very specific issues underneath this agenda. So what is a climate resilient health system? There is one working group looking at that. Pleased to say it's been chaired by Canada and Côte d'Ivoire. We have a working group also with on low carbon sustainable health systems, and how do we achieve that? What are the toolkits that are out there? What are the baselines that need to be established? We have one on supply chains and looking specifically at that. All of those have met the first time this autumn. And we have one on accessing finance that we're hoping to host almost immediately after COP. And looking at what are the challenges, what are the blockages, what are the barriers, but also what are the opportunities, what are the existing mechanisms that we can use better, and what needs to change. That's what we're hoping for, and how do we bring the different sources of finance together. So that's where we've got to with ATTACH so far. At this event, at this COP27, we've seen various different examples already showcasing progress by different countries, different agencies working in this space. And I think that's what ATTACH can help us do, amplify and really showcase where we're making progress, whilst also helping us to identify what more needs to be done. I'd encourage all countries to sign up to the COP26 objectives and to come and join us in the ATTACH effort, as well as all partner agencies who are interested in this agenda, and to really think about what your contribution could be, because ATTACH is a mechanism that can help us coordinate that effort. Apart from sort of identifying best practice and disseminating that, it can help countries and agencies come together and exploit what mechanisms exist and bring them into a greater collaborative effort. Finally, I just want to say that we want ATTACH to be bold. We want it to grow, we want it to be innovative, and to do that, it really needs everyone's help. We want you to be proactive. We want you to really push us on the two key words in the title, transformation and action. We don't want to leave it just here. We want to go forward boldly. Thank you.
Thank you very much, Helen. That was exciting, and I hope if you're new to this and you've not heard about Atache, there you are with a very, very nice summary. We will now slightly change tact and invite Canada, and Helen did mention Canada chairing one of the working groups, and we are joined virtually by Dr. Peter Berry, who is the Senior Policy Analyst in Canada, and he will speak to us about building climate-resilient health systems in Canada, some progress and lessons so far. So we'll ask the IT team if you could get Peter on the screen. Brilliant. Peter, we'll ask you to say next when you are on your next slide so that we well coordinate it with our IT team. Thank you. Over to you, Peter.
Thank you so much. Can you hear me okay, Max? Can you hear me okay?
Yes, we can hear you well.
Yeah, wonderful. Well, thank you so much. It's a real pleasure to present today to this event. I really appreciate the invitation from the Commonwealth Secretariat and from the World Health Organization. Just on behalf of my director, Carolyn, to teaching the Climate Change and Innovation Bureau, and Deputy Minister Isabella Chan from the Healthy Environment and Consumer Safety Branch of Health Canada. I'm just sending their regrets. They couldn't be at the event, but really wanted to be.
Hi, Peter. If you could get closer to your computer, we barely can hear now.
Oh, it's difficult to hear. Okay, is it better? This?
Yes, that's a lot better.
Okay, that's great. So, I mean, Health Canada has benefited greatly from participation in the attach, including as co-chair of the Climate Resilient Working Group with Côte d'Ivoire. So I'm really pleased to be able to provide some experiences that in Canada in striving to build climate resilient health systems and some of the challenges that we've had. Next slide. And so, one of the things that we've learned is that effective adaptation really requires robust scientific evidence about risks, vulnerabilities, and adaptation options. And so for this reason, a key starting point in Canada has really been to get that evidence. We've conducted 3 national climate change and health assessments, the two recent ones in 2008 and 2014. And just in February, we released our comprehensive climate change and health assessment that looked at some of the common health concerns that many people will be familiar with, air quality impacts from climate change, water, foodborne diseases, natural hazards, but also new areas of focus, including mental health impacts, impacts on health equity, impacts on Indigenous peoples living in Canada, and really importantly, impacts on health systems, which has been really helpful to have that information. Next slide. And so through the assessment, we know that climate change is impacting health systems in Canada, either through acute stresses or through chronic stresses that can really affect health infrastructures, operations, health financing, health care, public health programming, supply chains, and such. And this is just a map of some of the things that we've documented in terms of hospitals and clinics, health facilities in the western part of Canada and British Columbia, from wildfires affecting hospitals. In the eastern part of Canada and Nova Scotia, hurricanes. We've also seen ice storms in southern Ontario and part of Canada, and even in the north, permafrost melt affecting clinics, the infrastructure on clinics. Next slide. And certainly we know that all Canadians are vulnerable to climate change, but certainly some Canadians are really much more impacted, because climate change can really worsen socioeconomic conditions that are harmful to health, such as poverty, and amplify health inequities. So some of these people that are disproportionately affected that we have to think about when strengthening health systems are children, people that are pregnant, First Nations, Inuit, and Métis peoples, people with chronic illnesses, outdoor workers, low-income individuals, and people with disabilities. Next slide. And our experiences are that there can be many challenges to health authorities from local to national levels in Canada in adapting to climate change. So, thinking about monitoring and surveillance of health impacts, identifying the frameworks or the indicators can be a challenge. Even conducting climate change and health vulnerability assessments, we really need to exchange best practices on how to do that. We need the resources and the time as well to undertake these assessments. And certainly with building climate resilient health systems, there's some challenges around communicating health risks that people will be familiar with, collaborating with partners outside of the health sector, taking whole health system approaches, and even mental health impacts on people working within the health system from climate change. And then certainly planning for the future, planning for climate surprises can also be a challenge in terms of building that climate resilient health system moving forward. And next slide, please. And so, federal health agencies are working together in Canada, Health Canada, the Public Health Agency of Canada, Canadian Institutes for Health Research, and others to really address some of these challenges. And so, we're doing this by supporting and investing in research, surveillance, and monitoring, to address key knowledge gaps and things like Lyme disease, for example, that's coming north into Canada, leading national and regional risk assessments on health and health systems, developing guidance for undertaking assessments. We've developed a workbook for health authorities to use when they do assessments, but also supporting the development of targeted adaptation measures like heat alert and response systems for, really key issues that need to be addressed, and empowering Canadians and health professionals with information and tools to protect themselves and their patients from climate change. Next slide. And so this is just one example of a program that Health Canada led, the Health Adapt Capacity Building Initiative. It was a multi-year program introduced in 2019 that supported 10 projects from local, regional, and provincial territory levels across Canada to do their own assessments, get their own tailored information on climate change and health. And it really had a diversity of projects, including Indigenous peoples, newcomers to Canada, urban, rural, and coastal communities, and the whole health sector spectrum. And it's, one of the strengths, I think, of the project was because of the diversity, there's a lot of different learnings that, various kinds of health authorities can use to address some of these challenges that they're facing in terms of building climate resilient health systems. And next slide. I'm really excited that Canada is developing its first national adaptation strategy, and a key pillar in that strategy is human health and well-being. And so through broad consultation, the transformational goal around health is really focusing on transformational change to Canada's health sector to one that's just, equitable, decarbonized, innovative, and adaptive. And so this is going to be released in the coming months. And it's really important that efforts to protect people and really build climate resilient health systems are most effective when there's equitable participation and the inclusion of diverse voices in those processes. So, residents and community-based organizations, for example, have really important knowledge of assets and resources available to their community, local and traditional knowledge, past health interventions and campaigns, that have successes and challenges, and even networks to help with the communication and outreach on assessment results. And there's a number of tools that health authorities in Canada can use and are currently using to really engage broadly and make sure that all of these voices are heard moving forward. And certainly, Canada continues to benefit from international collaboration. So, strong collaboration really supports these shared ambition and targets in terms of rapidly scaling up health adaptation, which we need to do, shared learnings and experiences which can address these challenges, and shared communities of practice and, development of these peer networks. And so, many health authorities in Canada have really benefited greatly from the excellent guidance from the World Health Organization and Pan American Health Organization on how to conduct climate change and health assessments, how to measure climate resiliency. Certainly the Climate Health Portal that was recently launched is going to be a great repository of information for these health authorities moving forward. And even the Global Consortium on Climate and Health Education is providing some really helpful training materials for health authorities to really understand what some of the risks are and some of the processes are moving forward. So, looking forward, we're really excited to be part of the Attach initiative and to continuing to work with our partners, other countries, in terms of building these resilient systems, which is what we really need to do. Thank you so much.
Thank you very much, Peter. And we had a few challenges with the presentation, but I think you were loud and clear. My next presentation will come from Uni Krishnan Nai, who is the head of climate change at the Commonwealth Secretariat. And he will talk about the Commonwealth Climate Finance Access Hub, financing for a climate resilient health sector.
Thank you. If I can have the presentation. I think we need to adapt here actually. Looking at the, yeah. Good morning all, and thank you very much for the organizers for providing this platform to talk about the Commonwealth Climate Finance Access Hub. I'd like to put it straight from the beginning that this is an initiative that's working in countries to access finance to multiple sectors. So we do face the pains and the gains of the whole process of access to finance. And I'd definitely like to place our gratitude and thanks to FCDO for the great support that FCDO is providing for this initiative from the last 5 years. And the next slide, please. So the Commonwealth Climate Finance Access Hub is a mandate provided to the Secretariat by the heads of states in 2015 at the Commonwealth Heads of the Government meeting in Malta. From there, we started the journey of supporting member countries with access to finance. And we have progressed till now with substantial and transformative impact, projects of substantial and transformative impact at the country level. Next slide, please. So the Climate Finance Access Hub works in a hub and spokes model where we have the hub located in Mauritius, and the spokes are in different countries in the 3 regions, especially the Indo-Pacific, the Caribbean, and the African region. So, and it's supported by regional advisors who sit in regional organizations like the International Solar Alliance, the African Union, etc. And then we have advisors sitting in the countries supporting the governments. They work and sit with the ministries in developing project proposals and submitting it in line with the requirements of the multilateral funds. So it's completely a country demand-driven process, and it's a fair and multilateral approach for climate providing climate finance to the member countries. Over this last 6 years, we have supported 17 member countries in access to finance. Next, please. So what do we do in the countries? So we have 5 pillars of support that we provide, which include a concrete adaptation and mitigation project development, the development, the climate policy support, climate finance readiness. I think that's an important aspect, especially when it comes to health, since we don't have a project, especially in from the bigger funds like GCF from the health sector. More of readiness financing is important, and we did support many of our member countries in the readiness aspect. And human and institutional capacity development definitely is an important aspect to take this process of project development and mainstreaming forward. And definitely the hub and spokes model, as Helen indicated, the need for more of replication of ideas, amplification of the thoughts, we do through the information, knowledge management and learning process. Next, please. So where have we achieved? Like we have so far supported 16 countries with project development, and we have accessed climate finance to the tune of 53.6 million. And we do have a very robust pipeline of around 800 million that we are working with the member countries in terms of accessing and supporting the countries. Next, please. Yeah, so just would like to highlight some of the projects. If you don't mind, I just would like to stand up and talk here so that I can see the screen. So, so these are some of the forward-looking projects that we have supported. I've just taken some examples. in terms of how we work with the Mauritian government in building readiness for climate resilient health systems, especially in terms of setting up the standards within the ministries in terms of how to deal with to capturing the data when it comes to health related fluxes, etc., linked to climate change. We also worked with the government of Tonga in strengthening the adaptation planning, and also we also worked to enhance the civil society organizations' capacities and also disabled people organizations. It's a very unique project that we did in Tonga, and the climate finance advisor who did that particular project is right now present here. Towards a comprehensive national adaptation planning process in Jamaica is something which we did for the government of Jamaica, where the readiness ideas were worked out, and also the national adaptation planning process kicked off from there, and health was an important aspect there. And developing key legislations, regulations, policies and concept note for climate action in Namibia was also something which had elements of health that we highlighted in the project. Next, please. So one more case that I would like to bring here in terms of how we work with the government of Eswatini in doing the climate public expenditure and institutional review process with the support of the NDC partnership. So here health was an important aspect that was analyzed, and we also found that there's lack of data and also lack of information correlating the climate change and the impact on health, and of course that's one of the impediments that leads to less and less projects. And I was in the WHO FCDO meeting last day when this point was discussed, and even GCF the director was highlighting the need for more evidences to move forward and to develop more tools and techniques. So in that line, we did the climate public expenditure and institutional review for Eswatini. Next, please. So in that process, we did find out very clear direct threats of climate change on human health. Includes morbidity and mortality, vector-borne diseases, diarrhea and malnutrition, all linked to climate change. And also outbreaks of vector-borne diseases, and especially the malaria, dengue, etc., and also coinciding with the occurrence of extreme events, we could do the correlation very clearly. So I think the evidences are there in the ground. We need to bring that out for the countries and develop clear baselines that enables member countries to develop projects. And so we are supporting in that process. Next, please. So the other work that we did for the government of Jamaica is to do a socio-economic and financial implication assessment of climate change in Jamaica. So if you look at that, the health sector is vulnerable to the climate-induced events, and this assessment very clearly captured what was the impact of the last couple of hurricanes on the health infrastructure. So for example, there was a big typhoid outbreak after Hurricane Gilbert in 1988, and this was associated with the damage to a treatment plant that led to more of drainage waste going into the water bodies actually. So potentially these kind of clinching evidences is what we need basically to go into the process of project development and then access to finance for the countries. Next, please. So similarly, we also started off the process of climate finance landscape assessment for Belize. We also did a climate finance mapping for Zambia. So this is all evolving in the same direction in terms of generating more evidences and enhancing the preparedness to deal with and to help support the project development process. Next, please. So capacity building and training support is one of our major tools, and in that we have already supported and have delivered around 103 capacity building programs covering around 2,200 beneficiaries in the government. So please note that this is not just a one-off capacity building training that we provide to the countries. This follows a very clear approach of right shops. So next slide, please. So what do you mean by right shop? So this is where the government officials are made to sit down and write the proposals with the experts. So they sit down and and get familiarized with the processes, try to develop the justification, and they also understand the pain of the process of writing, accessing, and moving the project from concept to the proposal to implementation. Next, please. Based on our experiences over the last 6 years, we did compile practical experiences from the Climate Finance Access Hub as a toolkit to enhance access to climate finance. So this is publicly available. Next, please. So this has been uploaded in the UNFCCC website in the resource page, and also the toolkit to enhance access to climate finance is currently in the NDC partnership website, the Africa NDC Hub website, etc. So this is this is slightly different from all the toolkits that provide you with the evidences for making projects and proposals. This is based on practical work experience of my colleagues who have done this work in the countries, and basically the processes and the hurdles that they have faced in taking the project development process forward. So this is definitely something which I will recommend the stakeholders to have a look and see how this could be of use for developing projects in your own respective realms. Next, please. So before I conclude, I think health sector and climate change adaptation and mitigation, I think the low carbon health sector and climate resilient health infrastructure is definitely an important area in most of the national adaptation plans right now. So definitely there is a need for more evidences and need for more correlative articles to be made available for countries to substantiate their statement. It's real, but when it comes to a deployment of scarce financial resources, we need evidences, and that need to be translated into justifications. I think that's one space as Commonwealth Climate Finance Access Hub we are committed, and we are very happy to be associated with the working group of ATTACH, and definitely take this knowledge back as an evidences back for the mainstreaming process, the policy making process, as well as for countries. Because as our Secretary General always used to tell, the hub and spokes model and its uniqueness is basically if it is done in one country, that is applicable to the 56 member countries and beyond of the Commonwealth actually. So I'll stop here and thank you very much.
Thank you very much, Oni. I do recognize that our time is gone, but we have time for our next two speakers. Dr. Nick Watts is the Chief Sustainability Officer for NHS England, and he's been leading the work on delivering a sustainable supply chain within the NHS England. So he will talk a little bit about the experience of NHS in that scope.
And you want me to, oh dear, you want me to be short? How are we for time? Five minutes, okay. So look, hello everyone. A very, very dangerous thing to give me a microphone with speakers this loud, so I apologize, mostly to the audio-visual people in the back. I'll be quick. I'll talk about supply chain. For the NHS, we very, very roughly break up our emissions into, everyone here is familiar with the greenhouse gas protocol scopes, scope 1, 2, and 3. Scope 3 for us is 62% of our emissions profile. We sometimes make the mistake of conflating that and saying that means that 62% of that emissions profile is in our supply chain. And whilst that is technically where the emissions originate from, it has the negative effect of making it seem as though only our suppliers can act on them. Not true. It is our asthma nurses that decide what they prescribe. It is our catering staff that decide what food we provide for our patients. It is our occupational therapists, our physiotherapists, that decide how they send a patient with a new knee or a new hip home, and what sort of mobility aids they get. So the very, very first thing I would want to say, one of the things we've learned on our supply chain journey is it's absolutely critical that first we look at what the NHS, what healthcare systems themselves can do, because actually when it comes to that 62%, we are not only reliant on suppliers to engage there. In fact, they're reliant on us. We are reliant on each other working on this together. So the demand side of procurement, the demand side of the supply chain reduction matters immensely. Second, scope matters immensely. It's very, very important that when we talk about this, we are very clear, and for the NHS we are clear, where we are drawing our boundaries, and we have to draw them as broad as you possibly can. Quite frankly, unless you are talking, I think, about scopes 1, 2, and 3, and unless you are talking about an emissions profile that is both national and international, you are in the wrong decade. Anything less than that would be the NHS being disingenuous. If we only talked about our UK source emissions, it would be us talking about something around 32% of our emissions profile. If we only talked about the emissions that occur on site, it would be us talking about only 27% of our emissions profile. That would be disingenuous. So scope matters immensely, and ambition matters immensely. That long-term signal, I think, is something, and a bit of stability attached to that long-term signal is something that we found. Closer, really? Oh dear. Okay. I've never ever been asked to speak louder. The long-term signal matters as well. And so for the NHS, we have been very, very clear. We have our own net zero targets for our full total global footprint, 2045. What we've said attached to that is within the decade, the NHS will no longer purchase from anyone that does not meet or exceed our commitments on net zero. That's a very, very vague sentence. Vague sentences are dangerous. So we've been far more specific. 1 minute past midnight, April 1st, 2027, the NHS is introducing new qualifying criteria for all of our 82,000 suppliers. If you want to enter into a financial agreement with the NHS, then we want to know that you are the kind of company that we want to do business with. We want to know that we are aligned on the direction that we're heading, and if we're not, we are certain you have a competitor that is aligned with us. That has been important. The long-term trajectory here is important, but then it is important as well. 2027 is a long, long way into the future, too far away. So starting today matters as well. And so last April just passed, we introduced 10% weighting into all of the tenders out across the NHS for net zero, for social value, for climate change. Going forward, you will see us in 6 months introducing new qualifying criteria for all of our contracts over £5 million a year. What you get the sense of is a system that has a long-term roadmap and a long-term trajectory, but it's starting today. It's starting with small, easy steps that begin that conversation, force a conversation, frankly, between our 12,000 procurement officers and our 82,000 suppliers. What does this stuff look like? What does it mean to deliver that particular contract in a lower carbon way? You start with that stuff and then you get progressively more serious as you go. So the demand side matters, the scope matters, the long-term trajectory and the ambition, it matters immensely. The data matters, but quite frankly, it doesn't matter as much as people think. Anytime anyone in this space tells you I would make a scope 3 commitment, but it's really quite complex, they're lying to you. It was complex. It was complex back in the 1990s. It's not that complex anymore. Countries around the world, governments around the world, private sector companies around the world have figured this out. The healthcare system is just slow. We have just been sitting on our hands for a little too long, and so in particular, sure, we may need another 6 months to figure it out, but it is not that complex. And quite frankly, data evidence in no way whatsoever is an impediment to action today. It certainly was. It certainly was a little while ago, but you see inherent in the NHS's strategy where we know we don't have life cycle assessments for every single individual product. We're not going to wait for that nonsense. We're going to blow past that and focus initially at the organizational level, and then come 2028, start to insist on the life cycle, the product level decarbonisation. Because if you wanted to wait, well, you could, but you'd be waiting for 6 or 7 years. So the demand side matters, the scope matters, the ambition matters. Starting today and not letting some of these boring arguments of, oh, we would, but it's complex, oh, we would, but the data is nonsense. The final thing that matters is that you don't do it alone. The NHS is big. 1.4 million healthcare professionals, 5th largest organization in the entire world, largest healthcare workforce in the world, £155 billion of spend. And so you can see, if we're taking this quite seriously, that's not insignificant, the economic might of the NHS, but it's not everything. In fact, if the NHS is the only country running at this, we will fail. This only works because there are other countries running at this. This only works because the United States just yesterday stood up and said, yes, we're excited, we're interested, we want to run faster. Because Scotland has stood up and said they think they can decarbonise their healthcare system faster than the NHS in England, and we say, bring it on. It's very, very important that as we go forward with our friends, with, yes, other healthcare systems, with friendly companies, private sector. There have been a flood of pharmaceutical companies, med tech companies that have been engaging, have quite genuinely been trying to say, well, this looks tough, but how can we start this? How can we do some of this together? If we get those 5 things right, and we remember that this is urgent, and we remember that we, frankly, the NHS, frankly, has been sitting on its hands for the last 3 decades, so you don't have time to say, well, I would give me a year to come back to you with a plan, give me a year to come back to you with more data, then I think we start to make some real exciting progress.
Thanks, Nick. That was brilliant, and as you can see, I think well received here. I'll go to our next speaker, Dr. Gadak Shaki, who will speak about Egypt's experience in greening their supply chains.
Well, thank you, and thank you for this opportunity. I'm so proud to be here, and I'm more proud because I'm part of the attached group, especially in supply chain. I'm gonna make it short as possible as I could. I work for Egypt Healthcare Authority. Egypt Healthcare Authority is part of the new universal health insurance system that is currently implemented in Egypt. Egypt EHA is responsible for healthcare service provisions. So we started in 2018, and we're continuing till 2030. I'll start talking about supply chains, but I actually changed the scope a little. Yeah, I broke the long supply chain because I know supply chains are a little complicated and they are money absorbing. So I focus on the process itself, and I divided the process into the areas that we can work on. The first area for me was manufacturing, and actually, like the earlier group, it's not something on the country level. It's something that needs unified standards, and so that we can apply that to suppliers. I can't work in it alone, like you just said. The second part is procurement, and I'm proud to say that in 2020 the country issued the law on unified procurement, and we had an authority doing this currently. We have centralized procurement and distribution. The distribution is directly from the authority to the facilities, so the transportation thing is a little decreased. The third part is inventory. The demands, we make it based on semi-annual needs. So most of the products, we're trying to decrease the transportation actions, and it's done through electronic systems. So I think it's a good step. The third, using the 2 points before, procurement and the inventory, this actually helps in decreasing the transportation using and distribution. We narrow the scope. It's directly from the procurement authority to the facilities. So previously we had warehouses everywhere, and it's from I buy and then I send to a regional warehouse, and the regional warehouse and to another warehouse. It was a very long process. I'm also proud to say that we are going through our digital transformation. So it means less paper, less ink, less electricity, less everything. We've also here started in Sharm el-Sheikh Hospital solar panels, so it's going to help in decreasing the use of electricity. And eventually, I hope that one day we could, make the whole process complete, and we can decrease the carbon footprint for our supply chain. Thank you.
Brilliant. It's good to hear that, Gada. Now, I have to take a decision here. Instead of having a panel discussion, what I want to do is to have a discussion with the audience. because we don't have much time. So I want to give opportunity to the audience straight on to ask your questions, and we get that. So I've got 3 questions, 1, 2, 3 there. If you could pass on the...
Now, I want to thank the panel and the panelists for making the really compelling case for clean energy in healthcare. I'm Dan Kamen, a professor at the University of California, Berkeley, and the senior advisor at USAID for Energy and Innovation. And one program that some of the panelists I see know about, but I thought I would highlight, which meets your sort of challenge to do it now, do it with technologies we know, and improve the clean energy health process. And that's something called the HFE effort, the Health Facility Electrification Program, which now has a significant amount of backing from private companies. And the goal is ultimately to provide clean energy to all 100,000 health clinics and hospitals across Africa that we think don't have reliable or any electricity today. And the goal is to work with private sector partners that are deployment agents that will be paid back on the capital cost and the O&M based on clean energy services delivered to hospitals. We have a pilot program right now in eastern Congo based around Goma, where over 200 clinics and hospitals, we have real-time monitoring of the power quality, the quality of energy going into the radiology suites, the operating facilities, the cold chain for freezers and refrigerators, that we pay out based on the duration of verified quality electricity, again, all those services. And it's an area where everything from the GVAX efforts to some of the national healthcare facilities to some big foundations or partners. So I just wanted to highlight an example. Anyone who wants, feel free to catch me afterwards. But I feel like it really fits into your statement. Let's get on with the bloody job. We have the technology. Clean energy is now cheaper than fossil, even in these locations. And there's really no excuse not to try to deploy the $1 billion or $2 billion that we think are available from our partners now. The more partners, the better. Congo is obviously on many countries' agenda right now, but there's many others where this is critical today. So again, Dan Kamen, USAID, UC Berkeley, but thank you for what you've done.
Thank you, Dan. That's excellent.
So I would like to thank the panelists for the job well done. I'm Didas Namanya from Republic of Uganda. I would like to say that in the Ministry of Uganda was one of the signatories to the commitments in COP26 in Glasgow. And in those commitments, we committed to do a vulnerability and adaptation assessment and go on to develop a health national adaptation plan. So I'd like to tap on your support to do these activities so that we can build a resilient health system in Uganda. The access to financing is very critical for us, definitely. The experiences from other countries, many countries, which we have seen that we have supported, is very critical for us as we walk this talk so that we build a resilient health system in Uganda. So I look towards touching base with you and seeing how we can share this information and how we can work together. I thank you.
Wonderful, wonderful. So please, let's maximize on this opportunity to meet and connect different ones. Yes, ma'am.
Thank you. I've got 2 calls to action, but a quick preamble. First of all, you made my day yesterday when I saw that declaration between the UK and the US. That's the best news we've heard in the health sector for a very long time, and I'm sure the ripple effects of that could be massive. So thank you for whatever you did behind the scenes. The context with which I'm speaking is that having sort of figured out how to make carbon footprinting simple and working in partnership with WHO, we've now been providing orientation and tools to over 40 countries. We are also talking up standardizing KPIs on the supply chain. And with our own operations, and our target is 2030 for 1 and 2, we've got 25 targets for the supply chain, and it's 90% of our spend would be with companies declaring scopes 1 and 2, and 75 with their net zero plans. We might realign once we know your detail, because we want to not only align our own KPIs, but we want to promote in our teaching with governments what they might adopt so that we make life sensible for companies. So my 2 calls to action. One is, when our own supply chain, incidentally, we've figured out 30% of our spend is currently with companies that have their scopes 1 and 2. But that's just a beginning. But to get that data, we had to figure it out ourselves, and you know the methodology. So call number 1, can we have a database where we annually update the data that companies are sharing, so that we make it easier for our beneficiaries and others who are getting started, because that's not simple. The second call to action, I've been trying to think about something that we can all do and be part of doing before the next COP, because there's been just an inestimable amount of nauseating blah blah. Yesterday, I think everyone I spoke to was at a sort of tipping point in terms of anger and fatigue. Can we support countries, at least those that have made a commitment, to adopt the same KPIs for their supply chain? And can we try and have a reporting mechanism so that by the next COP, countries are coming forward to say they've already institutionalized the same approach? Thank you.
Wonderful challenges to a panel very soon to make a comment on that. I should take the last question, comment.
Sorry, it might look like a naive question. Do other sectors measure their supply chain? And are there cross-cuttings between the different sectors? Because you don't expect, if you think of a private sector, if I'm providing goods to the health sector or to the water sector, how to synchronize it? Should we at one stage synchronize the supply chain measurement in the health sector with other supply chains, carbon footprint of other sectors? You mentioned that now we are producing more greenhouse gas emissions than the aviation. Does the aviation include the supply chain of their products, including that, so as to compare apples to apples rather than... But I hope my question was clear.
A very, very important question. Will we take questions before we come back to the panel?
Thanks very much, everyone. I'm Colin from Ireland, and I thought that was a really interesting panel discussion. I think the attach principle is a really strong one, and I think being able to take examples of what works and replicate them, take the best-in-class examples and see how you can apply them in other sectors is a really strong idea. I had a question for Una Krishnan in terms of your experience of engaging with a number of different countries and the types of projects and regions that you showed in your presentation. Was there anything in particular that stood out in your experience that you could take and say, this worked really well here, we applied it again here, the principle of it, and it worked really here as well, and it might be a takeaway for those of us who are going back and looking to learn from what Attach can bring? Thank you.
Okay. Right. You had your hand up. Do you want to ask the question, and then we will go to our panel?
Thank you. My name is Cecilia Magnosa. I'm from the University of Exeter in the UK, and I work in the area of continuing professional development, so I work with health professionals. And we know that the climate crisis is linked to a health crisis, so we can't have a healthy planet without healthy environments. So my question to the panel is protecting and restoring natural systems part of your carbon mitigation strategy? Thank you.
Excellent questions. I want to give our panelists an opportunity to, this would be, you can respond to any question and make your closing remarks because of time. Peter, online, if you could just, I'll start with you.
Okay. I can pick any question to answer. Okay. I can talk about two things. The first part is Uganda, I think. It's here. What? Okay. The sound's good right now? Okay. I think Uganda, right, who talked about finance. We have the same problem. We were searching for funds, and the problem is most of the funds are directed to climate change, and there's nothing related to health and climate. It was actually a problem, and we had to do all the transformations by ourselves. So yes, this is a problem, and I don't know if it's available to be fixed, and there could be funds oriented to health, like the major part of the fund, you know. The second part is about okay. Of course, I think we consider the idea of environment because it fires back at us. We have problems of floods and heat strikes here in Egypt, happens sometimes, and we should consider the problem, and we're actually working on it. The WHO was on 1st of October, they came with us here, and we made a vulnerability and adaptation assessment, and we're working on it here in Egypt. So yes, it should be put in consideration because it's a big part of the climate change crisis. We're doing it. Thank you.
Am I audible? Yeah, I'll specifically a question that the gentleman asked about the experiences from the project that, you know, experiences from the project in terms of what are the learnings that you can take back. So I think there are many learnings which, as I gave in my presentation, the toolkit which is available in the UNFCCC website is something which you can refer back. But the one aspect when it comes to supply chains, so the couple of examples that I could give. So look at the paper manufacturing industry. If you look at the procurement standards within the paper manufacturing industry, which are following the Forestry Wardship Council standards, so there are multiple standards there. There's control board or community procurement. So the standards that are being followed, particularly when it comes to the farmer level or the community level, when a project is being developed which is linked to the supply chain, there is always a incremental value question that comes when it comes to the producers actually. And yesterday also we were discussing with the afforestation projects or the plantation projects that are supplying sustainable wood to these industries which actually cater to the supply chain. You know, the most important question that we consider there is what is the financial instrument that you have to adopt, or what is the financing mechanism that you have to adopt. If you falter there, the project will not take off. So it's important to see that what is the beneficiary level that you are operating, whether it's retailers, whether it's farmers, or is it big manufacturers. But when you deal with member countries, especially with the funds like Adaptation Fund, GCF, etc., the projects are mostly with communities. So of course we need more of cushioning mechanisms like first loss guarantee facilities or seed financing or bridge financing basically to facilitate the process actually. So this is one experience, and I definitely would recommend if you could go back to the toolkit to see more examples. Thank you.
Peter, are you still online? I wanted you to answer the question around the assessments, because you described quite a bit about the experience in Canada around doing around the health adapt work. So if you could probably put in a word or two on that, and what countries can do to really push that forward.
Sure, yeah, no, thank you. Thanks for all the questions. They were really great. Certainly on the assessments, one of the things that we've learned is, part of the most difficult challenge is getting started, getting the data and getting the partners and developing the work plan. And so some of the existing guidance that is available, and actually that the World Health Organization has sort of updated it periodically, is very, very helpful. But people need to be sort of sort of trained on how to go through the process. So this is really important. And one of the things that as part of the attached working group on climate resilient health systems, we'll be looking at how can one sort of inventory some of that guidance that's out there and really make it most available to people to really support these kinds of projects. So that's been our experience within certainly within Canada and working with other partners moving forward. So yes.
Thank you, Peter. Nick, one question for you that I'd like you to answer, and this is around the standardization within the supply chain of the food printing, and if you've got any comments as well on aspects to do with nature and integrating all that into the health sector.
So yes, other sectors absolutely have standards that they apply to their supply chain. Other sectors absolutely consider their Scope 3 emissions. They are slightly more sophisticated than us, that they have ways of avoiding double counting, but we are so far away from that. The methods that Fawzia was talking to are so rudimentary because they're effectively just taking a snapshot proxy against spend data from what you know about what the world used to be 5 years ago and assuming a linear path forward. We're so far away from that in the healthcare sector that I think we probably need, before we get to the point of standardizing that, we need to frankly go away, do a lot of the really quite hard work of these product by product life cycle assessments. Every single drug in the British National Formulary, every single clinical device, cochlear implant, needs to be properly assessed. It needs to be independently assessed. Let's be serious about the fact that that is actually a very, very challenging task. It is not a task that the NHS is well suited to do. It is not a task that any one healthcare system is suited to do. Frankly, it's a task that medicine does as a whole, right? And it needs to happen over the course of the next 5, 6, 10 years. But because of the momentous nature of that task, we simply can't afford to wait for that. And so we have to start down a different track, quite frankly, today. My favorite part about working in the NHS is just how angry and passionate and inspired our nurses and our pharmacists and our physiotherapists and our doctors are. Everywhere we look, we find examples of individual clinicians always, could it be different? Could I do something just a slightly different way that would be better for my patients, that would be better for the environment? A lot of what we do when we do tackle nature directly, quite frankly, comes from them. So let me tell you about one or two examples that have been scattered out across the country. There's a guy called Frank. He's a physiotherapist up in Manchester, and he realized that he could do a much, much better job of rehabbing his patients from stroke if he had access to the natural environment to do that. You have unstable surfaces. That's really important as you are learning to retrain some of the motor neurons that need to be retrained there. So he went and created an enormous garden out across Manchester Foundation Hospital and started to rewild a lot of that. And that's where he runs, that's where the hospitals there run a lot of their stroke rehab now. It's a really cool example. He said you're from Exeter down there. There's a whole chain of hospitals now, initially led by the Royal Cornwall Trust, that have beehives along their clinics and along each of their hospitals on the roofs there. And they have this sort of superhighway that bees sort of come back and forth, and they've managed to chain up enough NHS hospitals, because quite frankly, we are everywhere, to properly sustain a bit of an ecosystem. That's really cool. The final thing I think I am excited about is down in Sussex. There's a set of hospitals there that have got really concerned about the impact they were having, their plastic waste was having, especially during the pandemic, on the natural environment around them. And so in response to this, and I don't actually know the full detail of whether or not this is a brilliant idea, but I love the sound of it. They've taken all of that waste, they found a way to clinically, they're not incinerating it, they're disposing of it at a far lower temperature, they're melting down the plastic from the PPE, they're separating out the biohazardous waste, and then they are reprinting that into office supplies that the hospital uses, into trash pickers that the local school uses, into playground equipment there. So we've got examples like that scattered across the entire country. That usually, when we are engaging properly in sort of the nature side of the response to climate change, that's where a lot of that comes from.
So, Helen, I have left you to respond last because I wanted you to address, there have been a number of calls here on what needs to happen next, and just in a nutshell, how we position Atachi to try and push forward on all of those things.
There are a lot of things, so but I think Attach, well, we want to position it as a community that's emboldened to make the health arguments for climate action and also develop really strong cases, investment cases for why we need to do this, so that countries can engage, or health sector can engage with the other sectors in its own country to make the case, to get its finance, to make the case to international financing mechanisms, and to make help the money flow. That's a big thing I've heard around this room around the financing. Part of that starts domestically, and then we go internationally. Through Attach, we can get the message out to the international actors, and we can work collaboratively with the other sectors to do this. We also need to think about how we engage not just environment ministries, but we need to engage the finance and planning ministries, and we need to be astute in how we do that. And we need to work with sectors on water, on food, on others, the upstream determinants of health, so that we're actually doing this together. And I think that's what Attach can help us achieve. I think Attach can also needs to really get out there and share those lessons, because there are lots, and we can come together. And like others have called for here, standardize approaches, share those lessons, really get out there and be active. So that's what I'd like to see Attach do, really create that community that's really alive and really driving that agenda ahead.
That's wonderful. Just want to say thank you to our panel of speakers. Thank you to Barry, who joined us virtually. I'd like to ask you to give a round of applause to all of them for a job well done. Just before we go, Ruth, did you want to say one or two things?
So firstly, once again, thanks to all the panel. And as Nick was saying, the evidence is there. He was talking about data. The evidence is there. And where have we seen the evidence? We've seen wildfires in Canada. We've seen wildfires in Australia. And the worst thing about all these things is also the mental health consequences it creates. I've been in Bahamas, where I've heard about young people having severely being mentally affected because of our climate crisis, that they're having to face hurricanes every year. So there's a whole range of experiences, physical and health systems, but also mental health issues. And Pakistan, we are seeing right now, with a third of the population being submerged, vector-borne diseases, that directly relates to health and climate change. So I think we heard about digital health from GADA. So at the Commonwealth Secretariat, the good thing is that my directorate, I'm responsible for climate change, health, finance minister. So I'm convening all these together. So it's an opportunity, as we have been hearing today, about interconnecting and working together. And we heard about the finances. Unni explained some things about Mauritius, for example, the amount of funds we've helped to the country get is about 300,000. And then there's another readiness project with St. Lucia, which is about 10 million, I think, in terms of real amounts. Uganda, we heard the question about Uganda. We are looking to work with Uganda, so we are looking for funds to work with you, and I believe we will get that. Lastly, I just want to say, Together for Implementation is the title of this COP, and we have no choice but to work together. As well as today is the day 2 of the youth day at COP27. And 60% of the Commonwealth's 2.5 billion is under the age of 30. And hence, young people are at the center of all that we do. So thank you all, and thanks for your questions and interventions. And glad you sat through this whole event. Thank you, moderator.
Thank you very much. We'll request you to please make your way out. There's another session that's coming through, and we've just overrun. Thank you very much.
professor at Allergy and Clinical Immunology, Transylvania University, Brașov, Romania. And she's the chair of the European Academy of Allergy and Clinical Immunology Research and Outreach Committee. So she will give an introduction about the Academy and One Health. Please, Joanna.
Good morning, ladies and gentlemen, and welcome to the EACI session, organized with the occasion of the COP27 Health Pavilion. I'm Ioana Gace, I'm the EACI Research and Outreach Committee Chair, and I will present you our organization and its initiatives in the field of One Health. Now, this is the EACI vision for the management of allergy and asthma. So we are based on 4 pillars, looking at connecting science with the transformation of care. Of course, meeting the changing needs of all our stakeholders, grow in a sustainable way, but most importantly, prioritizing some research directions. And here you can see that 2 of the most important directions for our academia are the developmental exposome, because allergies start early and they are early indicators of change in the immune system that predisposes to all chronic diseases after that, and this is highly impacted by environmental health. And this is why we are looking at allergic diseases and asthma in the context of population and environmental health. These are our challenges and unmet needs that we identified at our strategic forum a few years ago. And we are currently focusing on lobbying for a better European legislation on environmental control, looking at issues like air quality, smoking, indoor and outdoor pollution, invasive allergenic plants, and occupational exposure. Now, we know that allergy and asthma are typically One Health diseases because they are driven by a myriad of factors which are all relevant to the One Health concept. For example, the environmental stress, pollution, both indoor and outdoor, climate change, global warming, lifestyle changes, hygiene status, food processing, and especially loss of biodiversity and microbiome, and loss of contact with greenest soil and nature. Where are we with the allergic diseases? They are rapidly increasing in the last few decades, now affecting 1 billion individuals in the world, with atopic dermatitis and asthma being the most prevalent chronic diseases of childhood, with climate change and global warming increasing the incidence and severity of allergy, asthma, and all other chronic diseases, with specific examples like, for example, dust storms, drought, wildfires, heat and pollen increasing, deeply impacting patients with allergies and asthma. And as you will hear in the following talk, with more than 200,000 new anthropogenic substances being released into the exposome without a full understanding of strategies to mitigate their very damaging effects on human health. At the EACI, we have many initiatives which are focusing on the One Health, looking at the interdisciplinarity and joint efforts in education, communication, clinical care, disease surveillance. With that in mind, we created 2 new working groups. One is a working group dedicated to One Health, uniting colleagues from a broad range of fields of expertise like nutrition, ecology, biology, microplastics, agriculture, veterinary medicine, wildlife experts, and aerobiology. The second group is looking at the root cause of the disease, the epithelial barrier dysfunction. And here again, we are looking at a lot of data on detergents, household cleaners, air pollution, and so on and so forth, for favoring allergy, asthma, and other chronic conditions. We do have dedicated resources for the One Health. One is our journal, Allergy Journal, which is the leading journal in the field of allergy and clinical immunology. And we are developing 2 resources. One is academia framework for intervention in the format of guidelines on environmental science for allergy and asthma, and a global atlas on planetary health. Of course, we are also encouraging our colleagues to actively contribute. For example, the recent campaign that was launched on the occasion of the One Health Day is attracting contributions from all our members to start acting daily to contribute to a better world. And we, over the time, we developed many other One Health resources looking at aerobiology for the safety of human health, the microbiota, a living lab for biological diversity, looking at prevention through microbiome, nutrition, and epithelial barrier tools, and of course, One Health International 2021 digital event. With that, I would like to invite you to enjoy the following talks and to follow us on the NIACI website on more initiatives on climate change and One Health. Thank you.
So thank you very much, Joanna, for this wonderful introduction about the academy. Our second speaker is Cezmi Aktes. He's the professor at the Zurich University Medical Faculty. He's director of Swiss Institute of Allergy and Asthma Research. He will talk about epithelial barrier and the immune system as key tools for resilience. Please, Cezmi.
Hello, good morning, all COP27 participants. It's great to be in this meeting together with you. I'm going to talk about global environment and health crisis, which started around 1960s and together with epithelial barrier theory. And this ended up with around 2 billion chronic non-communicable diseases. So this is the allergy, asthma, and autoimmunity pandemic. When the first cases were described in 1819 by John Bostock, these are the first asthma cases, and Charles Blakely, the first series in 1873, the prevalence of these diseases were very low. When we come to 1900, again, it is said that there's only 1% of allergy and asthma in the Swiss Army, and this was analyzed by several methods that it's true. In 1960s, again, the allergy and asthma prevalence is quite low, 1 to 2%. But after 1960s, we see a very steep increase, and we can see the percentages here about 4.4%, 8.4%, 20%, 28%, 26%, 43%. Currently, about half of the world population have IgE-type antibodies to allergens, and about 1/4 of the world population, 25%, have a clinical disease. And this is starting with the introduction of more than 200,000 new substances to human lives, starting from 1960s, together with the chemical revolution, together with the oil revolution and oil products. And then we had, at that time, around 20 to 30 million chronic non-communicable patients in 1960s, which increased to 2 billion at our time, with a 100 times increase. Then we are seeing a second wave around the year 2000, with the increase in food allergy, eosinophilic esophagitis, drug hypersensitivity. These diseases are also on the rise at the moment, and we can say that the first cases of eosinophilic esophagitis was described in our institute in 1996, and currently the prevalence goes up to around 4% of the population. And in the same time, the world population from 1960s to now increased by 2 times. So what happened after 1960 to cause the global health crisis? There's more than 200,000 new substances introduced to human lives with almost no control on their health effect after 1960s, and many of them ended as pollutants. So we have a list of substances that we have worked in our institute and have data. We have here laundry and dishwasher detergents, surfactants, diselexaws, ozone, nanoparticles, enzymes and emulsifiers in processed food, shampoos and body cleaners, household cleaners, toothpaste, particulate matter, microplastic, and all of these substances are affecting the epithelial barriers. The epithelial cells, which make the border and the very strong barrier of our body in the skin and on mucosal surfaces, are not touching each other. And there is microbes, allergens, toxins, and opportunistic pathogens going deeper in the tissues, and they are interacting with the immune system to start an inflammation. This is described in this paper in detail, but our work started in around 2000s for analyzing the epithelial barrier damaging substances and its mechanisms. Currently, we have more than 70 diseases that we can talk about related to the epithelial barrier theory. And our selection criteria is increased prevalence after 1960s or 2000s with almost the same method of diagnosis. There's microbial dysbiosis with the loss of commensals and colonization of opportunistic pathogens in all of these diseases. There's epithelial barrier defect and epithelitis, the production of certain cytokines from the epithelial cells because of their activation. And there is circulating microinflammation with chemokines, inflammatory markers in these patients. So these patients are now appearing with comorbidities. They are appearing together with many diseases at the moment. In 1960s or before 1960s, they were mostly a single disease and they were not coming with many diseases. We have a list of these diseases, and these are the group that the epithelial barrier defect or body surfaces defect and microbial dysbiosis is taking place in directly affected tissues. Here we have atopic dermatitis, a skin inflammation which affects around 10% of the population, asthma, a lung inflammation, and chronic rhinosinusitis, allergic rhinitis, eosinophilic esophagitis, inflammatory bowel disease, and celiac. In all of these diseases, we are seeing microbial dysbiosis, change in microbes, and at the same time, epithelial barrier defect. The second group is autoimmune and metabolic diseases linked to mainly gut barrier defect, but also it can be periodontitis and sinusitis and microbial dysbiosis. Here in this list, we have very prevalent diseases that we are continuously daily talking about: diabetes, obesity, fatty liver, autoimmune hepatitis, liver cirrhosis, rheumatoid arthritis, multiple sclerosis, systemic lupus, ankylosing spondylitis. In all of these diseases, we are seeing microbial dysbiosis. The microbes are changing, and bacteria are translocated below the epithelium. And there is models that show also epithelial barrier leakiness and gut microbial dysbiosis in these diseases. The third group is affecting also a huge population in the world, and these are neuropsychiatric conditions linked to gut barrier defect and microbial dysbiosis. Here we have autism spectrum disorders, Parkinson's disease, Alzheimer's disease, stress-related psychiatric disorders, and chronic depression. So what happened is after 1960s, there was an agreement of millions of years with mammalians and the microbes, and this agreement started to be broken. There was a homeostatic interaction of the epithelial cell in the immune system with commensals. So the commensal bacteria, the normal flora bacteria on the skin, in the gut, in the upper respiratory mucosas, are floating normally on the surface of the epithelial cells. And they are not going below the epithelial cells, or they are not going in between the epithelial cells. But after 1960s, what happened is that their function as digestion, providing nutrients, vitamins, metabolites, immune education, cell differentiation, tissue maturation is broken. Because these bacteria, the biodiversity, which Professor Matela is going to talk about and Professor Claudia Treidel-Hoffmann is going to talk about, is now broken. It is not the same biodiverse bacteria, and there is colonization of opportunistic pathogens, and this agreement of several million years, and for humans around 500,000 to 1 million years, doesn't work because of environmental change and because of exposure to many toxic substances. So what happens? Let's try to understand together. This is our body surface epithelial cells. Nowadays, they are not touching to each other, and this is happening most probably around half of the world is now affected with this epithelial barrier damage. And these epithelial cells are not touching to each other, and they are getting activated when they are exposed to microbes and environmental factors, and they start to release certain cytokines. And these cytokines are called alarmins, and they activate the immune system to come together with the epithelial cells and more close to epithelial cells and start a peri-epithelial inflammation. This is called epithelitis. And this is together with also neuroimmune interactions and changes in activation threshold of cells. Then we have the expulsion response, which is very important. The body thinks that these bacteria are not in the right place. Some of them are between the epithelial cells, they are touching the basal epithelial cells, and some of them are beneath the epithelial cells. And the immune system is activated to get rid of these epithelial cells. It starts to tries to throw them away, tries to get rid of them, and this makes the diseases that I have listed to you, like asthma, allergies, and chronic sinusitis, and colitis, and Crohn, and these bowel diseases. So the players for the upper respiratory system is Ig type of antibodies that make allergy, eosinophilia, which is the main characteristics of asthma and chronic sinusitis, open epithelial barriers, cough, and the types of cells, T helper 2 cells, innate lymphoid cells, and certain cytokines. And nowadays we have treatments targeting these cytokines that are very successfully working. At the same time, opportunistic pathogens, Staph aureus, Moraxella, Haemophilus, and Pneumococcus for the respiratory system are colonizing, and our microbiota is changing, and the biodiversity is decreasing because of colonizing opportunistic pathogens. And this immune system shows an immune response to our healthy bacteria. So the agreement with healthy bacteria is broken, and we are now trying to attack our healthy bacteria and changing the biodiversity. And then there is the autoimmune part of this reaction, and immune response to commensals and Staph aureus and autoantigens are taking place. That makes a very complex disease that we are talking about. Asthma, rhinitis, atopic dermatitis are from these diseases. The other important aspect is that this inflammation, when it starts, it doesn't stand still on the affected organ. The cells and also the mediators start to circulate in the body and affect other organs. So let's look at the lung section here, or a gut section. The epithelial barrier is broken, epithelial cells are not touching to each other. There is microbes, allergens, pollutants between them and passing through them, and the immune system cells are activated. So a cell which is activated because of increased particulate matter, because of increased air pollution, is activated here, which we have seen in 2019 Stockholm, 2020, 1920 Beijing, that these cells are migrating to brain to make multiple sclerosis. Or these cells are activated, they are migrating to joints to make rheumatoid arthritis. And how this environmental pollution and change and exposure to toxic material leads to very many chronic diseases is related to this mechanism. And we have skin homing T cells, CLA positive cells that were also studied in our institute a lot. And these cells are migrating to skin to make atopic dermatitis. And there is also impaired gut barrier defect. In the intestinal barrier is broken, but the patient appears with diabetes. And also joint migrating T helper 17 cells from gut and rheumatoid arthritis. And brain migrating T helper 17 cells moving to brain and then making multiple sclerosis. So there is a lot of important events taking place, and that is affecting and that's causing a huge healthcare burden currently. And here is the summary of all these. Now we can see there's genetic reasons and exposure to barrier damaging agents and opening of the barrier as the first step. Then colonization of opportunistic pathogens and translocation of microbes to subepithelial areas. Then we see immune response to these microbes and allergens and autoantigens at the same time. And we can see the commensals are decreasing, and there's microbial dysbiosis taking place with decreased biodiversity, and then inflammation in the epithelium and chronicity. So when an asthma patient or atopic dermatitis patient starts, it's very difficult to get rid of these diseases. There's a chronic inflammation because there is molecular reasons for chronicity, and defective epithelial barrier healing capacity and epithelium is leading to chronicity is very important. And we are seeing 2 billion allergic, autoimmune, and neurodegenerative patients. In summary, we have direct toxicity to epithelium, then we have epithelitis, the inflammation in the epithelial area, expansion response in the epithelial area, and we see migration of inflammatory cells to distant organs. I'm going to stop here, thanking you for all your attention, and look forward to working with you in collaboration to solve these problems. Thank you.
Our next speaker is Professor Teofil Mumbaga. And Dr. Mumbaga is a pediatrician at Kilimanjaro Christian Medical Center in Moshi, Tanzania. She is the director of Kilimanjaro Clinical Research Institute and co-leader for the KCMC collaboration on clinical research. She will talk about climate change and allergies in Africa. Please, Professor Mumbaga.
Yeah, thank you very much for the introduction. I'm happy to be here and present to you all. And I will be presenting the case of children air pollution profile in Africa, which is a study done within a network, but I will present the results based on the Tanzanian findings. So, as she has introduced me, I'm coming from the Good Samaritan Foundation institutions, which is Kilimanjaro Christian Medical Center, founded 1971, Kilimanjaro Christian Medical University College, 1997, and the Kilimanjaro Clinical Research Institute, which are linked in their functions, and one dealing with healing, teaching, and research. And I'm currently the director of research in the 3 institutions. And I will present one of the research activities we have done on air pollution in children. Yeah, we know that air pollution and climate change currently is a problem, and especially due to climate changes, there is a higher increasing episodes of allergy and asthma, and this is due to a long prolonged warm season, as well as prolonged pollen periods, but also we do face natural disaster and the floods, which happens even in Tanzania, and also the case of a long-term dry due to irregular rain season, and these are all leading to changing in climate and also producing pollens, as well as favor the pollens related plants and increase some allergic reactions into people with asthma. And therefore, it's quite very important to look into it and understand and monitor air quality so that prevention and effort to minimize exposure to pollutants can be done, especially to people with allergy and those with asthma. And as already mentioned by my fellow previous speaker, asthma is one of the chronic obstructive pulmonary disease, which is quite affected with air changing and air saturation. As a result, people are getting worsening symptoms, and you know that in asthma, allergy induction is quite one of the common reasons for people getting attacks. So what I'm going to present to you is related to children air pollution profile in Africa, known as CAPA study. And this CAPA study was funded by NIHR and Queen Mary University London as a lead, but several African countries have been participated, Malawi, Uganda, Zimbabwe, Ghana, Nigeria, and South Africa. But here I will present the result based on what we have done in Tanzania. So Tanzania, we did as a pilot start where we launched the project in June 2021, and the enrollment happened in 5 schools, which were located at different places in Moshi municipality. We did engage school authorities and health authorities, but also parents. And we got consent from the school authorities as well as parents, but children, because we were involved, children from 12 to 16 years also provided assent to be participating in the study. And we screened for Acacia breathing survey. This is a larger study, which is based on asthma in children in Africa. But for the air pollution study, it was a sub-study. So we screened 919 children for the asthma study, and we had 109 asthma patients. So from this 109 asthma patients, we enrolled 62 pupils in our CAPA survey, who parents provided consent, and also children provided assent. And we had 62 enrolled pupils because cutting across the 6 African countries, each country were about to enroll 60 pupils in this air pollution survey. So we deployed backpack with air pollution monitors to students, and they can stay with this bag for almost 72 hours, monitoring all the time air where they pass, from home to the school, from school to home, and we trained them so that they don't sit far from their bags, and they don't share the bags with their fellows in school, so that we can catch where really they are passing about. And we engaged with parents, and the phone calls were done for follow-up, and then we collected bags. But upon collecting bags, we actually given thanks to the pupils by giving them a backpack for their to continue taking in their school books. So these are different schools which we have enrolled. There are 5 schools. 2 schools they are together, and these other schools they are different. These 2 schools they're actually in the city center, and also near a bus stand, and also near some industries. But these other schools were into different extremities. And as I said, we launched our study, we trained the children, we did a survey, and this survey including different air pollution exposures at home, on the way, which the children knows. But also we trained our research team in how to charge the monitors which children were using, because they had to charge and make sure that it has enough power to stay for the 3 days. So I can present the results of what we have seen. We know that WHO has actually the recommended air is at least 2.5, but most of children, and whether at home, on the way, commuting, or in schools, they were exposed to higher than required air pollution, starting from around 20 to 44.6. And in some of the schools which were near the cities, you can see that it was even higher during commuting, up to 45.6. And this one, 52.4. So these are schools which are near industries. And this Mawens primary school is also just like 5 meters from the bus stop. And you could see that there is also higher air pollution. So in average, if we see that the average exposure, it was 26.0 as minimum, but the highest 41.3. So this is extremely higher than 2.5, which is recommended. And this observation which is seen here, it was similar to an observation which has been seen in other countries, that children are exposed to higher air pollution. So if we look exposure in different, you can see the mean at schools was like 34.9. During commuting, which is higher level of exposure, it was 36.6 microgram, and at home seem to be the lowest exposure of air pollution, around 30.0. And these are the different areas, commuting, home, and the schools, but all are having higher than 30 as the mean exposure. So the highest concentration in schools, which were around industrial areas, as I mentioned before, and is slightly skewed highest during commuting. As you can see, this school, Azmio, is showing the highest one, but also Mawens, which is in the city center, and these others. And you could see at different periods, how children were exposed to, but all there were more than 25 microgram. Yeah, so if we look at the individual child exposure, you see that the early morning when they go to school, the exposure is during commuting is maximum, highest. And during the school time, you could see in the morning before 9, it was also higher, maybe because at this early morning, children are cleaning environment at the school with the dust, and they are also maybe exposed more. But during the class time, it's less. And in the evening, also, you could see that it is changing. So in the home environment also, it is fluctuating. It depends maybe where the child is, but also you could see the different fluctuation of the exposure. And looking at the time series, you see that, as I said, in the morning, there is highest exposure. This is another child compared to the previous one. And looking at the schools, the exposure is low, but during commuting again, the exposure is high, and at home, the exposure is low. So, and after the session where the children were staying with the bag for more than 3 days, then they were getting this present. So that because they used those days to go with the bag, so we were worried about the children be bullied by the fellows because they have now, the bag has been taken off. But this came as an advice during stakeholders meeting with parents and teachers before the study started, and which worked on well. And after our start, actually, we also did a focus group discussion with the pupils and the parents to give them opportunity to learn what kind of, to tell us what kind of exposure or what kind of air pollution exposure they think about, and they get an opportunity of discussing and mention different exposures. And most of them learned because they never know that this might be also some exaggerating asthma attacks in their children. So during this exercise of bag, we did find 3 children who had symptoms of asthma, and they were referred to for care at the hospital. But at the end, we did feedback by doing the stakeholder engagement meeting with the teachers, parents, and government officials, which were quite well received. And we discussed the different preventive measures, including suggestions from the teachers to put some waters on the lanes around the school, especially the time when children are assembled, or cleaning in the morning, so that to avoid a lot of dust. So our key findings during dissemination, as I say, government officials were quite received it very positive, and were committed to collaborating in creating intervention. And the parents were quite very happy, and were happy for the feedback, especially, and the way the children were handled for those who were sick. And they had an opportunity of discussing air pollution sources specific to their home settings. And also the teachers, based on the children they see at the schools, especially the health education officer, they thought that it's quite important for them to get support for school emergency asthma kits, more school education awareness for asthma, but also how to refer children with the asthmatic attack for further evaluation in the health care. Yeah, so in conclusion, I can say that air pollution is a problem in Africa as it is all over the world. And the children with asthma are exposed and increased attack risk because of the dust and pollens. And the mean air concentration is above the WHO recommended 2.5. As you can see, the mean was 26 up to 41. And all countries involved in this study, as I said, observed similar trends. And high air pollution were in schools near industries and cities in the middle of the city. And that means attention is needed in improvement of the schools, environment, and the locations. Yeah, so to share with you, I can send appreciation to the team, Acacia team, as well as Kappa team, but also NHIR for funding us and our institutions, which supported us in involvement into this study. So thank you very much.
Thank you very much, Professor Mbaga, for this wonderful presentation. And we have another speaker who is the expert in his topic, Professor Abbas Ostad. Abbas is the head of the Department of Health in Emergencies and Disasters. So his main interest is community disaster resilience and climate adaptation as well, especially in urban settings. So Professor Ostad will talk about climate change and allergies in the Middle East.
In the name of God, hello dear friends and colleagues. My name is Abbas Ostad Taqizadeh from Tehran University of Medical Sciences, Iran, and my presentation is about the climate change and allergies in the Middle East. All of us know that the main reason for climate change as one of the most important issues is the increasing the level of CO2 emission in the air, mostly caused by fossil fuels. CO2 emission in the atmosphere can cause and increase the average daily temperature as the cause of some impact of climate change, such as floods, such as heat wave, and so on. The question is that why climate change is important. Because the climate change can impact can influence different aspects of life, human life, such as health, agriculture, nutrition, economic, and etc. Concerning the health impact of the climate change, we can divide the impact of climate change on physical health, such as coronary artery diseases, respiratory diseases, renal diseases, and etc. And the second category of health impact of climate change is mental health, and the last one is community health. In this presentation, I just want to focusing on the health impact of climate change in respiratory diseases. These slides show key challenges in the cities that are related to the respiratory diseases. You can see the household quality and housing and sheltering quality, air quality, workplace quality, and as well as global climate change. All of this issue can influence the rate and the prevalence of respiratory disease. We know that the climate change can cause different kind of natural disasters such as flood, drought, heat waves, cold waves, and dust storm. But concerning the respiratory disease, we can say that the main the issue is the heat waves that caused by climate change and dust storm. In this presentation, I just want to focus on this main issue and this important issue. In terms of respiratory disease, why dust storms are important? because dust storms are contain different particulars such as some small materials, some fungi, some microbes that can enter to the respiratory tract and cause different disease. The top of these diseases are COPD and all of the respiratory diseases that are related to the allergy. We are talking about the Eastern Mediterranean region countries. As you know, we have in the region 22 countries from Tunisia in the west to Pakistan in the west. And this region is one of the most important region that most of the dust storm can cause here. The presented slide show the asthma prevalence in the world and comparing it with the Asia, and you see that the prevalence of asthma in countries such as United States, some European countries, and Australia is more comparing to the Asian countries. When we take a look in the trend of prevalence of asthma in the world and in the Middle East region, we see that the prevalence of asthma in the world is decreasing, while the level of the asthma prevalence is sustainable mainly in the EMRO region. The question is what was happening in this region. As you see in this slide, sand and dust storm origins come from some part of the United States, and mainly in the MENA region, the north of Africa, Middle East, Saudi Arabia, in the China, and some part of the Australia. This part of the world are the most origin for sand and dust storms. Comparing a map of the sand and dust storms in the world and the map of asthma prevalence in the world show us that it seems that there might be a relationship between these two items. It means that when the level of the sand and dust storm is high, the prevalence of the asthma is high. In this slide, you can see the Middle East dust storm sources. As you see, most of them are in the Egypt. Most of them are in the Saudi Arabia, in the west of the Iraq, and mainly in east of Iran. We have some sources for sand and dust storm. And we can imagine that most of the cities are prone to sand and dust storms, such as Tehran in Iran, in Doha, in Baghdad, in Riyadh, and different major cities. Reviewing top quality publication in EMRO region that most of them conducted in Iran show us that there is a significant relationship between the level of the PM10 and PM2.5 and the risk factor and risk of the mortality and morbidity of respiratory diseases. This is a fact that we find reviewing the publication in this region. From lots of researches, I just want to and have to review some of them. We conducted a systematic review concerning the health impact of dust storm, and you can see the map of the researchers that conducted in this issue, and you can see some of them conducted in the America, and most of them conducted in the Asia. Our systematic review shows that lots of the articles shows that the relationship between adverse health impact of dust storm. Dust storm can increase the mortality due to respiratory, cardiovascular, and cerebrovascular diseases. Dust storm can increase the level of the emergency medical services, hospitalization, admission, and hospital visits due to respiratory and cardiovascular diseases. As well as sand and dust storm can increase daily symptoms such as nanopharyngeal symptoms, pulmonary symptoms, skin and ocular symptoms. Another systematic review was conducted in Iran concerning the heat wave, and in this slide you can see the research map of heat wave and health impacts. This systematic review showed that there is a significant association between the heat wave and different kinds of diseases such as cardiovascular disease, renal disease, respiratory disease, and hospitalization, and so on. One of the most important issues in EMRO region is that there isn't any unified standard for assessing the level of PM10 and PM2 as one of the most important criteria for sand and dust storms. And you can see there is different standard in different countries. So WHO recently published a new guideline entitled Air Quality Guideline Level, and suggested the level of the PM10 as 15 microgram per cube meter. Our study in Desful in south of Iran showed that if we imagine that the level of the air quality guideline that WHO conducted is 15, most of the months are more than, is about 10 times more than the standard. Our studies in Desful showed that the dust storm is related to the level of the PM10, and as you see, the risk of the respiratory diseases can increase depend on the level of the PM10, especially after 6 days of occurrence of this sand and dust storm. It's so important that we have a delay in the mortality risk of respiratory disease when dust storm occur. Another study in west of Iran, in Elam, shows that the level of the PM10 can increase the hospital visits for COPD, and can increase the level of mortality due to respiratory diseases. And this is attributed to the PM10 concentration. The question is that how we can adapt with some impact of dust storms. Our studies in Iran show that we have different kind of strategies. We need to develop educational activities in public and in academic activities. We need to increase the level of public participation. We have to increase the intersectoral collaboration and coordination, as well as we have to develop institutional activities for coordination and collaboration, as well as we have to preserve and conduct some environmental preservation activities. One of the most important action that can be done for adaptation is monitoring sand and dust storm adaptation in the communities. Our studies in Iran shows that we can monitor the level of the community adaptation concerning climate change, and right now we have developed a tool for assessing and monitoring the level of community adaptation. This questionnaire and tool have been validated and piloted in Ahvaz city of Iran, and we can use it. In general, our studies in this region shows that there is significant relationship between the sand and dust storm and heat waves and different kind of climate change impact and respiratory diseases such as hospitalization, such as COPD and mortality of respiratory diseases, and we need to do some actions. Thank you.
So we thank very much to Professor Abbas Ostad for his presentation. And it's a pleasure to invite the next speaker, Professor Claudia Treidel-Hoffmann from University Augsburg and Helmholtz Center, Munich. She focuses on environmental health sciences, both with translational research and patient care. Today, she will turn the magnifying glass to early warning systems as an opportunity for allergy management and prevention. Her talk title is Real-Time Monitoring and Alert Systems. Please, Claudia.
Maybe, Chair, thank you very much for introducing my talk. Dear colleagues here in the Zoom and also in the world and there also in Sharm el-Sheikh, it's really a pleasure for us here as represented as colleagues from the EACI to speak about allergy and climate change. And as you all know, climate change is impacting our health. It's a major threat for our health, and it's making us ill from head to toe. We are concentrating here on the skin and on the respiratory tract and on allergies. So my task here in the following 15 minutes is to convince you that allergy really is a threat of our younger generation, and we need something really to for a comprehensive allergy management. And this means also that we have to measure allergens in the air. But first of all, here the European view, we have 150 million Europeans that are suffering from allergic diseases, and this reflects how important this illness is for the whole world. And it does not only mean that people are suffering, but it also means that this costs a lot. Allergy costs a lot to our socio-economic world, and this should at least convince stakeholders to do something here. For us as medical doctors, we have the health of the patients in our mind. So there are 4 things you have to keep in mind when you think about allergy and climate change. First of all, due to climate change, we have longer pollen season. So they are starting to fly earlier in the year, and they are flying in the autumn. Then second is we have more pollen that are flying. And we have also another quality of the pollen. The pollen are getting more allergenic because the stress means for the pollen to rise its own immune system, and the immune system of the pollen are the allergens, the proteins that are inducing in our body the allergy. So this means the pollen is stressed and it's upregulating these proteins. So the pollen are becoming more allergenic, more aggressive. And the 4th point is that we have also new pollen. Again, here a little bit the European view. So we are becoming, we are getting new pollen, for example, the ambrosia pollen that are entering here the European planet, the European area. And you can see here that this new pollen, which is something which is known already to the people from US, it's really a strong
allergenic pollen inducing asthma attacks and also rhinitis. So these 4 factors are really important. And in order to understand how environment is impacting on our health, we have really to bring the exposure together with the reaction. And this is only one example for you to make you a little bit, to give you an idea what we mean as researchers and medical doctors when we speak about environmental health sciences. So we are combining environmental factors, pollen concentration with symptoms and trying to bring this together. And all this at the end helps us to understand how we can manage an allergic disease and how we can manage also allergic disease in 10, 20, or also 50 years when the exposure with pollen is becoming more and more. So what we are doing here in Germany and also in Europe, so we are trying to monitor pollen, but what we are normally doing is somebody is looking in the microscope and counting pollen, tick, 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 1, 2, 3, and I think this is not what we should do in the year 2022. We have also these automated bioaerosol sampling measures. This is only one example of several. And with this automated pollen monitoring, we really can do a real-time monitoring. This is what we need in order to inform the patient, in order to make them alerted that pollen concentrations are high, to change their medication, and also perhaps also to stay inside. Quite simple measures that can be taken in order to reduce the symptoms. But for this, they have to know how many pollen are flying. Second, here, one clear-cut example comparing the old standard and the new online pollen monitoring system. You can see here clearly that the old system is underestimating the pollen concentration in the air, and it's also missing the peaks. Here you can clearly see it, and this means we really need here a worldwide automated and online pollen monitoring system in order to understand how many pollen are flying and to inform the patients what is in the air. So what we are doing then in research, to give you a glimpse of what we are doing, so we are really going also outside. We are taking here the catkins from the birch pollen, but trying to understand how many pollen here are there. And another point is we are also trying to combine satellite data with the data of students that are going around and trying to pinpoint where the birch trees are. And the clinical relevance is really that we're trying to have this fine-scale spatial information service for the patients in order to make them able to plan their lives, to plan also their activities outside. And by this, we are able to set up here the first bioaerosol monitoring in Augsburg and in Bavaria. We have really a good online monitoring system at the moment, and we are trying to expand this further. And the clinical relevance is really that we can here have high-risk alerts for pollen allergics and to warn them when pollen are high. Second thing is, and this is also important, that we have not only pollen that arise from the birch trees. For example, here I'm sitting at the moment in Berlin, but we have also this long distant transport. And we also know that this long distant transport, even this can cause symptoms. We know this from a study that is going to be submitted in the next days. So also this is something we have to take into account in our research. So also what we have to take into account is to look into the future. What is happening with the pollen in the future? And here again, a Bavarian example, when we look for the different IPPC scenario, we can see that we have a strong increase in some areas of Bavaria, especially here in areas we have medical rehabilitation places, so where people try to get healthy again. And this is the point, but you can also see that really at the end of the century, we are losing also the birch trees because they are dying, because the trees are dying, but this is not at all a good information. But we will see a strong increment of pollen concentration in the most areas here in Bavaria, and this holds true for the whole of Europe. Another thing I would like to bring to you, it's not only pollen in the air, it's also fungal spores that are increasing. And also this is something we are doing together with a global network here, the European example. So we know that higher air temperature is also inducing outdoor spore concentration, and spores also are inducing allergies. And this is also something which is increasing. Another thing which is really absolutely out of the box, we know also that pollen are not only inducing allergies, but pollen are blocking the mucosal immune system. So when pollen are landing on your mucosal surface, they are blocking your antiviral responses, meaning we see that when pollen are high, we have an increment of rhinoviral infections, and also we saw an increment of SARS-CoV-2 infections with higher pollen concentrations, meaning pollen are paving the way for viral infections of the upper respiratory tract. Climate change is impacting on our health. We know that pollutants are here very important. And what I would like to stress again, that there's this co-exposure of pollutants and pollen. This is something which has a major health impact, and climate change is changing all this even a little bit more. And this is really important, the cumulative exposure risk. So it's not only pollen, it's pollutants, it's temperature, it's light pollution, it's NO2. So we have to take all these pollutants into account for our alert systems. And this is data here again from the satellite. So this is really what we can do to combine also the satellite data in our early warning systems. Something else, what we need is city planning, which can be approved. You see here in Berlin, they are planting birch trees in the city. This is really ridiculous. We know that pollen are the major inducer of allergies. So why one could think about planting birch trees in a city? So this means we medical doctors, we have to work together with the city planners in order to do this. And as my colleague just said here, this is a screenshot of her talk. She said that we need to increase the monitoring system. So this is something we need to do worldwide. We need online monitoring system worldwide in order to have sustained and comprehensive management of allergic diseases. To summarize here, we need to measure exposure. We need to take the reaction of the patients in order to set thresholds, personal thresholds, to identify the personal risk. And then at the end, and this is what we need prevention through prediction of the disease and prediction via the risk assessment. And these are the unmet needs. So we need area-wide pollen spore information system, comprehensive pollen and spore real-time information system, combined exposure risk assessment, personalized education, intervention for sustained prevention, and we need more translational research to assess personal thresholds. And by this, I would like to end, and I know that we together can save our environment for sustainable health. Thank you very much.
Thank you very much, Claudia, for your excellent talk. And we have another speaker. I would like to invite Professor Tari Hautela. And Tari is the Professor Emeritus at Skin and Allergy Hospital in Helsinki University. And Tari will talk about the integrated prevention of NCDs, nature loss, and climate change, asthma and allergy showing the way. So he will explain to us what is NCDs. Thank you. Tari, please.
Thank you very much. My very warm greetings from Ray. Nature loss and climate crisis, and maybe asthma and allergy can show the way. Already in 2014, WHO asked who is at risk of climate change, and the answer was straightforward: everyone and everywhere, and especially those vulnerable individuals and populations are in danger. But less is known of the relation of two megatrends: the nature biodiversity loss and the rise of non-communicable diseases, whether they do have something to do with each other. Here down on the left is the very recent Global Living Planet Index by WWF, which shows that the relative abundance of more than 5,000 vertebrate species has gone down in 50 years, almost 70%. And on the right, you see some statistics from Finland showing how asthma, allergic rhinitis, inflammatory bowel diseases, colorectal cancers, type 1 diabetes, celiac disease, autoimmune diseases have gone up at the same time. Do they have something to do with each other? Let us visit the eastern border of Finland, the Finnish and Russian Karelia, which were strictly divided by the Iron Curtain after the Second World War. The population on the Russian side, they continued their small-scale, self-supporting agricultural life, when on the Finnish side, the more urbanized and industrialized development took place. So it created kind of a living laboratory. Now look at that figure here. School children, they are quite different in terms of occurrence of allergy and asthma. Asthma, hay fever, sensitization to environmental common allergens are very, very different. The red columns are the Russians. Hay fever is almost non-existent there. When we look at the picture here on the right, we see a very remarkable cohort effect in adults. If we look at those who are born in 1940s, there is no difference in the sensitization rate of common allergens, when the difference is already manifold for about 40 years later. So in 40 years' time, a very different development in these two areas, which are very close to each other, about 200 kilometers distance. So if we would understand what is causing this kind of disparity of development, we might take steps from treatment to prevention. Well, overall, we have looked at the reasons, and the conclusion is that the allergy contrast was not caused by basic genetical differences, but by environmental and lifestyle factors. The naturally biodiverse, rich environment of the homes, of the adolescents, school children, it was related to rich microbiota on the skin and immune balance and health. And this created kind of a biodiversity hypothesis, which were also very clearly seen on the microbiota. Here are the Finns on the left-hand side, and here the Russians on the right-hand side. Very remarkable difference in microbiota diversity and richness. Well, bacteria and also the other microbes and biogenic chemicals up and down regulate gene expression and the epigenetic modulation for the immune response to the environment where we live in. We have neglected very much to study the so-called biogenic chemicals. There are more than 1,000 identified. There are the terpenes, pinanes, linones, and they do have anti-inflammatory, antioxidative, and anxiolytic effects. But the clinical potential of this exposure is really very poorly known. In 1992, biodiversity was defined by United Nations as variability among living organisms, the richness and genetic diversity of local and global species and populations. And in fact, we are protected by two layers of biodiversity. The outer layer with the macro and micro diversity, and the inner layer with external and internal microbiota. And the crosstalk between the ecosystem of the human body and the environmental ecosystems is mediated by the barrier microbiome. And it has 100 times more genes compared to what is the number of genes, about 20,000 in our own cells. So the information and the informative content is huge in this barrier microbiome, in the gut, on the skin and airways. So human body certainly is an ecosystem, a community of species, and immune defense is a response to biodiverse environment. And to create and maintain the immune tolerance, the innate immunity needs continuous natural exposure, because no permanent memory cells are easily created in the innate immunity, so that our immune system can make a difference between danger and non-danger, as well as self and non-self. If it cannot make difference between self and non-self, it may attack its own cells, like in pancreas, those cells which are producing insulin, and the outcome is diabetes. In practice, the microbial diversity means a lot of species, but in small amounts. And on healthy skin, the microbiota is rich and diverse, but if the inflammation attacks, the diversity collapses, and the opportunistic microbes like Staphylococcus aureus can take the dominance. And the patient may have to go to the doctor and get an antibiotic to kill the dictator and suppress the inflammation with corticosteroids. And then slowly the microbiota recovers towards normal. Well, the biodiversity hypothesis states that contact with natural environments enriches the human microbiome, promotes immune balance, and protects from allergy and inflammatory disorders. And it certainly looks like that it's not so much question of new risk factors when we are speaking of allergy, asthma, and other non-communicable diseases, but more question of losing protective factors. And they originate from soil and natural waters and air. They are microbial, but they are also chemical, biogenic chemicals. Well, we implemented these Karelia results and biodiversity hypothesis to practice by making the so-called Finnish allergy program. And that was a systematic approach. We made the strategic choices. We defined the tasks and tools and also the activities, like educating the healthcare and making a campaign for lay public. And it was really a natural step to allergy health, and we especially focused on children. And here on the right, you see these children there in a natural environment, and you can imagine what they taste, what they smell, what they drink, what they eat, what they breathe, what they touch, compared to these children who are in an urban environment. Well, allergy program achieved most of its goals, of course, very much by improving management and the guidelines, but also improving primary and secondary prevention by endorsing nature relatedness. In terms of allergy diets, occupational allergies, also the asthma patients, they were marching out of the hospitals, and the cost savings were remarkable, especially in terms of the disability, indirect disability cost. And here you see the cumulative cost savings, the yellow columns here, and the cumulative cost savings. They were 1.2 billion euros. 1.2 billion euros only for one group of disease and for a population of 5.5 million. And if you think about the investment to healthcare education and information campaign, it was around 2 million euros. So with 2 million euros, we got 1.2 billion savings. Of course, a lot of voluntary work was also involved, which is not counted here in the investment. Well, then you may say that the Finnish program was an open intervention, and maybe good things would have happened even without that. But now we also have very recent studies, placebo-controlled double-blind testing of the biodiversity hypothesis. And there in the daycare, the sandboxes, they have been enriched by microbe-rich soil elements. And already in 2 to 4 weeks, here, the blue columns, we see that in many of these bacteria families, there is a significant increase, and at the same time, also positive improvements in the immune response. Of course, we don't know whether this approach prevents really from the disease later on, but very, very promising. So overall, the non-communicable diseases are on the rise in all urbanizing societies, and they share the common features of microbial imbalance, long-term immune dysfunction, and low-grade inflammation. And of course, the barrier hypothesis we just heard from Sesame is playing a very important role here. The risk of disease depends on individual genetics, but clinical manifestation, especially on the epigenetic regulation modified by lifestyle and environment. And we are moving forward. Lahti is a mid-sized city in Finland, and it was the European Green Capital last year. And this year we started their regional health and environment program. It's a 10-year program where we have combined the challenges of public health to the challenges of environment. And we try to improve the situation by promoting healthier diet, mobility, physical activity, creating better living environments around the homes, and also in every possible way connection to nature. Of course, we don't have any result at this point. Also, we have there maybe at least it is the first in Finland, but maybe in the world we have a planetary health doctor. Half of the week, she and she is a neurologist. She is seeing the patients, and the other half she's taking care of the planet. Well, my dear friends, disconnection from our evolutionary home has caused a major public health crisis. We certainly are not going back to nature, but we have to take nature back into the cities and our everyday life. And for that, we need everyone. we need to change some of the societal structures to urban forms. We have to change lifestyle and our behavior, and we have to promote green economy, which also may give possibilities to the business world by the nature-based solutions. So, my dear friends, here are my conclusions. The rise of non-communicable diseases is caused by changes in the living environment and lifestyle. And the health crisis is very much interconnected to nature loss and global warming. And that is why the crisis must be solved together in the spirit of planetary health. This would have a large-scale social impact with enormous potentials for cost saving. So at the end of the day, we may ask, who is the doctor and who is the patient? Thank you very much.
So thank you very much, Tari, for this excellent talk. And our last speaker is Professor Marek Yutel. Marek is the head of the Department of Clinical Immunology at the Medical University of Wrocław. And he is the past president of the European Academy of Allergy and Clinical Immunology. So he will give us some information about the Academy's guidelines on environmental science. Please, Marek.
Hello, my name is Marek Yutel, and I am immediate past president of the European Academy of Allergy and Clinical Immunology. I would like to take this opportunity to tell you shortly about our monumental work, which is EAACI guidelines on environmental science. Regarding the scope and the target audience, the guidelines address topics concerning the impact of environment on allergic diseases and asthma from inception to severity. The target audience includes healthcare professionals, basic and translational scientists, ecologists, climate activists, regulatory bodies and policymakers, consumers, and, of course, patients, as well as caregivers. This work has been divided between several working groups. The first one deals with atmospheric science, with special focus on pollution, indoor and outdoor, air quality, air biology, climate change. The working group number 2 deals with ecology, focused on the exposome and biodiversity. The number 3 deals with human environment interaction and social science. Working group 4 deals with regulatory issues, which is very important, and focuses on economic and political dimensions with recommendations from policy change based on validated modules of exposure and means of mitigation, integrated surveillance network. And, of course, to show and utilize the most advanced tools, the deployment of artificial intelligence to develop a causality model will be also provided. So these guidelines are really scientific work based on the very solid evidence and very much advanced analysis of this evidence. So this is a great methodology. So first, the questions, the PICO questions are formulated, then evidence is searched and elaborated, analyzed, graded, and then overall quality of evidence across outcomes based on lowest quality of critical outcomes is analyzed by the panel that is searching to provide the suitable answers to the questions that were asked initially. And this is a consensus work of the key opinion leaders, the leading specialists in the field. Here are some examples, the questions that we would like to answer. So with the working group 2, ecology, you can see here the questions. Does exposure to microplastic impact asthma? Does exposure to pesticides impact asthma? Does exposure to cleaning agents, detergents, disinfectants increase the risk of asthma? Is exposure to cleaning agents, detergents, disinfectants associated with asthma exacerbation? Does exposure to hard water enhance the risk of development of atopic dermatitis? Does greenness area in the city-urban environment prevent development of allergic diseases and asthma? Does greenness area in the city environment impact asthma? And another group of questions, does living on traditional farms versus modern farms prevent development of allergic diseases and asthma? Does living in traditional farms impact asthma? Does parasite infestation prevent development of allergic diseases? Does viral infection enhance the risk of development of allergic disease and asthma? So we are very keen to learn the answers. These are a few more examples. The questions formulated by Working Group 3, Human Environment and Interaction Social Science. Do regiotypes exist in nasal polyposis? Do regiotypes exist in pollen allergy? Do regiotypes exist in atopic dermatitis? Does breastfeeding have a significant impact on the incidence of allergic diseases? Do packaged food, additives, emulsifiers have a significant impact on the incidence of allergic diseases? Does the type of peanut exposure impact the incidence of peanut allergy? And another group, does migration impact the development of allergic diseases? Does resilience, lifestyle, socio-economic status impact the incidence of the allergic disease? Does modern living have a significant impact on the incidence of allergic diseases? And there are many more questions that we attempt to answer and provide solid scientific evidence to the public. This will be published in one or more of our journals. We have Allergy Journal, which is the leading journal #1 in the allergy field in the world. But we also have Pediatric Allergy and Immunology Journal, very important and high level, and also Clinical and Translational Allergy. So we are looking forward to provide you with this evidence, and I hope that you will find this useful in your daily life and also in the practical attempts to improve our lives and decrease the incidence of allergic diseases. Thank you very much for your attention.
Maybe Chair can start.
So thank you very much, Marek, for sharing us the guidelines. And I would like to close the session and thank to all our speakers for their wonderful talks. And I would like to thank you for joining us. And as we heard, and all our speakers indicate that if we work harder, we can make our world a better place, and we can also help our nature to recover. Thank you very much.
Thank you very much.
working? No, I don't think. Oh, yeah, okay. Oh, that was that. Okay, this one's working. Woohoo! Right, welcome. Welcome to the session on the human cost of fossil fuels. I'm Jane Burston, the Executive Director of the Clean Air Fund, and I'm going to be guiding us through this amazing event with some fabulous panelists who will talk us through the health impact of fossil fuels and some of the solutions that they've seen that they're working on, and some successes that we can be encouraged by. Because as we all know, burning fossil fuels prevents really, really serious threats to our health, both from the air pollution that it causes and during the process of extraction, which I think is talked about much less often. So to check the kind of level of awareness in the room, I thought I'd give you all a quick test to begin with. I'm sure you will all ace it, because I have heard this statistic several times during the first week of the COP, and I've read it a few times too. And the test question is this: how many premature deaths a year happen due to exposure to air pollution from fossil fuels? This is worldwide. And to give you a clue, there's about 55 million deaths every year. So how many are due to just the air pollution impact of fossil fuels? There's a guess down here, 7. Anyone else? 7 million, I'm guessing. Yeah, she didn't have a million fingers. 9. Another guess, 9. Any takers? Any more than 9? No, both are right, pretty much. So 7 million is the number of deaths that the WHO attributes to air pollution. 9 million is the number that a group of UK and US universities attribute to fossil fuel air pollution. Obviously, there's a range. It's a really big number either way. 1 in 8, 1 in 5 deaths, that's huge. And many more people suffer from diseases that give them a really poor quality of life because of air pollution as well. And like we said before, the process of extraction is also really dangerous, and we're going to hear a bit about that from our first 2 speakers. Our first speaker actually couldn't come here today, so she's recorded a video for us. She's Melina Laubucan Massimo from Lubicon. She's a Lubicon Cree from northern Alberta. And Melina is the founder of Sacred Earth Solar and the co-founder and senior director at Indigenous Climate Action. She's been a researcher on climate change, Indigenous knowledge and renewable energy for a long time, and she's the co-host of a documentary series on these issues. So we're going to go to the video, given that Melina was not able to be here with us today. Sound is coming shortly, we hope. Should have prepared some more test questions.
And we had an oil spill here in 2011, and it was horrible.
April 29th, 2011, there was a massive oil spill in our traditional territory. 28,000 barrels, 4.5 million liters from a pipeline, which also consumed beaver dams, and it went into a muskeg, which is a lot of where our traditional medicines grow as well. And the muskegs are connected to the aquifers and the water systems.
And it happened right on our traditional. And we had an oil spill here in 2011, and it was horrible.
April 29th, 2011, there was a massive oil spill in our traditional territory. 28,000 barrels, 4.5 million liters from a pipeline, which also consumed beaver dams, and it went into a muskeg, which is a lot of where our traditional medicines grow as well. and the muskegs are connected to the aquifers and the water systems.
And it happened right on our traditional land. It happened near a river, and the river all carried out right into our lake.
How I found out was my Aunt Lillian, who taught in the school for 35 years, she called and texted.
And I said, we need you home. You need to come help us. And she said, Auntie, I'll go as soon as I can, right away. She got on it.
And she said, no one's telling us what's happening. Can you find out what's happening? Because we took the kids out to the schoolyard and our eyes are burning, our stomachs are turning, we don't know what's happening, and we can't breathe. There was no evacuation process. In fact, the community wasn't even told of the immensity of the spill until 5 days later. So I set out to find a helicopter to at least fly over so we could take pictures from the air. We wrote up a press release, and then we sent it out to the media, and every major media outlet in Canada came because it was one of the biggest oil spills in Canada's history.
Animals were dying, and they ruined the water, and it's forever. People are crying. It hurt.
I would say I probably developed PTSD from that. It's very traumatic. The fact where you're just you work 16-hour days and you're shaking because you're just trying to field calls from the media and trying to get access to the spill and trying to make sure your family's okay. It just felt like you couldn't do enough. And I can talk till I'm blue in the face. It doesn't matter how much I travel and talk, but that my family can't breathe. That was why I really wanted to see what does a just transition look like when we're implementing renewable energy so my family doesn't have to experience so many oil spills in and around the area and breathing in these toxic gases.
My niece Melina brought in the solar project. It was really awesome. Something, was happening in our community. The local people helped a lot to set it up.
That was my way of feeling more empowered, of building and doing something that will leave a better legacy for younger ones coming in after me.
Okay, a really, really powerful video there from Melina. Yes. Okay. So now we're going to hear from Ken Henshaw, who's going to continue this thread of the impact on community extraction. So Ken is the executive director of We the People, an NGO working with communities in the Niger Delta where oil and gas extraction is happening. And Ken, it's so great that you're able to be here with us today because Ken was also going to have to do a video. Tell us about your experiences and the experience of the communities that you'll be working with, and we'll try and get your slides up, but if it's not possible, I'm sure that you'll manage.
Thank you so much. Good afternoon all. My name is Ken Henshaw. I live with 40 million other people around the Atlantic coast, a place called the Niger Delta. I'm probably sure you've heard about the Niger Delta, right? It's a place where crude oil has been extracted from non-stop for the last 64 years with devastating environmental and health consequences. Unfortunately, my slides are not up here. I have some very exciting pictures to show you, but I'm going to skip all that and tell you in 5 minutes the kind of impacts we have had to deal with. So I was born into a crude oil age, an age where we saw oil companies, Chevron, ExxonMobil, Shell, invade our communities, invade our swamps, invade our rivers, invade our wetlands, our farmlands, our rivers, everything, drilling for crude oil and gas. And there has been an unprecedented penetration of every nook and cranny of the Niger Delta for the last 64 years. We live in a community where people have been literally kicked out of their homes, for oil to be extracted. For the Nigerian state and their oil company partners, there is an illicit wedlock, and that wedlock is cemented in petrol profits and at the detriment of the people of the Niger Delta region. And it's important to say that oil extraction in the Niger Delta in Nigeria happened without the free, prior, and informed consent of the people. At no point in time were the indigenous people of the Niger Delta ever consulted before their creeks and their rivers and their swamps, was probed for crude oil. At no point in time. The British Crown during colonialism in 1938 awarded a blanket license to a company called Shell de Acre that later became Shell, basically giving them permission to go into any farmland, any river, any creek, and drill for crude oil. And they have continued that way for 64 years, up till today, drilling non-stop for crude oil in our space. In this period, the Niger Delta people have become poorer. And oil extraction has happened with the worst form of technology imaginable. Yes, we know that when you drill a hole deep in the ground and you bring out crude oil, water, mud, crude oil, and gas comes from it. The gas is not waste material. The gas can be harnessed to provide electricity, to provide cooking energy. But from the very start, oil companies made up their mind that they will flare that gas. And so the crude oil is channeled in one direction, and gas is channeled in another direction. And the gas is set ablaze. It's been burning in about 1,000 furnaces all across the Niger Delta region for 64 years, just burning. There are kids, old men now, who were born and have seen those flares. And the impacts are devastating, right? This is carbon being burned. It goes up in the air and it comes back as acid rain. It pollutes farmlands. It destroys river bodies. It fishes. It causes diseases of the epidemics. And the people also breathe gas flaring. We have irrefutable evidence of the health impacts of gas flaring. It causes bronchitis, cancers, diseases of the epidemics. In the Niger Delta where I live, there are women who go into menopause at the age of 25, and the cases are increasing. There's a community I've been to. I just met him here. Friday, he's my colleague from Nigeria. Bodo community. If you drive into that community, the biggest pastime every weekend is burials. Right? It's an oil-producing community. So you drive in there and you see posters. Oh, my slide is up. I better just forget it. I have so many slides. Just keep going. I'll tell you when to stop. You know, so Bodo community, you drive in and you see posters. Okay, hold on there. That's one of the communities in Ogoni land. This is what parts of the Niger Delta looks like. 7,000 kilometers of pipelines have been buried in the swamps, the creeks, and the farmlands of the Niger Delta region. As routine as clockwork, almost on a daily basis, these pipelines rupture. Hell, they have been there for 64 years. Many of them as old as 64 years were being replaced. They rupture and they spill and they destroy farmlands. You don't know the effect, the health impact of oil spill until you see one. A few barrels of crude oil spilled into the river sends thousands of fisher folks into starvation immediately. If the spill happens on land, farmlands, one whole year of crop dies instantaneously. And there's never a time there's no oil spill in the Niger Delta region. As I speak to you, there's an ongoing oil spill. There's always an oil spill in the Niger Delta region. There are oil spills everywhere as we speak. Next slide, please. You know, and of course, I've spoken about gas flaring already. Gas flaring does not continue because there is no option for managing associated gas. It continues because the oil sector has decided that it is more profitable to poison the health of people than to harness the gas and manage it in a more sensible manner. The diseases that gas flaring causes are enormous, right? It's also important to know that gas flaring has been illegal in Nigeria since 1979. At least 9 times the government has moved the deadline on gas flaring because the oil companies blackmail the government and tell them, listen, if you stop gas flaring, oil production will stop and you get no money. And they move it 9 times. The last deadline was in 2020. It was moved again for a World Bank for 2030. And now they are saying 2050 with net zero target. Gas flaring will never end. The poisoning of community people will, continue almost ad infinitum. Next slide, please. So in 2016, we had to deal with this. Another fallout of hydrocarbon extraction in the Niger Delta region. It's called soot. We woke up one morning and we saw soot everywhere. If you touch surfaces, window, your bed, and so on, you see this. It's a combination of artisanal refining, gas flaring, and the refinery in Port Harcourt City that has, saturated the atmosphere and given rise to this. Assessments indicate that more and more people living in the Niger Delta region are suffering respiratory illnesses. An expert has said that in the next 15 or 20 years, there will be an increase in the number of birth deficiencies, children born with deformities on account of black soot. We've been breathing it since 2016. I'll probably breathe it when I go back to Port Port Harcourt. Next slide. And the impacts of oil extraction, right? The direct impact is flooding, right? And this was in 2012. We saw the first massive flood that broke with known patterns. Whole communities were inundated in about 7 feet of flood water. I took that photograph in 2012, and an octogenarian said that he had never seen anything like that before. But since 2012 up till today, we have seen an increase in flooding in the Niger Delta region. One flood is ongoing at the moment. Next slide, please. So I'll show you a few exciting images. I took these images myself when I visited the flood locations 3 weeks ago. This is an oil-producing community, a place joint Krama, where Shell has extracted crude oil from for the last 64 years. This is what it looks like this minute, today. This picture is 1 week old. Next slide. Here is another one. Next slide. And another one. Next slide. Do you know what that is on the table? That's a pharmacy. That's where the people who are devastated by floods have to depend on for their medical care, because the company, the state government, the federal government, and local government have failed to provide for the health needs of the people, and so they have to make do with what they have. That's a health center right there on the table where thousands of teams have to go to for medical services. Next slide. I know my time is almost up, so I'll just try and wrap up very quickly. But when oil spills into farmlands and into the forests and into the swamps and into the creeks, it does not only immediately cause health harms on the people, it does more than that. Because for a community where healthcare is hard to reach and unavailable, the forest is also their pharmacy. The forest is their source of medicinal herbs. When you destroy it, you take their health away from them. In a place where the government has failed to provide healthcare, the people have for generations depended on these communities for healthcare. And when oil spills, the whole hospital is also gone. Next slide. I can see she's moving nearer, right? But let me conclude on this slide. Let me just conclude on this slide. Nigeria has got probably the worst health indicators in the world. Life expectancy in Nigeria is somewhere around 54, 56, right? But in the Niger Delta, where oil is extracted from, it's 46 years old, about 10 years lower than the national average. So my friend Friday is almost 40. His time is almost up, just like mine is. Thank you very much.
Thank you so much, Ken. That was a very quick fire, very compelling list of experiences from your community. We really appreciate you bringing your personal story and the stories of the people that you live with here to the COP. Next, we're going to hear from two incredible women who are working on the impact of air pollution from fossil fuel burning on our health. Dr. Purnima Prabhakaran is the director of the Centre for Environmental Health at the Public Health Foundation, India. She's a medical doctor, epidemiologist. She leads a huge program of research on the environmental impacts on our health. And Purnima is going to update us on her latest research on the health risks of air pollution from fossil fuels.
Yeah.
Does that work?
Hello? Yeah.
Nice.
Thank you, Jane. And very hello everyone. So moving from that very compelling story Ken shared with us, I will take you into the more poignant story that I have from parts of India where we are seeing combustion of fossil fuels impacting the health of our populations. Next slide, please. So thank you for talking so much about the gaseous pollutants. So all of us know the combustion of fossil fuels, right from the extraction, the transport, the combustion, and the delivery of the effluents into not just the air but also the surrounding water bodies, impacts communities, the vulnerable populations that live in the vicinity of these power plants. And in India, the country where I come from, 70% of our electricity comes from the combustion of fossil fuels, coal. And the price we pay, this is what we want to bring to your attention today. Next slide, please. So I don't want to preach to the audience, but just to get us on the same page over here, combustion of fossil fuels can give rise to both particulate pollutants, what we know as PM 2.5 and PM 10, as well as all the gaseous pollutants that we heard so much about. And I want to focus on the particulate pollutants because those are the ones that are causing serious hazard to human health. Next slide, please. Why? It's because of the size. So the picture that you see at the center is the hair follicle. And the dimension of the hair follicle is about 50 microns. Particulate matter, PM10, is one-fifth of that. And if we're talking about particulate matter 2.5, the real culprit responsible for health impact, it's a fifth of that. So think about what happens when we inhale these particulate pollutants, what's the impact on the human health. Next slide, please. So there you go. Because of that ultra-fine particle and the size of that particle, we are easily inhaling this every second that we breathe. And it enters into the human respiratory system, down into the nasal passages, and you have this beautiful sculpture here. You know, the lungs, the respiratory system of the human body. But what happens beyond that, I want to show. Beyond this point here, you know, intuitively we think that the impacts are on the respiratory system, the lungs. But beyond this point, we have the particles enter the systemic circulation. So the medical doctors here will understand what I'm talking about. So beyond the pulmonary circulation, there is a mix of the blood. And so the particles cross this barrier and enter into the systemic circulation, which essentially means every part of the human body. So next slide, please. So beyond the impacts on respiratory health, we have particulate pollutants impacting, literally just focus on the human body picture over there, every organ in the human body, the brains, the heart, and if it's a pregnant woman who's being exposed to these particulate pollutants, you can have impacts, adverse impacts on fetal life. And those impacts really carry on into the growth and development phases of the children. So really, pollutants coming from combustion of fossil fuels in India, the ambient air pollution, as we call it, is responsible for 1.2 million deaths. Jane, you were talking about 7 million or 9 million. These are numbers, but in India, we contribute about a quarter of the global mortality from ambient air pollution. Next, please. And the problem with this is that these ambient particles, you know, are responsible not just for acute respiratory illnesses, but also chronic disease. And India is already a country that is vulnerable to chronic diseases, lifestyle disorders, cardiovascular cardiometabolic disorders, diabetes, hypertension, stroke. And here is the air pollution becoming now the top of the table risk factor for non-communicable diseases. It has been declared top of the table risk factor. Next slide, please. So this is just a graphic to show you the impacts on various body systems. So you see on the top, on the left over there are the impacts on the pulmonary vasculature, the lungs. And as you move this side, you see the feet over there. That is the gangrene. That's because the particles have entered the really distant parts of our vasculature. So you have peripheral vascular disease, impacts on the brain, you have impacts on the heart, and a whole lot of intermediate risk factors, hypertension, diabetes, and obesity. And this is not good news for a country like India, where NCDs have been a big problem already. Next slide. So I just wanted to show this slide to show that this does not stay within a generation. So the impacts of exposure to ambient particulate matter, of course, have impacts on every organ system in the body. But if this is the pregnant woman who is being exposed at fetal life, if there is a transfer of the particles across the placenta, you have impacts on fetal growth and development. And that is why we're talking about the intergenerational transfer of exposure to particulate pollution. Next slide. So what are we doing? What can we do? Are we going to prevent these children who are living in the vicinity of these coal-fired thermal power plants from living their lives, stealing their childhood? And I keep looking at that screen over there, the poignant story of little Ella, and you know what happened with her? We have not learned our lessons. We are still doing the same thing over the same mistake over and over again. Next slide. So don't worry about this slide, but just to show that this is actually the biological pathway, you know. So whether it is a pregnant mother who's being exposed to particulate matter, on the other slide you have children who are already born and in early life are being exposed to particulate matter. Down there, you see the health outcome. And the health outcome is increasingly the evidence pointing to neurocognitive development. We have affected mental health, we have cognitive impairment, and we have child growth and development being affected across the board. So we are impacting the entire demographic, the future of our populations. Next slide. Yeah, next slide, please. So, so I'm just going to rush through these. This is again from literature, the evidence base that is coming next. Just go next, yeah, please. So this is actually the evidence that's coming from scientific literature, and all of this is coming from developed countries, you know. What particulate matter, polycyclic hydrocarbons, what do they do to the neurocognitive development of our children? And to that, all the confounding factors of socioeconomic status and all the other sources of air pollution. Being proximal to road traffic, for example, is another exaggerating factor. So just to conclude, what we are seeing, next slide, please. Yeah, there's more evidence from literature. Next slide. And just my key takeaway points that extraction, transport, and combustion of fossil fuels has serious adverse effects on the health of not just children, but adults and populations everywhere. And it's not just from the direct pollutants, but also because of the pollutants entering the water bodies and other ecosystems. And really, what we need to do is to take action right now to move away from the use and dependency of fossil fuels, giving subsidies, and moving to renewable and cleaner forms of energy. Thank you, Jane. Sorry if I...
Thank you so much, Dr. Purnima Prabhakaran. I mean, all of that you were saying about the impact directly on children of this is, I know, something that Bavreen Kandari, who is a hugely inspirational advocate for clean air that I've been following closely for years, has been working on and is an inspiration to you, I know, because of the experience with your own children. Bavreen is working on the Fossil Fuel Non-Proliferation Treaty and also runs Warrior Mums in India. And I wondered, Bavreen, if you could tell us a little bit about your personal story and what you're working on, and especially the current situation in Delhi, because I know that air quality right now is extreme.
Yes, I just keep repeating that, but it just doesn't, it's like now, even now when Jane asked the number of, deaths that we are seeing with the air pollution, it's just that it's surprising that everyone should know it because it's just being said so many times, and everyone needs to know this and jump into this because it's actually a fire and it's for our children. Dr. Purnima said everything. I'm not going to get into any figures and data and the technicalities because we know it. We just have to believe it. The air is invisible, so we don't tend to take it that seriously. And I'm now sitting here from one of the most polluted city of the world, and our children are, my daughters are 18, and as they were born, they were precious babies, and they were born in the 6th month, so very premature, and we'd almost lost them, but God was kind, and when as they were growing, we started seeing these initial problems of running nose and coughs and things. So this was an initial signs that made me. I was doing a little bit work on clean air, but obviously we were not experts, and trying to find more support from doctors and scientists to see what this was, and that led us to a few of us to kind of a research that this is not an allergy. Every elder in the family would say, oh, this is an allergy, because when you exit the country or the city, it's just gone magically. Otherwise, for months you are on antibiotics and medicines or medications. In India, we do a lot of these home remedies, and you tend to do that. So this brought us, of course, to the air pollution, and over the years, then the air pollution and what was it, combustion of fossil fuels, which we were learning from, various sources. And then this was about being from an elite home in a comfortable, space, which is very, very small number in my city and in my country. The masses are, of course, there on the on a very different level. They're in slums, or they're in open areas, or under the flyovers, and that's the reality. Like Dr. Purnima also mentioned, the thermal power plants where the children are living, because now we were working with them, and I could see that they were terribly victimized, because there we have the lung tests, and we were trying to find more evidence as to how it was. Even in my city, of course, I mean, coming to fossil fuel is what, for me also, it's my latest passion to be exposing that, because in my country we talk of air pollution, but we don't talk of the coal, we don't talk of the fossil fuels. And but we have a waste to energy plant right in the middle of a city. So when you saw fly ash there is this fly ash. This is a residential colony there, a hospital there, a university there. So this is happening now, even now. I mean, this is 10-year-old, and so obviously our policies are not going the right way, and we are expanding on such projects. And coal has been, we are mining, we are one of the latest things in Chhattisgarh, we are mining huge forests. And so the pledges that we are making of phasing down, they are not really working, because of course maybe they want to, and it is a challenge also for the government, because we are a coal induced country. It's important for us, it's an important source of energy for us. But when it comes to children and their future, and that's what we are here as parent delegation, it's kids first. I mean, if you tell me that, if tells anybody says that you want to choose poison, or you want to choose a little tougher path of going and picking up something right, you will not give poison to your children. And that is what we are doing. So one has to think like that. And it's so funny that it's one of those testing moments for me. My daughter's not feeling well, and she just fainted, and I'm just looking at my phone. Sorry. So so that's what I mean, that that 1 second of this thing just kills you, and you're so disturbed, and so this thing, and then how do you leave your children on a planet like this? And the fossil fuel treaty has been something very close to us, and we learned a lot from the treaty. And that is something I think we all need to demand. We all need to ask our governments to bring it into their policy and take it the way it's being said. It's something that we cannot dodge. We have these some postcards here also that have the QR code, and please, as parent, as a mother, as a sister, as a brother, please sign this and show your consent to that, to no to fossil fuels. And we just have to take this by the horn, or whatever they say, because it's not going to work, because we cannot live with excuses anymore. I just want to, because I know I'm short of time, and my mind is a little thing. I'll just read. So one thing that I ask would be at the COP, asking them to take on the treaty, would be to ask the wealthy nations to pay for all the damage that they've done and they are doing in terms of climate crisis in our countries, in the global south, and the number of loss and damage, the deaths that it's causing, of course. And world leaders have to they have to now just choose. There is no way. In fact, I was saying in all these plenaries and all, where we are not allowed for whatever reasons. I don't know why we're not allowed. First time I saw a COP that they've not even permitted us to come in and even hear it. So why don't they just ask, okay, raise your hands who do not agree to save the 7 million lives or 8 million lives or 9 million, whatever number, who do not agree. Let them raise their hands. Because if they don't raise their hands, then we know that they are the ones, and they are our children's murderers. We have to kind of bring them on. So thank you, Jane. Thank you.
Thank you so much, Bhavreen. I mean, there is absolutely nothing more compelling than the story of a parent who's worried about their children being able to breathe. And I hope that your daughter is all right. If you need to leave, please feel free. I mean, the work that Bhavreen and others have been doing on the Fossil Fuel Non-Proliferation Treaty is amazing. it has made huge sense for a lot of people in the health community to sign a letter adding their voices to this call. And nearly 200 health organisations and several thousand individual health workers have now signed the letter. The call was actually even endorsed by the WHO with Director General Dr. Tedros calling out the continued use of fossil fuels as an act of self-sabotage. So please do pick up one of these flyers, check it out, and add your voice to this call for a move away from fossil fuels at the end of the session. So now we're going to open things out and look at the broader harms of fossil fuels with two more incredible women. Sorry, Ken, that you're so outnumbered. You're enjoying it. First, turning to Marina Romanello, who's the executive director of the Lancet Countdown. And for a long time has been a health and climate researcher at several universities. I won't list them all. Currently at UCL, and has also spent time in the NHS with UK researchers developing the NHS's net zero commitments. So Marina, could you talk us through the main findings about fossil fuels from the 2022 Lancet Countdown?
Thank you so much, Jane. And first of all, it's really humbling to be sitting here with these people that are actually fighting the fight on the ground. So thank you so much for doing that. I hide behind numbers in general. So I'm going to show you a bit about what we found in our latest report. And these are the numbers that I'm so delighted to be in this panel, because these are the people that bring them to life. We try to quantify things, but numbers don't say much. What says a lot are these stories here. So thank you so much for sharing them. Next slide, please. So for those of you that don't know the Lancet Countdown, just as a very brief introduction, we are an academic collaboration, a research collaboration that brings together researchers from around the world. We have regional centers now in 6 different countries trying to expose the intersection and the links between climate change and health in different world regions. I'm going to show you today some of the key findings of our latest global report that is the product of 99 researchers. We're just under 100, so if anyone wants to. From around 51 institutions. Next slide, please. Annually, we pull these researchers together that come from many different walks of life, many different disciplines, to produce these annual reports that get published in the Lancet just ahead of the negotiations, with 44 indicators that monitor both the health impacts of climate change and the health opportunities or missed opportunities of climate action. And this data, again, the numbers that we're hoping that those sitting in those other rooms can listen to and can act upon, but that you've heard what those numbers mean in these stories here. Next slide, please. So the latest finding of our report is perhaps unsurprising given the panel. That is that we have a fossil fuel addiction, and we've seen that very clearly this year. That is not only exacerbating the health impacts of climate change, but is now also reducing our capacity to cope with and to respond to other crises that we're facing. So we're not only dealing with the climate crisis, we're also dealing with a war in Ukraine, with a cost of living crisis, with an energy crisis, with a food crisis. And climate change is just acting to exacerbate the impacts of those other effects that we're seeing on our health. Next slide, please. So for those of you that had a very, very good vision, you can probably tell me what the numbers are. I don't expect you to see this. I just dumped there some of the indicators that we have on the health impacts of climate change. And the only thing I want you to see there is that everything is going upwards. And that is not good. Up is bad. We're seeing an increased exposure of vulnerable populations to heat waves in people over 65 years of age and very young children, to which heat stress puts them at acute threat and is a life risk. We're exposed to 4 billion more present days of heat wave exposure in the latest years with respect to a very recent baseline, actually. We're seeing that heat exposure is also reducing our labor capacity and therefore is undermining our livelihoods by reducing our income. And that is affecting now people which are also facing a cost of living crisis and are struggling to afford their basic energy needs. So again, coming to compound those other crises that we're facing. We're seeing food insecurity on the rise. Labor supply is being lost mostly in the agricultural sector, that is the teal color that you see there. We're also seeing extreme weather events affecting our crops. We're seeing supply chains disrupted. And we're seeing that the increasing heat waves is directly correlated with almost 10 million more people self-reporting that they could not afford the food that they needed in latest years with respect to our recent baseline. We're seeing extreme weather events on the rise. More and more extreme weather events are becoming lethal. We're seeing that exposure to wildfire danger is also increasing as a result of the drier temperatures, the hotter temperatures, and therefore people are being put at acute risk of wildfires that not only affects us through direct burns, obviously, also affects our infrastructure, disrupts the essential services that we need, and exposes us to air pollution from those wildfires that have enormous effects on our health, as you have just heard. And we're seeing also that infectious diseases are being spread more easily because of the changing weather conditions. We're seeing malaria in highland areas of Africa that were before relatively protected from malaria. We're seeing vector-borne diseases shifting more northwards and southwards in the globe. And that means that new populations are being exposed to hazards that they're not used to dealing with, and our health systems are not used to facing. So I'm showing you this. I know you all know about climate change, and I know you all know about the health impacts of climate change. But last year was the first year that in a COP document we had fossil fuels mentioned. And this is the result mostly of the continuing burning of fossil fuels. True, land use change has an influence and affects emissions. We have emissions from the agricultural sector, but by and large, the culprit of this is the fossil fuel burning, and we should not forget that. Next slide, please. But beyond that, as you have just heard, the burning of fossil fuels is also affecting our health directly. And what we're looking at here is the extent to which in the household sector we have or not access to clean energies. This comes, the data on the graph that you're seeing comes from the SDG 7. The SDG 7, as you know, is kind of one of the SDGs. We also have an SDG on health and another SDG on climate change. But this is SDG 7, and I think it's kind of both. We're seeing that just 57% of all the energy that we consume in the global household sector comes from clean fuels and technologies at point of use. And what I'm showing you there, again, from the SDG 7, data collected by the WHO, is the extent to which we're being able to access in our homes clean fuels and technologies for cooking. In the rural global sector, only 48% of households have access to clean fuels and technologies for cooking. That means that 52% of households are still burning dirty fuels in their homes, mostly biomass, but also oil and solid fuels. But there's a big divide in Human Development Index countries. We're seeing that those countries with lower levels of Human Development Index, those that are the most vulnerable countries, have less access to these fuels, and that is the human face of energy poverty. Just 5% of the rural households in low Human Development Index countries have access to clean fuels and technologies for cooking. And what that means is that those peoples are being directly exposed to dirty fuels in their homes. And for the first time this year, we try to quantify what that means for air quality inside people's houses, where people spend most of their time, especially children, and especially women in many cases. Levels of PM 2.5 air pollution that you already heard is the biggest and most dangerous pollutant, exceeds the WHO guidelines by 30 times. People are breathing air that exceeds 30 times WHO guidelines inside their homes. Now we're seeing a cost of living crisis and energy crisis and rising energy costs. And what that means is that even in wealthy countries like the UK, people are going back to burning dirty fuels and biomass because it's cheaper. So because we're so addicted and we were so late in the adoption of renewable energies, we're still heavily dependent on a fossil fuel market that fluctuates, that is very sensible to geopolitical conflicts, and therefore we're today still using biomass rather than clean energies, which can be made available at point of use. Next slide, please. And perhaps this is what annoys us the most. We're seeing that governments and companies are still prioritizing fossil fuels, even though they know this data. The first IPCC report already talked about the health impacts of climate change. Next slide, please. Next slide, please. The 86 countries that contribute to about 90% of all emissions, 80% of them are still subsidizing fossil fuels. And the total amounts that they're allocating to fossil fuel subsidies is $400 billion in 2019 alone. We still have not delivered the $100 billion that we need to promote a healthy and just transition. Next slide, please. And when looking at the fossil fuel companies, if you enter BP or one of these other fossil fuel giants, they probably look like a renewable energy company. But when you look at their strategies today, what they're doing today will take them in 2040 to exceeding the levels of emissions compatible with the Paris Agreement by over 103%. So their strategies are incompatible with a healthy future. Next slide, please. I think it's fine. Next slide, please. That's the last one? Okay, brilliant. That's it. Thank you.
Thank you so much. A huge amount of data to digest there, so I'd suggest people go look up the report on, is there a Lancet Commission website where they can find all of that in detail. So finally to Patty Ree, who's the Global Methane Hub's Partnerships Officer. I know that Patty spent more than 20 years at NASA's Jet Propulsion Lab trying to herd various CAT scientists, government people, researchers, industry leaders, and policymakers, and to get them to work together on climate solutions. So maybe Patty should have been moderating the panel. But Patty, I wonder if you could tell us what the health harms of other short-lived climate pollutants are that we haven't heard a huge amount about, and the Global Methane Hub's work on that. Thank you.
Thank you so much. It's a pleasure to be here and always humbling to hear from the frontline community and the researchers who make Jane and my work possible. We are, just like Clean Air Fund, a re-grantor, and our whole job is to support the community, support those who are trying to work in the front lines to really win the battle. I'm going to say something that is probably contradictory to everything we've been talking about so far. Methane is not harmful to your health. Methane is detrimental to the Earth's health, but your personal health, it is not. So then why am I sitting up here? Methane is always found as a it comes in packages. It is always found with other pollutants, 21 actually to be exact, of health diminishing air pollutants. So when you identify and mitigate methane, the conversations that we're having up here about the detrimental impacts of health will also be diminished. So our focus, while it is about trying to bring about the well-being of the health of this planet. And by the way, that's 85 months we have to do this. It's 85 months until 2030, until the point of no return that we've been talking about. And methane is the only way we will actually bend the curve and bring global warming down. We need to do work on carbon and all the other super pollutants, but including methane in it is our only solution to actually make a U-turn in our fight against global warming. Our whole focus, while again, is methane, it cannot be sorted out without talking about the impacts of health, talking about environmental equity, talking about environmental justice, because who will be most impacted by methane emissions, especially in the fossil fuel area, are the frontline communities. Where are the wells? Where are all the leaky pipes? But that doesn't mean that all can escape from the impacts of methane and its co-pollutants. Here's a fact, a research that came out of Harvard and Stanford that shows if you have a gas stove at your home or a gas water heater, it leaks. It leaks all the time, even when you have it off. So those, without us knowing, are having an impact in our health. So what is our focus in trying to then bring about mitigation? There's been some amazing technology developed with researchers and work of the communities that allows us to actually pinpoint now, using satellite and airborne data, exactly which pipes are leaking and how much. I'm going to go back and nerd out a little bit with you for 30 seconds. So methane, how we learn to detect methane actually is when I work for NASA, that's how you look for signatures of life in other planets. If you can find methane in other solar systems, that's how you know there's actually possibility of life. We've taken that instrument and turned it and looked down on Earth to look for methane. And because our instruments were so sensitive in being able to detect methane in planets, in solar systems far, far away, imagine what we can do here. We can tell you actually how much each of your car and how much each of your household is emitting methane. Now, the technology that has commercialized and is available and that we're using to detect methane is right now single point source emissions. Each pipe that is coming into your house, and depending on how much is emitting, we can tell you how much is leaking. And we're working with, so there are agencies like NASA, there are organizations like Carbon Mapper, GHGSat, working to mitigate methane using these types of detection purposes, which again, if we can really bring that about, the mitigation, that just naturally will bring about positive change to health impacts that the co-pollutants have. I don't want to go on longer because I know I would love to get some Q&A in, but again, our whole job is to be the funders, the boosters, and the catalyzers of trying to figure out how do we bring about methane mitigation, which will allow for solutions to some of the problems we're talking about here.
Thank you so much, Patty, and for leaving us a bit of time for questions as well, which we're now going to take from the audience. Because this is being live streamed, you'll need to have the microphone, and because we're running quite far behind time, it would be great if you could stick to a question rather than a long comment, so 30 seconds max. And tell us before you tell the question your name and your organization. So I'm going to come to Collins and then down here at the front, and we'll then see if we've got any more time for questions. Yeah. So name, organization, and a brief question.
Thank you very much. Collins Gamali Hodoli, University of Environment and Sustainable Development, but I'm representing Urban Better. Actually have a lot of questions. One, we understand that...
Just the one.
Just one. That's a problem. Sorry. Can I ask two?
No.
Wow.
Restrain yourself.
Right, so in 2019 alone, we lost about 1.1 million deaths in Africa due to air pollution. And more than 0.5% of these were just due to household air pollution, which means that we understand the sources. Now, the key part of air pollution control is to be able to identify the sources, and studies have shown all of these. Why are we not fueling the energy transition, particularly in environments with very limited resources, so that we can reduce the impact of air pollution on public health, particularly kids? Thank you.
Thank you so much. And then we had one down here.
Thank you for your presentation. Thank you.
Yeah.
It is? It is?
Yeah,
okay.
it's working.
Thank you for your presentations. My name is Safed Kadovic. I'm from the Islamic Society of North America and the Parliament of World Religions. Causality, attribution. Anyway, any possibility, I like this information about the methane. If I can track what's happening to your daughter to a particular direct cause, not the aggregation of data, I allow lawyers to do their job, which is to go after legally those responsible for death and murder. Any way we can work on this, any way that this can come about, attribution. This particular refinery caused the death of this particular person or can be implicated in it. Thank you.
Thank you so much. I'm going to take two more, one here, and then I'm going to come to the panel. I'm afraid that will be that. Come to the panel for closing remarks, and then we'll close the session. Thanks.
Thank you so much. My name is Abdul Hadi. I am from Afghanistan. And you know, Afghanistan is one of the more air polluted country, which is affected more. And every year we are losing thousands of people because of air pollution diseases. You may saw the reports, or you can see, search for the reports. So Afghanistan with no resources, how we can reduce air pollution effects or impacts? This is one question. The second question, our suggestion please include Afghanistan in your research or anything that we can do in our country. Thank you.
Thank you so much. And one final question from the front here.
Yeah, hi. My name is Josh Carliner. I work with Healthcare Without Harm, and it's a question for Ken. Ken, yesterday was the 27th anniversary of the execution of Ken Saro-Wiwa by the Nigerian government at the behest of Shell Oil. And I was struck by your presentation in that it felt very similar to what Ken was talking about 30 years ago. And so my question is, what's changed and what needs to change in the Niger Delta to move beyond the situation that you're in now? Thank you.
Thank you so much for those questions. So I'm going to come to the panel one by one. Obviously, Ken has a specific question for him. If the other panelists could take one of those other three, that would be fantastic.
Thank you so much. What has changed? Not much. It has even become worse. What needs? The kind of thing Ken Saro-Wiwa fought for and got killed for is still happening in the Niger Delta region, and the power dynamics led by the oil company still exists. In fact, it has gotten even stronger at the moment. And the same level of repression, human rights abuses, suppression of dissent and all that is still ongoing till now. In 2019 alone, my organization documented 3 cases where the military working for oil companies invaded and bombed Niger Delta communities. In fact, in May 2019, one particular community called Udoda was bombed by air, land, and sea. A tiny unarmed community just to allow crude oil flow. So nothing has changed. What needs to change? What needs to change is this kind of forums, right? We need global and international support, working closely with frontline communities, making just one call: leave the oil in the ground. 65 years of oil extraction has led our environment, our health systems, everything. Nigerians have become poorer for it. Niger Deltans are worse for it. We've seen nothing oil has given to us, and so our argument is leave it in the ground. If you do not bring this thing out, then you will not burn it, then you will not mess up the planet, then you will not destroy our lives. Leave it in the ground. That's what needs to change.
So just to take on from the gentleman's question at the back, point taken, it's a very pertinent issue that you raise. But when we're talking about air quality management, we need to look at the sources. Arrest the sources, and you are better off for sure. So depends on the context, the geography. Even within my country, we are like countries within a country. In different parts of the country, the sources are very different. So you need to address the sources. And in your situation, the household use of coal or the biomass, they contribute a big proportion of ambient air pollution. So transitioning to cleaner forms of energy for cooking, for heating, I think it's a big the narrative has to change. And I think if we start talking about the health impacts of using such dirty fuels, I think we will start to make a change. And I think that's the momentum we all need to build on.
Yeah. So, I'll just sum it up in one sentence that something that is close to all the parent delegation. They're here, Maya and Ju, Oli, that catastrophe is not a matter of fate, it's a matter of choice. And we need to work on that. That's why each one of us will have to step forward and sign and demand that our governments will sign the Fossil Fuel Proliferation Treaty, Non-Proliferation Treaty. And that's what we need to do. Yeah.
To the gentleman at the front, I think we need to chat, because there's a lot that you can do without direct attribution, just knowing the amount of emissions and knowing what is the impact. And we've been speaking with some strategic litigators on that and how to make that happen. So it would be great to have a chat with you. And to the other gentleman on the back, I think in terms of access to clean fuels in the domestic sector, particularly in remote areas, that's a huge opportunity that has been delayed, not by accident. And what has to be taken into account is that we have to be very careful in the adoption of renewable energies, that we don't generate technological dependence north-south, because that would leave us in the same position now, where vulnerable places still depend on markets that are and products that are developed elsewhere. So empowering those communities to get access to locally produced renewable energy and local technologies that are produced locally and that are resolved locally is crucially important to reduce energy poverty and indoor air pollution.
Our theory of change as a funder is very simple. Bring about complete transparency to methane emission so we can show you where the problem is and you could be empowered to take charge of your community and act upon it. We are working with incredible minds, university researchers, other foundations, places like Google have all come together for that one purpose, to create absolute global transparency for methane mitigation. So we hope to have platforms starting in the next 6 months up and available. We're going to start with waste because we know that is a very much an easy to solve problem and a localized community problem. But that's what we hope to do, bring for you absolute transparency that you can be empowered and aware to take action where you need. Thank you so much for the opportunity to be part of this panel.
Thank you. And did one of you want to take the question here about what to do in a resource-constrained environment like Afghanistan?
I'll take that just because that is partly what we do as a foundation, right, Jane? We try to close gaps. So I think it's important that we talk to folks like you to understand where that hole is and see how we can help fill it, or at least catalyze to get action started in your community, in your region, in your state. So I would say let's talk and see, you know, what we can start in that area.
Just to add one more thing, in resource-constrained environments and low-middle-income countries, in general, the conversation has revolved around loss and damage and adaptation. But that means that the gap of adoption of renewable technologies is getting bigger because we're putting all the pressure on mitigation in high-income countries. And it's those countries that are developing new technologies, getting up to speed with the new economic transition, and leaving behind low-middle-income countries. And the injustice of that unjust transition will be perpetuated even if we manage to meet the commitments of the Paris Agreement. So allowing low-middle-income settings to get just access to these renewable technologies is crucial. And there the voice of those settings is essential.
Thank you all to the panelists. So, I mean, we've heard a huge amount about the power of data and transparency. We've seen the power of data and the huge power of stories and lived experience. And I really thank you all for coming and sharing your knowledge, your research, and your passion with us, because that has come through loud and clear. We're going to finish off right at the end of the session with another video about the projects in the Indigenous community in Alberta as you leave. But a quick plug for another partners session. If you'd enjoyed this one, there's a session on Friday, November the 18th, so a week today, from the Health and Climate Network. And it's called A Just Energy Transition for a Healthy, Fossil-Free World. And that one will be on in the SDG Pavilion, 8:30 till 10 on November the 18th. And I think there's flyers down here for it if you want to grab one to remind yourselves. So thank you all so much for being such an engaged audience. It's great being in a packed room for these kinds of sessions. Please don't forget, if you want to take individual action, as Vavrine says, this is a choice. We all have to demand action, and one way that you can do that is by picking up a flyer, checking out this fossil fuel non-proliferation treaty. And thank you so much again to all of our speakers.
The Lubicon Cree have been here since time immemorial. Indigenous peoples have a very intimate connection with our homelands here in northern Alberta. And what we've seen instead is industry coming and essentially taking over our lands and really exploiting them, and it's had a detrimental impact. We see companies digging down into the earth, trying to extract the very last drop of oil. But instead, we can start looking up. We're bathing in sunlight all around us, and yet we don't utilize that energy. And so that's why our community has decided to install solar. pretty amazing to see this project go up. A lot of the community members and the young people are working, they're getting hands-on training right now. It's really amazing to see how proud people are of it and how it's a community project, because all of this has been through the blood, sweat, and tears of the community.
Well, this project matters to us because it kind of represents who we are and where we're going in the future. When you see the work, I can say that I did that. I took part and I did it right. So there'll be a lot of people seeing it every day. I can tell people I worked on this.
I know in a lot of the ceremonies and the songs, the sun is praised. Even the project name, Bita Pan, means the coming of the dawn, and it's coming of a new era. Era where we use, energy that's not devastating to our environment. In getting this solar project going, we are leaders in solar power, and that's what we're teaching our youth. They have to learn how to operate it, they have to learn how to maintain it, and they already know how to set it up. So if any of our neighbors in the surrounding First Nations or Métis settlements want to start a solar power, we can be there to help them get it going.
who were our executive directors. And so they quickly took us out of the model of education and into the model of campaigning. And what we've found in general is that choosing an evidence-based target, making sure that your team is really focused on that, having messaging, policy documents, and mobilizations aligned with getting that done, and then achieving that win is in fact the way to increase the amount of resources that flow to your programs. People get excited, they get inspired by the wins, more money comes your way, more people come your way, you get known as somebody, as a group that gets things done. And that's not something I learned in medical school. And so we're hoping to show you some of the things that have worked, and we're going to be working with some of these other wonderful people from around the world who are also doing things that are working. So we'll have colleagues from, we'll have Martina from Réclamer Face aux Fruits, and we'll also have Ken, who is in the last panel from We the People, and then Maria Nera and Mohamed Issa will join us in response, and we'll have a question and answer. So next slide. I'm just going to put my mask down. I think she's ready. Next slide. Great. So this is this picture is actually of the place that I call home. So this is the Mackenzie River Delta. It's 3 degrees Celsius warmer than when an 80-year-old elder was born. That is a river that is the outlet of some of the water that flows past the oil sands. So water actually goes up the map. So what that means, and this is a reality right now, I just had a conversation with Chief Bill Erasmus about starting to defend this land from the possibility of having tailings ponds from the oil sands dumped into the river, because that would bring it all the way north, thousands of kilometers, and in fact could contribute to polluting the entire Arctic Ocean. So this, you can see that the water there is just freezing up. That is a highway for people in the wintertime. So it's how they cheaply transport building supplies. It's how they go out and hunt, how they fish. You can imagine this is a fly-in community. I have a picture of a $7 cucumber, like a cucumber that costs as much as the most expensive sandwich that you've ever bought here at COP. And so you can imagine that the cheapest protein, the most healthy protein, is actually what comes from the land. And so if all of a sudden it's really dangerous to go out on the land and you're liable to fall through the ice, 3 degrees Celsius is a big difference between solid water that you can walk on and liquid water that you can't. So this is what has motivated me as a community-based physician to do the work. And as you do this work, I encourage you to start your presentations with a slide of why you care. Because that's, in fact, an evidence-aligned communications technique. Yeah, next slide. So I now believe we actually have to reframe the entire way we look at health. Next slide. And that really all of health and healthcare is dependent on stability in the ecological determinants that underpin. So if this is stable, if the climate is stable, water is stable, soil is working well and able to help us produce crops, next slide, we can build and, next slide, we get to build the societies and the economic structures that give rise to our social and structural determinants of health. And when that's really stable, next slide, we get to build, staff, and supply the incredibly complex structures that are our high-income country health systems. Next slide. And when you do a literature review across countries, we find that overall health status is attributable only about 20% to healthcare and everything else to all of those determinants. Next slide. And so what that means is that the work we do in the hospital is not only very important but small proportion of overall health status, but it's entirely dependent on stability in the layers underneath. So I've spent a long time trying to get conventional mainstream medicine. I'm also on the board of the Canadian Medical Association. You might not be able to get on the agenda. It's hard to get on the agenda. You may show up in conventional medical health spaces and have people kind of like, maybe not laugh at you, but definitely gaslight you. Most of the time, they don't know what they don't know. And until you can get on the agenda, you're going to need to get good at making your case in a calm way, in a reasonable way, in about 2 minutes. This is the best way I've found to do that, because all of a sudden the crusty surgeons and the crusty emergency physicians, I'm an emerg doc, so I can say that, understand that we don't do this work despite being a clinician. We do this work because we are clinicians and we care about being able to provide really stable, safe, secure care. Next slide. And when I first started doing this, I didn't realize that people weren't doing as I asked because it made them feel sad. So I would go to the Canadian Medical Association General Counsel and they wouldn't listen. And so then the next time I would go back with more data. So at one point I was the only person who was showing up at the CMA General Counsel with an appendix of references for each motion. And then they still didn't pass the motions, and I couldn't understand why. And then I noticed that people were avoiding me and they were ducking into the bathroom when they saw me coming, and I was like, what's going on here? And I realized that what I was telling them about environmental threats, about what our children are facing, was making them feel sad. And so you've probably heard people say people don't necessarily remember what you told them, don't remember what you, the data you relay, but they remember how you make them feel. So just be really conscious that how you make people feel has a huge determination on what they're going to do. And so what I did at that point was I realized that I had to master my own emotions around this. I had to give myself time in nature, with my friends, with my children, exercising, so that when I entered those spaces, I could be strategic in the way I communicated, and I wasn't sort of spraying anxiety everywhere, because that anxiety, as we know from our clinical work, was transmitting to my colleagues. And it was making it difficult for them to cope with the information. So now when I am presenting this information, I actually go about it in a compassionate way, very similarly to when I relay a diagnosis in the emergency department. Next slide. Because people are going to be angry, they're going to be anxious. That's totally normal. Those are human reactions to bad news. And it's easy to be frustrated with it. But we're humans, and one of the aces we have in the hole as health practitioners is we're trained to deal with human emotions. Now, one great way to generate positive emotions is to talk about the co-benefits. So these are things where when we decrease greenhouse gas emissions, we also improve health right now. You've probably heard now in this pavilion so many ways that air pollution is really horrible for health. So essentially, any time we decrease air pollution, we save lives. And what we can do is bring those stories into decision-making spaces. So cleaner energy, active transport, making sure that we clean up our fossil fuel supply. We need to also empower girls and women, make sure that people have access to the family planning that they tell us that they want, access to education, plant-rich diets. Policymakers love to hear these stories, especially if you crunch the numbers and give them the data. Next slide. So we'll go through a couple of wins around this. This is former Minister of Health Jane Philpott. She's a family physician, ended up being Minister of Health. She put up her sharp elbows and said, when we develop our new food guide, we are not going to have closed-door meetings with industry. Know what we ended up with? An evidence-based food guide. It's the best thing. Next slide. So if you look at these two plates, this on the left is the Health Canada plate. On the right is the Eat Lancet Commission plate. They came out within 2 weeks of one another, so they were based on the same set of studies, and they look exactly the same. Now think about this. When I actually told Jenny Miller of the Global Climate and Health Alliance about this, she's from the US, she was like, in my country, ketchup is still a vegetable? Because of the huge influence of industry on lobbying. Next slide. And so we can, when I think about this, our Lancet Commission report last year, the policy brief, recommended adopting similar practices for lobbying with fossil fuels. If we can do it for food, we can do it for fossil fuels. This is an emergency physician, Eric Nopebart, who mapped the intersections in Montreal where the most cyclists were getting killed and injured. And he proposed an alternative map with the help of engineering students, showed up over and over and over to the municipal council meetings in Montreal until they all knew him. And once they know him, they trusted him. And so the mayor is implementing the alternative map, and they're redoing this in multiple cities in Quebec, and they're also redoing it. They're doing it in Vancouver. Next slide. Carbon pricing. I was here a couple days ago talking about this. Imagine trying to sell carbon pricing. You're trying to sell a tax. I was pulled into this work by an economist who was despairing at his ability to sell carbon pricing. And what we ended up doing was I went first and I gave the impacts of climate change. And right when everybody looked super sad, I was like, here's Doug. And so Doug would come and he would provide the treatment, which was carbon pricing. So instead of him talking about CO2, he wasn't a scientist, he felt super awkward. And instead of me giving a presentation where I didn't have an action item for people and I left them depressed, it worked super, super well. So we did that in the north, and then we started doing it nationally. And that's essentially how CAPE supported the implementation of Canada's national price on carbon. So this was me with Catherine McKenna a couple of COPs ago with the Lancet Countdown Policy Brief, where we had recommended that. The Canadian Medical Association, Canadian Public Health Association also supported this. And we ended up getting a national carbon price. It was challenged in court. We were interveners in all of the court cases. And when it was upheld by the Supreme Court of Canada, we were the only NGO invited to the press conference. So what that tells me is that the government valued the voice of health in that pursuit. We know that carbon pricing is one of the #1 things we need to get done. I think we could do that internationally. Next slide. This was one of the graphics we made. So diagnosis, health stuff, prescription, carbon pricing. Next slide. PARX, this is my lovely colleague, Dr. Melissa Lem, who can't be here with us. She's a family physician. She's the founder of PARX, which is a Parks prescription program. And this has gone viral. Family doctors can prescribe park time. We're partnering with Parks Canada. People like it so much that the government invested a little bit at first, and now they're investing a lot more. And at this moment where people are so stressed, it's super, super healing to be able to do this. Next slide. I'm not sure if this is going to play. Do we play it? Okay, next slide. Next slide. And so after that, so those are some of the campaigns that have already worked. And now we're going to hand over to Leah Temper, who is an ecological economist with a PhD that we're super happy to have on staff. And she's going to tell us about a win that we had yesterday for this campaign that she started a couple months ago.
Thank you. So yeah, what I'm going to talk to you about today is health movement, our movement in Canada of health workers against fossil fuel advertising. So this is a campaign being led by the Canadian Association of Physicians for the Environment. And essentially, we know that fossil fuels kill and will kill many, many more people than tobacco and then the tobacco crisis. And what we are urging the Government of Canada to do, and which we are also would like to urge the World Health Organization to do, is to put in place some of the same measures that have been effective in reducing tobacco use and deaths related to tobacco. So in Canada, that includes, for example, taxation. It included mandatory labeling. It included outreach and education campaigns for the public. And of course, what this campaign is focusing on, it includes comprehensive restrictions on the advertising of fossil fuels. When we talk about restrictions on advertising of fossil fuels, we're talking about, of course, for gasoline that you get, for oil and gas industries, also for gas-powered vehicles, and for utilities like natural gas in your home. And in some senses, it seems sort of obvious when we are in the middle of a climate emergency, and these products are threatening human and planetary health. But, you know, just to kind of say, for example, in Canada, it's extremely counterproductive to our efforts. For example, we are trying to phase out gas-powered cars. We're spending about $1 billion in Canada to promote zero-emission vehicles, while the car industry is spending about $36 billion on ads to convince people to purchase bigger and bigger vehicles. So in Canada, about 80% of the ads are for SUVs. The most vehicles that are about 30% more polluting, and 80% of the cars bought today are for SUVs. So we can see the impact that these type of ads are having on people's consumption. Maybe I'll change mics if there's another one. And then, of course, even more insidiously, we see how misinformation through advertising is obstructing climate action. And this was something that was very clear in the last IPCC report. They said that vested interests from advertising are kind of undermining public support for climate action in Canada. Next slide, please. So here you can see the type of ads that people are being exposed to. Ads that tell you that you can drive carbon neutral, that natural gas is clean. Next slide, please. And in June, what we did is we sent a letter to the government from 700,000, from organizations representing 700,000 health professionals, demanding a comprehensive ban on fossil fuel advertising, a robust regulatory response to greenwashing, and regulations that are mandating the disclosure of health and environmental risks associated with those products. Next slide, please. Other actions we've been doing is 1 month ago, we submitted a complaint to Canada's Competition Bureau, which is the federal body that's responsible for regulating false and misleading advertising and representations that companies make to Canadians to advance their business interests. And the complaint was against the Canadian Gas Association. They have a campaign called Fueling Canada, which claims that natural gas, which is more accurately termed methane gas, is clean. Now, we all know that methane gas is not clean in any sense of the word. Clean means free from pollution. And gas actually, of course, it pollutes in every single stage of its extraction, production. And, you know, there's increasing attention to the health impacts of burning gas in the home, particularly in a place like Canada, where due to the weather, you're kind of locked inside all year round and children are exposed. So we know there's a much higher risk of asthma exposure for homes with gas stoves. Next slide, please. So the good news is that yesterday we actually launched a press release to announce that we found out that the Competition Bureau will be investigating the Canadian Gas Association. So we've been covered in newspapers across the country, and you know, considering that this announcement came on the eve of this event in COP27, and also it follows sort of the high-level expert group report chaired by a former Canadian minister, Catherine McKenna, on greenwashing, where she was very clear about the guidelines for companies about greenwashing, specifically stating, for example, that no company can have a claim to net zero if they plan to expand fossil fuel extraction and infrastructure. So we hope that this sends a clear message to companies that they cannot get away with greenwashing. And meanwhile, we will continue to work with the Canadian government to make sure that there is a more robust regulations against greenwashing and against, this is an advisory statement from a Pathways Alliance tar sands company that is the, shows all the conditionalities to their carbon plan, you can see. And they're still advertising that they are moving to net zero. Next slide, please. So, we believe that, and I think Martina's going to talk a little bit more about this, there's already campaigns around the world that have been replicating what we're doing in Canada as a health worker-led campaign to ban fossil fuel advertising. There was a campaign in Australia that has already had many successes, and in the Netherlands they're also really bringing forward the health message. We feel that this is a really strong opportunity to use the power of advertising to make it clear that the climate crisis is a public health crisis, and I don't think that message is getting out to people. And we would also really like to see how we can work with the World Health Organization to replicate the successes that they've had based on their framework convention on tobacco, to ban fossil fuel advertising and to keep fossil fuels in the ground. And I like to end with this slide over here that, when you look at this picture of doctors promoting smoking camels, it seems really ridiculous and preposterous today. And on the right, you see the ad of the Tar Sands Pathway Alliance. This ad campaign is all across Canada, on the radio, huge posters everywhere that they are talking about clearing the air when they are the biggest polluters on the planet. So we really hope that the global health community can work together to stamp out this type of advertising. Thank you very much.
I think this one's working, yes. So next up is my good friend, CAPE President Joe Vipond. So he is an emergency physician in Calgary. He is, I think, one of the doctors in the world who knows the most about coal power phase out. And he's here to tell you how CAPE and largely led by him, particularly for the Alberta and the national part, have helped to decrease a whole heck of a lot of greenhouse gas emissions in Canada.
Wow. Check. All right. Well, I guess I can talk pretty loud through this mask, eh? So, how many people here are doctors? Oh, I'm fine. How many people here are physicians? Are there any physicians? We got one physician, two physicians. How many people are medical students? Do we have any medical students in the audience? We got medical students. We got nurses. Nurses in the audience. Excellent. Any other health professionals in the audience? Sorry? Nutritionist? Awesome. And in the back? Veterinarian? Awesome. You guys are all really important. Your voices are really important. In fact, we can go to the next slide. When we talk about climate change, this is the slide that keeps me up at night. This is the framing that works on me. When you look at this, we only have a fixed amount of space under the curve, and the slower we act, the tighter that timeline is to get to 1.5 zeros. And so this is the thing that keeps me up at night. But it doesn't work on most people. Next slide, please. So what we've tried to do is frame it in a different way. What about polar bears? People care about polar bears, right? They're cute, they're anthropomorphic. Why not? Except let's be honest, people don't really care about polar bears either. What we do care about, next slide please, is people, right? We care about humans. This is where the connection between health and climate matters, is because we care about humans. But guess what? We don't really care about humans either. Because unless they're like in front of us, unless they're our friends and family, we don't care about them. Next slide, please. This is what we care about. Honestly, this is what we care about. We care about ourselves, and we care about those that we love. And so that's why the physician framing is so important. Next slide, please. Next slide, please. Oh, thank you. We are trusted. This is the veracity index that it comes out of the United Kingdom every year, and every year they update this. Who are the most trusted people in society? Nurses and doctors. Right down at the bottom is politicians. Lawyers somehow made it right to the middle. I don't know how they made it in there, but good for them. Hairdressers are kind of up towards the top too, although they're not in this slide. We have power. We have power as physicians, and with great power comes great responsibility. So we need to use our power as society's advocates to make great change. Next slide, please. And so that's why I'm wearing a stethoscope. That's why in this slide I'm wearing scrubs, is because when society sees us as advocates for health, they listen. This is a true story from 2 hours ago. We were meeting with a high-level government official, and he was saying we were having a fight with the media, in the media, with a doctors group on Billings. It wasn't to do with climate, but it was on Billings. And then somebody on the physician side came on stage in a scrubs top, and they looked at each other and they said, well, we're going to lose. The power of image, right? The stethoscope, the scrubs. Use your power for good. Next slide, please. So I was very lucky to be able to use my power for good when it came to the coal phase out. I was involved in both the Alberta and the Canadian coal phase out, but our organization, the Canadian Association for Physicians for the Environment, was involved in 3. And those 3 phase outs had an impact on over 9% of Canada's emissions. 9% of Canada's emissions. And we would not have been able to do this if it hadn't been for the co-benefits that come from getting rid of coal and having the physicians on side. By the end of our coal phase out work, we had over 43 organizations that were engaged on it. But the top 8 were all health organization, Asthma Canada, Heart and Lung Association of Northwest Territories, Alberta Coal Phase Out, Alberta Medical Association, the Nurses of Alberta. Those were the voices that made the difference, because the sad reality is, as humans, it's easier to care about 100 deaths today from air pollution than my home province of Alberta, than millions of deaths from climate change 20 years down the road. Next slide, please. And that's, and so right now what we're going to do is we're going to be taking this forward at this conference, and we're going to be engaging with Powering Past Coal so that we can take some of the learnings from our very successful coal phase outs in my home country and put it forward towards other countries so that they could have the same successes with both air pollution mitigation and GHG mitigation. So I'm going to pass this back to Courtney so that she can introduce our next speaker. Thank you.
Thanks, Joe. And if anybody has questions about coal power phase out or the campaigns, it is basically Joe's favorite topic. Like, he will talk to you about coal and phase out and air pollution and how to get that done and how to mobilize networks all day, every day. He will talk in megawatts. He will talk in PM 2.5. So please, we're really, really interested in, there will be some cool announcements coming next week around the Powering Past Coal. And we're hoping to help mentor and support groups from around the world to do similar work. Okay, now we have someone who is already starting to do some of the work around tobacco laws and tobacco advertising, Martina Doppen from the Netherlands.
Thank you very much. Yes, so don't know if the slides can come up. That would be amazing. Sorry? Yeah, but the slide is actually the first thing I would like to talk about, so. So I can introduce myself again. So we are fossil-free advertising, or reclame fossilvrij, and we campaign for specifically a ban on all advertising from the fossil fuel industry. So oil, gas and coal companies, including flight companies and fossil car companies. And I hope the slide is coming up now, because otherwise my first sentence doesn't make sense at all. But I think it's, sorry?
While we're waiting, just tell us why you care. Why did you get into this work?
Exactly, thank you. Oh, this is the last one. Can we get good at first? Thank you, yes. So that was the introduction. The second one, please. The next slide, please. Yes, because my first question is, do you remember this? This is the Nobel man watching over a school children's yard. And they remember that the same industry has been sponsoring football events, they have been sponsoring education material, they have been sponsoring marathons even. Imagine how bad this is for your health, and then sponsoring marathons. And today, in most countries, luckily, it is not allowed anymore. And no student, no politician, no parent can think about these images in our streets or even on social media timelines. And yet, somehow we still are okay with advertising from the fossil fuel industry. We still allow them to advertising. And they are the new tobacco. And this is forbidden because the WHO successfully endorsed, or they drafted the convention, the Framework Convention on Tobacco Control. And therefore we urge the WHO today to do the same for the new tobacco, for fossil fuel advertising. Because both of them, they have a huge damage to human health. And actually the climate crisis, including air pollution, is the biggest human health threat in our century. And they have a lot of similarities with each other. And I would like to point out a few, because they are, what is very remarkable is that they have both an extremely smart and a very tricky PR machine. And from the fossil fuel industry, this goes back to the First World War. And they kept on going, brainwashing human brains and telling us that we need fossil fuels in our economies, that we cannot live without. And they spread both a huge disinformation about the impact on planetary health, about the impact on human health. And both they paid scientists to spread this disinformation and to prove that this disinformation was actually the truth. Well, they were actually lying. So as I told you, the climate crisis is the biggest threat to human health in our century. So we should give the fossil fuel industry the same treatment as big tobacco. And yeah, they know they won't stop themselves. They keep on harming human health. They keep on destroying our planet. They keep on destroying our communities. They won't stop themselves. So we have to stop their power, reduce their power by taking away a very important pillar of the fossil fuel industry, and that's their PR machine. And sometimes people ask me, do you really think this helps? And I know it helps, because we have seen it from the tobacco industry. Next slide, please. And also the next slide, because this is like a good example what Shell does. And this is a good example of all the misinformation they spread. So they said that we were lying to our children, that there is nothing like an apocalypse. This is from The Guardian. It's a whole article, a collection of all the misinformation they spread. Can you go to the next slide, please? Yes. And next slide, please. Yes. So this looks, I think, all familiar to you. This is how the CO2 emissions are rising. And then go to the next slide, please. And this is how that went in the US with tobacco. But then the WHO drafted the Convention on Tobacco. And then we saw a complete drop. Next slide, please. And it was also not only because of the banning these advertising, but also because there came space in society to talk about it, to talk about prevention. And with this PR machine, we are not able to reach these tipping points. This is actually a social tipping point. So from this point on, there was way more space to talk about these things, to start prevention campaigns, and then it dropped down. So this is the power of advertising and also the power of a fossil ad ban and a tobacco ad ban. And it's not just that I am saying this as a campaigner. This year, it was in the IPCC report, advertising was mentioned. And it's also mentioned by the Cambridge University and by the UNEP. And just think yourself, why would an industry, why would they spend $750 billion every year on advertising? They just do it because it works, because it grows their core business in oil and gas. And you've also seen the slides of Leah and also the slide of Shell before. They don't advertise with fossil fuels anymore. They advertise with how green they are. They advertise about climate solutions. So they give themselves a space in this whole pavilion, in this whole COP27. Today there are 636 people of the fossil fuel industry actively lobbying here to have a position on the table in the energy transition. And can you imagine that the tobacco industry would be at the WHA, the World Health Assembly? Can you imagine? We don't think about this anymore, but yet the fossil fuel industry is here and they're actively working against effective climate solutions. And one more example, our company or organization, we started with banning a festival out of The Hague. And it was a festival organized by Shell. It was called Generation Discover. And at this festival, Shell tried to teach children that natural gas, or methane gas, they like to call it natural gas, was a good thing for Social Development Goal 7. So that was a good starting point for this. And then we banned this event out of the city, and we started the campaign against fossil ads. And our movement is growing massively. So Amsterdam was the first city in the world to ban fossil ads from the streets, and we still need to embed it by law. But we are growing around the world. We are working together with CAPE in Australia. Doctors are standing up in the UK. So backed by a lot of science, a lot of physicians, a lot of healthcare professionals, we are urging the WHO to also stand for a ban, a tobacco law for the fossil fuel industry. So I'm very happy to hear later on from Maria Naira what you think about it, and also from the IFMSA, from Mohamed. Thank you very much.
Amazing job, Martina. I am extremely motivated about this campaign. I already was because of Leigh. You guys are two incredible campaigners and advocates and communicators, so thank you. Ken Henshaw is also an incredible campaigner and communicator. He's from We the People, Nigeria. They've done really important work in the very polluted Nigerian oil region. So please come, Ken.
Thank you very much. Can my slides come up now? Thank you. So I'm going to talk for 5 minutes or a bit more, but specifically about greenwashing in the Niger Delta region where I live, right? Next slide. So I hear that there are at least 600 delegates at this COP from fossil industry, well, heavily represented here. That's excellent. I work for an NGO called We the People, and we work with frontline communities in the Niger Delta of Nigeria. And our job is also to campaign and advertise and tell the true story of what oil companies are doing, their true legacy and their true heritage. We know for a fact that when oil companies come to these spaces, all they do is greenwash, tell stories of how well they are doing, how they are providing sustainable energy. For us in the Niger Delta, it's insulting that companies can tell this kind of lies. Because from the very start, oil extraction was an imposition on the people of my community. They were never negotiated with. They were never discussed with. It was a colonial imposition by the British Crown, and it has continued as a corporate wedlock between the Nigerian state, the Nigerian military, and oil companies. Next slide, please. Recently, for the last quarter, Shell declared $9.5 billion profits for 3 months. This year alone, Shell has paid out $26 billion as profits. While these companies are making massive profits, this is the communities where those profits are made from. The background you see there are mangroves, and if you know mangroves very well, these are the birthplace of fishes. This is where they spawn, lay eggs and all that. And when oil spills into the mangrove, it kills those fishes, kills their eggs, and the fishes have no way of laying eggs anymore. So when oil spills, the productivity of aquatic life drops. Agricultural productivity drops. This is the place Shell made $26 billion from. That's the true advertisement that that company needs. That's the true advertisement that Exxon needs. Next slide, please. In the previous panel, I already spoke about environmental pollution and how oil spill has devastated the lives and the livelihoods of 40 million people who live in the Niger Delta region. But I'll talk a lot more about it. That sounded like me talking, so I'll talk in the voice of the United Nations Environment Program. They also have a pavilion here, right? And you can verify. In 2011, after an assessment of samples in Ogoniland, soil and water taken, UNEP came to the conclusion that oil pollution from Shell specifically had so devastated the environment of Ogoniland that it would take between 25 and 30 years to restore the soil and restore the water. That it would take an initial deposit of $1 billion to even start. It said it will amount to the biggest environmental remediation exercise ever embarked upon by man. That is UNEP, that's not me talking. On what Shell had done and other oil companies had done in Ogoniland. Ogoniland is just one tiny community in the entire Niger Delta region. Just one. The impact of oil companies is devastating on these places. Exceptionally devastating on these places. That is the true legacy. That's the true advertisement of oil companies. Next slide, please. For us who live in the Niger Delta region, it is an insult for anybody to brand the fossil industry as a brand worth advertising. If we can criticize Marlboro, Benson and Hedges, St. Maurice, if we can have a ban saying cigarette kills, for us in the Niger Delta region is the same. Oil has killed us. Oil is killing us. And oil will probably continue to kill the people of the Niger Delta region. I spoke earlier about gas flaring. As I speak to you here in Egypt, gas flaring is going on. And the companies who 600 of them are in pavilions moving around the COP are flaring gas at this very moment in my community. They are flaring gas, they are poisoning people, they are killing babies, and they are destroying futures even right now. They have no right to advertise. Next slide. And so, I spoke earlier about black soot. This is the most visible impact of oil extraction in where I live. Just before I left 2 days ago, if you touch any surface in the morning, that's what you get. And we have had to breathe this for the past 7 years in the Niger Delta region. 7 years. This is hydroparticulate soot, is the byproduct of an incomplete combustion process, right? And this comes directly from the fossil industry. Niger Delta region are living with it on a daily basis. Next slide, please. So, what's interesting is that these companies who have extracted crude oil from the Niger Delta region for 64 years with these devastating environmental and health consequences are divesting. After 64 years, ExxonMobil, Shell, Total are all divesting. And for them, this is part of the transition. Total doesn't call itself just Total anymore. It's now Total Energy. That's part of the greenwashing. They are moving away and dropping the backlog. And that we, the people, we say, no, you can't. You are a fossil company. You destroyed the planet. You will not divest without first restoring what you destroyed in the Niger Delta region and elsewhere in the world. For us, that is our statement on loss and damage. You destroyed the environment, you destroyed the planet, you will fix the planet before you leave. But we cannot do that if we do not have the kind of connection that spaces like this provide, where Africa, frontline communities in Africa and Europe and Asia can link up and say the same thing. Because it's fanciful for them to kill people, destroy the environment, destroy livelihoods, and run to Europe wearing fancy suits and greenwashing. It's easy because you don't see that impact. But thank God for technology and spaces like this, that we can actually bridge that gap and tell you, this is the true image of Shell. This is the true image of Exxon. This is the true image of Total in the Niger Delta region. This is where the wealth comes from. They cannot run away from their legacy. Next slide. I will dwell just a short while on this. Of course, you know about Ken Saro-Wiwa, right? In 1994, he was a fantastic campaigner who simply got tired of the pollution of Shell and decided to lead a campaign of his people, his indigenous Ogoni people, asking Shell for a better deal. And what happened? Himself and 8 others were brutally murdered 27 years ago. And they were murdered as a result of the instructions of Shell. Shell is as powerful as the Nigerian government. It's as powerful as the Nigerian government. A kangaroo tribunal was set up and he was sentenced to death alongside 8 others. 27 years after, nobody has been held accountable for the things that happened to those men. The people, the women that were raped, the houses that were destroyed, the people who went on exile, 27 years after, nobody has accounted for them up till today. Nobody has held Shell to account. Even before the Ogoni experience in 1990, another community where Shell has extracted crude oil from for 64 years decided the same thing. They wanted a better deal from the oil company. They went somewhere and protested, and Shell called in something called the mobile police. At the time, in 1990, that was the most lethal wing of the forces. They went there, murdered 100 people, some ran into their houses, and they simply locked the door and burnt it. These forces were invited in by Shell. A panel of inquiry was set up and it found the company and the Nigerian state guilty and ordered compensation. Shell paid out compensations, and when the people went to the bank to cash the checks, it bounced. Some of them still have those checks till today. That's the true legacy of this company in the area where I live in. Next slide, please. But instead of facing their ecological damage, their human rights abuses, and their very negative legacy, what these companies have done globally and even in my region is spend enormous amount of resources greenwashing, telling stories, right? And what they do limits our conversation on climate change. It limits the prospects of real solutions to climate change. So when we say zero emissions, they fund those who say net zero emissions. When we say below 1.5, they say well below 2 degrees. They change the narrative consistently because they simply don't want to take the kind of actions that are needed to be taken in order to stop the climate crisis. For them, this is all business. This is what they're advertising. This is what their advertisement leads to. And if you can ban gun companies from advertising because they kill people, if you can stop the fossil industry from if you can stop the tobacco industry because tobacco kills people, why can't you stop the fossil industry from advertising because it also kills people? It follows naturally that there needs to be a ban on how fossil companies advertise. People people who murder people, people who steal livelihoods, people who kill babies, and people who incinerate the planet cannot freely plaster their faces everywhere on billboards as energy companies, as saviors of the planet. They must be called what they are: killers, murderers, and polluters. Thank you very much.
This has been so great. We have so many incredible communicators here, and what passion. Now I'm going to ask another incredible communicator who's very passionate, Dr. Maria Nera, to come up with me. Hopefully that mic works. And I'm also going to ask Mohammed Isa, International Federation of Medical Students rep. We're going to sit up here. And I'm very curious. We have the biggest boss in health and environment in the world here. Maria, someone I've learned a lot from and admire tremendously. And we have someone who's also becoming a big boss. But you know what? Something I've learned in medicine is you only get the new eyes of a medical student at the beginning of your career. And after that, you know, your impressions get a little bit less fresh. And I find sometimes medical students are our truth tellers. So I'm going to start with you. So Mohammed, having seen that, what are your initial thoughts about what you witnessed and what you think we should do next? Like, if you could ask senior doctors, senior decision makers to be as courageous as we possibly could be to fulfill the promise of health professionals and this moment, what would you ask us to do?
Yes, thank you so much. So maybe reflecting on all the amazing initiatives and the amazing campaigns I have been hearing about since the start of the session, I guess what I would call on like the seniors, not just healthcare professionals, but even like other sectors as well, to collaborate with the civil society, to collaborate with not just the civil society, but all other stakeholders. There are so many on the grassroots level, and that's what's most important. Here in COP, we take global decisions. In regional climate weeks, we do regional consultations. However, on the grassroots level, it's the most important action that needs to be taken. And as I have seen here, there are many actions that have been taken on so many different countries and different regions as well, which are very much, I would say, they just need the support, I would say, and the further mobilization by the decision makers, because this is very important. However, we need this to be converted and also, I would say, translated into policy that should be implemented. However, from my point of view as well, because this is something I have learned, there are different levels of output when we get to do advocacy, which is something that we all do here. And what we're doing right now, it's actually success. Because some people think that, okay, I did not reach the stakeholder or the decision maker yet, then I'm doing nothing. No, actually, this is an output that we have received, and I would say the very basic level of output, which is still success, is access, in which the previously, or the voices of the previously excluded people are now heard. That's actually the definition of this output level. So this is actually something that we're doing at the moment, and we can do further on. For example, by doing policies, by implementing these policies. So my call to the decision makers and the other stakeholders would be that we need to collaborate together in order to drive this forward, in order to reach the highest output of advocacy, which is the structural, in which what we're talking about in terms of fossil fuels, that fossil fuels should be phased out completely. This should be the norm for everyone. This should not be something I'm waiting for, but it should be the exact opposite. That, for example, if someone is saying, let's do fossil fuels, we would all look and say, we don't do this anymore. It might be something that I would say some people may think that's utopia and not realistic, but I would say the exact opposite. That's realistic. And even if it's utopic at some point, that's exactly what a vision is. A vision should be utopic, so that we can come up with goals, we can come up with objectives and exact actions, so that we can reach this at some point later on. So yeah, thank you.
Perfect. Thank you so much. I totally agree. If we're not designing in our minds a world that we would love to live in, where we can picture ourselves thriving, where we can picture our kids living happily and healthily, what are we even doing this for? We can create that. I totally agree. And so, Dr. Maria Nera, you sit at a lot of very important tables, and you're part of a lot of really high-level discussions. you clearly can't commit to doing anything on behalf of the WHO right now. However, what ideas have sparked enthusiasm in you? What ideas did you see, oh, that's kind of cool, and I'm going to look into that more, that's inspiring to me?
Well, first of all, I have to say that all the presentations I heard until now, there is nothing on those presentations that I will not endorse 100%. All of them, starting with the last one, which was absolutely amazing, with the campaign on tobacco, the coincidence with that, all the presentations, the need to use a stethoscope, the credibility, 100% in agreement, and on a way or another, I'm sure that if you search in WHO's work in the last, let's say, years, you will find this type of statements. We said at the first conference on air pollution and health, I say it to the media, I said, this is the new tobacco. Some activists of the tobacco came to me saying, hey, wait, don't compare, and say, no, I'm not comparing. I'm saying that we will need to use the same tools that we use it for the tobacco. Fighting against a lobby, fighting against a lot of commercial interest, fighting about the glamourization of the tobacco, the way, it's not just the cowboy, it was for the woman, it was fantastic. If you smoke, it looks very glamorous. Let me tell you an anecdote. It was my great honor and pleasure to work with Dr. Brundtland, you know, the Director General of WHO for 5 years, the one who made the Tobacco Framework Convention possible. And one day we were looking at the Marlboro, advertising, and she says, we need to do something to deglamorize that guy, and we need to do something to deglamorize the woman. And then we did, I don't know whether you remember, a woman that looked ugly because she has been smoking, and then all the glamour disappeared. And for the Marlboro cowboy, we put it, he was saying, Bob, I got cancer, and then the whole glamour disappeared completely. Anyway, let me try to structure a little bit my ideas, because you deserve something a little bit better than what I said. The question is, we need to, we are all in agreement. We have incredibly strong arguments. We have incredibly strong scientific evidence. We have the commitment of all the health professionals behind us, or some of them at least, and others are coming. We are all converted here. We are all convinced that yes, we need to do something about fossil fuels. So I don't understand what is happening then. Why are we here? All the leaders are here talking and all repeating that this is horrible. We are destroying the planet. We are destroying the health. Let's take this. We will take care as the health professionals, because I don't see anybody else doing it. So first thing, let's explore legislation. I think we are not using it enough. You see the case on UK, the little Ella, Kisidebra, now in the UK. You have on the death certificate of the little Ella, unfortunately, case of death, air pollution. This is something extraordinary. We are now asking Rosemund to go around. She's our special champion, because we want to replicate this type of change on the legislation in all the countries. Second, let's use full art, images, whatever you have in terms of advocacy, because this is fundamental. We need to convince the citizens, the more sensible ones, that this is very much about health. We have the resolutions of the World Health Assembly. We have a resolution on air pollution. It was very difficult to reach there, believe me, but we have it. We have a plan of action. But now we need to put pressure on our countries to endorse that and to really put it in place. 4, we have the air quality guidelines. Make sure that we raise awareness about, and maybe we can even reach a treaty, a legally binding treaty, even more than the tobacco one, because the tobacco, we didn't finish with tobacco. We have a legally binding treaty, which is quite exceptional in WHO, but I think we can reach a legally binding treaty for fossil fuels. We can do it in the name of health, not in the name of environment, in the name of health. And So I was on the resolutions. We have all of these instruments, but we need to make sure that every government commit to endorse WHO air quality standards. To do that, the first thing you need to do is to transition to renewable energy. So here we are, the damage on the fossil fuels. 5, WHO has been saying very consistently, even on a manifesto just when the COVID outbreak started, the COVID pandemic started, stop giving subsidies to fossil fuels. Stop giving subsidies to fossil fuels. Some people thought, well, you are going out of your mandate. No, we are not. If you give subsidies to fossil fuels, you are maintaining that level of diseases and death that the exposure to the combustion of those fossil fuels are creating. And then, of course, we need to use all of this energy that was presented here today to push in the same direction, keep with very clear messages, as you were saying, and make sure that this transition is done. No greenwashing, very consistent messages, use all the tools we have in our hands, and definitely you can count on the power if we have it, but we will use it as much as possible. We have been as well endorsing the Non-Proliferation Fossil Fuels Treaty. We have been saying that this is an addiction. The addiction to fossil fuels is an auto-sabotage. So we need to keep repeating all of these messages, and of course we need to keep optimistic as well. Otherwise, they are gonna kill us. Thank you. Sorry.
Thank you. No, that's very, very helpful, Maria. Thank you so much. And you know, when you asked why are we still here, the answer that comes to mind is power. We have a real power imbalance, and that has to do with money. It has to do with colonialism. And one thing that I think has really changed, when I used to come to COPs, I was the only doctor from Canada, and now we have a whole delegation. People from Health Canada are here. When I met someone who's become a mentor, Dr. Trevor Hancock, who founded the Canadian Association of Physicians for the Environment, he was one of the co-founders. I was a lonely advocate, and I remember standing up and asking him, where do we get courage from? And I remember him looking at me and saying, that's a really good question, and we didn't really have a great answer. And I think what I now know is that we get courage from community. And community and the courage that allows us, it's a positive feedback circle. I think maybe some of the fossil fuel treaty work, when we started to endorse it, I hope and believe that gave maybe the WHO some courage. And when the WHO endorsed it, that gave countries the courage. So it's a positive feedback cycle, community, action, courage, community, action, courage. And that's what's gonna help us build the power we need to confront these extremely entrenched structures. And I'm just seeing so much momentum, so much good work. Please tell the stories of your wins to inspire everybody else. Don't be sad and shy about it. Spread the news, we'll amplify it, and let's keep that cycle of community, courage, and power and winning together. Keep it going. I think with the energy and new eyes of the medical students, the experience and real power and communications of people like Maria Nera, of all of us, I truly believe we're going to deliver a healthy response to climate change. Thank you.
Welcome, everyone. Thank you for coming to the World Health Organization's Pavilion, and welcome to everyone at home joining us live for this Transforming Health Systems Through Decarbonization and Resilience side event. My name is Diana Picon Manjari. I am the International Climate Director for Healthcare Without Harm, and I welcome you to this session. I don't want you to be fooled by the title. It's a lot of words. It's a little boring, to be honest. And we were trying very hard to work on the title with all of the panelists, and we failed to do this on time. But what I'll say is that what we're trying to do with this event is to really bring vulnerability, adaptation, decarbonization, mitigation in the health sector in our communities to really transform how we do healthcare. And with that in mind, I'm gonna ask Dr. Darmit Campbell-Lendrum to join me on stage to give us an opening statement before we start with the first panel. Dr. Campbell-Lendrum.
Thanks very much, Diana. Thanks for the warm welcome. Thanks for calling it the WHO Pavilion. We actually say it's the Health Pavilion. It really is the broader family. We've had the pleasure of putting it on with support from the Wellcome Trust and these wonderful artists, but it really is, we see it as basically as your home. Thanks for, it's very kind of you to call me Dr. Campbell-Lendrum. It's very formal of you, and I feel like I should be here on a podium with a formal script, and as you can see, I have none of that. And this really is a couple of remarks just by way of welcome on behalf of WHO and the importance of this discussion. And Diana was being very modest in the quick discussion we had before, and in her introduction, she said, you know, it's a lot of words, it's a long title, it's a bit boring. I don't think it is, because if you look at what it is actually saying, there's not much more ambitious than you could say than that. We actually want to transform health systems, and one of our watchwords within WHO is that health systems is not just hospitals, healthcare facilities, and so on. More importantly than that, it's the people that work within them. The health workforce is the most important part of a health system, and we also emphasize that it's decisions taken outside of the health system which have a really important determining role in health. So we want to take that broad view of health systems as health systems per se, but also in the reach outside. If we talk about decarbonisation, you all know the figures, you'll hear them again. Healthcare, even as a sector, is 10% of the global economy. We often say it's 5% of emissions, that's important, but it's 10% of the global economy. It's one of the biggest health workforces in the world. It's a big growth sector for many economies around the world. It's often one of their showcase sectors. So if we are able to decarbonise, that is taking emissions out of the system which are bigger than the emissions of Africa, for example. So that's a massively ambitious agenda. And we talk about resilience. We know that the climate crisis is a health crisis. We see the range of things that are being thrown at health systems, and more importantly at people, which are being made worse because of climate change. So that if we're able to strengthen our health systems, make them more resilient, we save lives now as well as protecting out into the future. So there is no more ambitious agenda than that, and no less boring, I would say, agenda than that. And we're also casting this very ambitiously and non-boringly in terms of transformation. We're not just talking about incremental improvements. We are actually talking about a whole new mindset. We are talking about things that people can do in their individual spheres of action. If you're a frontline community health worker or a nurse or a hospital manager, you need to be thinking about what you can do within your own health system. But overall, we are talking about changing the mindset of transforming a system, so it's actually a health system, not a sickness system. It's not just about disease. So there is no more interesting, I would say, and ambitious agenda than that. Diana also, maybe I shouldn't be telling people this, Diana described this as a Frankenstein event, that we basically put together a whole series of different body parts, if you like, in this discussion. We have people from a wide range of different disciplines. We have the frontline humanitarian health workers. We've got people working in academia, in research and so on. I think that's an advantage. In order to achieve that agenda, we are going to need everybody to play their part. So again, nothing to apologize for in terms of bringing together different communities and different stakeholders in order to do it. So that's what I wanted to say by way of welcome to the Health Pavilion and to this event, and I'm really looking forward to the discussion. So back to you, Diana.
Thank you so much, Dermot. I will try to be less formal from now on. And we want to welcome the first panel. It's going to be a very interesting one because we are combining two diverse contexts in this panel. One in terms of focusing on Africa and very vulnerable areas of Africa, and the other really bringing up the experience of Asian countries, India and Laos. Without further ado, I want to introduce the first moderator, Trish Naina Schroedel. She's the climate change and health researcher from the Heidelberg Institute and Médecins Sans Frontières. Please welcome her and the panelists. Thank you.
Thank you. Thanks so much, Deanna. So this first segment is really about diverse health settings and climate resilience and decarbonisation in diverse health settings. So I'll keep talking? Yeah. So I think if you do a search for climate resilient, environmentally sustainable health facilities, often the first thing that will show up will be the NHS. And we get in our picture, in our minds, this picture of a high emitting tertiary referral hospital in a developed country that needs to decarbonise. But that's not an accurate picture of health in our world. An enormous proportion of people in our world have no access to healthcare at all, or they have access to very basic healthcare. So what does this conversation about transforming health systems to be climate resilient and decarbonised mean for people who don't have access to healthcare at all? And these are often in settings where there's high exposure to climate shocks and stresses, and there's low adaptive capacity, and then on top of that you've got a fragile or failing health system already. So that's what this session today is about. We want to diversify the conversation about transforming health systems to consider these contexts. So firstly I'll introduce Steve Cornish. He's the General Director of MSF Swiss, and the Operational Centre Geneva of MSF, Médecins Sans Frontières, have really been the leaders for the movement in planetary health and engaging in climate change and health issues. Here we also have Patrick Youssef sitting next to me. He's the Director of Africa of the ICRC. So we're first going to hear from Steve and Patrick about these diverse health settings, and I want you to think about, when you're looking at these images and listening to these stories, what transforming health systems means in these contexts, and it's very different from the conversations that we've had today. Thanks, Steve.
Thank you so much, and thanks for hosting this panel. I'll try to paint a little bit of a picture of our work in South Sudan, an area where we've seen 4 years of unprecedented flooding, which has caused so much destruction and devastation. It has washed villages and houses away. It has left stagnant water throughout the whole year, leading to spikes in malaria, leading to severe malnutrition. In fact, half of the population, some 7 million people, are food insecure. And when we talk about health systems, we have some very small scattered health posts. Often the flooding leaves populations unable even to access the health care that does exist. And of course, with that as a background, we've seen the health needs, the health-seeking behavior explode because of diarrheal disease, because of malaria. Simple everyday issues can lead to an emergency situation. And as a result, we've had to change really how we work. And we've done a number of things trying to build resiliency into the system. First, by focusing more on preventive healthcare. In the last several years, we've done chemoprophylaxis at a community level ahead of the malaria spikes. We've put a higher reliance on prevention and vaccination, using oral cholera vaccine, for example, and spent much more energy and time training community health workers and other members of the community to be able to spot the warning signs of malaria, of malnutrition, of diarrheal disease early enough that they can then reduce suffering for a community before waiting until that health-seeking behavior would be required. And then along the way, we're looking, of course, at our own carbon footprint and at the system itself. And they're doing many of the technical fixes that we all speak about on solarization, looking at more local and adaptive capacities, and trying to ensure that the health posts themselves are not in areas that will be flooded. We've relied on early warning and forecasting to be able to pre-position supplies so that they're at the right place, both nutritional as well as medical, and taken a number of other steps. And it's really coming into a full culture change to work with the patients and communities as partners and with other partners so that together we can hopefully build in a stronger frontline defense, which in fact is the patients and the populations themselves.
Thanks so much, Steve. Thanks. From Patrick Youssef, the Director of Africa, ICRC.
I hope you can hear. Gonna keep it short. Well, first I wanted maybe to second what my colleague from MSF just mentioned about first and foremost greening ourselves. That's a very important aspect that within a transition fund that the ICRC has put up, it has the ability and also the ambition to start thinking first and foremost about our own footprint. Maybe I want to move quite quickly to some of the situations we see in Africa, where in all our answers, all our operations, social cohesion is really the center of what we want to achieve, either by responding to emergency situations and in maintaining people's dignity quite quickly after a shock, but also through resilience building, and that goes through, on the health side, or what we call everyone in the humanitarian sector. No. The continuum of care. And what I want to mention here is that as many of our humanitarian partners, the panoply, the palette of activities kind of ranges from surgical capacities to primary healthcare centers to surgical, but also to something that I want to highlight here. When we speak about the dual impact on conflicts and climate change, and that's where the MSF and ICRC expertise really lies, we want to go beyond the fact that we repair a primary healthcare center once because it was destroyed by a cyclone and another one by a non-state armed group, namely the Islamic State. Let's go beyond that. I want to mention something that we're living today in a very, very crucial way, and that is about food security in Africa. And we all know that food security, the main driver of food security today is armed conflict, unfortunately. And therefore, the impact on people's nutrition is highly, highly impacted. And I want to mention that because, as you know, climate change exacerbates existing fragilities, increases chances of people going deeper into areas that are irreversible in livelihoods and the way they conduct their lives. And hence, that indeed affects the two major economic communities and powers in Africa. These are the farmers and the herders. Those alone who would account for 80% of the informal economy in a country like Mali. I was last week in Mali with our president, and I've witnessed indeed the complete marginalization of those communities who, given the state of affairs and the lack of sense of agency, are becoming no way close to becoming part of the solution. And hence the impact, which we never mentioned today, unfortunately, on the nutrition side of things is grand. Everyone today is thinking about people putting food on people's plates. And that's the emergency response, while the long-term approach should indeed look about on nutrition. There are 1.8 million people facing severe malnutrition, and again, according to data from trusted organizations like the ISFs and the others who are on the ground. But there's a double size of people who have already reached IPC 4 and 5 and have never been mentioned, unfortunately, in our programs. Hence, the impact on nutrition is grand. If I take one example in Somalia, one of our nutrition-led centers in the center of the country used to admit 87 cases only in the lean season between June and August. This year, it reached 486 cases. And that is a stark difference and an immediate connection with climate change. And the fact that climate is now inducing more and more displacements, inducing more and more poverty, and hence I think the connection is quite clear. Without a holistic approach, an informed approach, and a good collaboration with those entities that have the capacity to respond, including development actors, I don't think we're going to be able to break that cycle and come in 5 years to see that the same crisis has hopefully a lesser impact on people, lives, and livelihoods. Thank you.
Thanks so much, Patrick. And it's really great that you bring to our attention also the determinants of health, because I think when we talk about transforming health systems, it is still downstream, isn't it? And so we shouldn't do that at the expense of looking upstream at the determinants of health. I remember when I was working for MSF in South Sudan, we were paying our health workers with money, but at some point they came to us and said, well, we can't buy food anymore, so we're actually going to have to leave the health system, the health facility, because the money is not useful at all. We need food. So that's another, it really sheds light on, you know, the realities in these diverse health settings that we're talking about here today. So thanks for that. And it's really good to hear from humanitarians as well, who really provide a different perspective from people that are actually living at the edges of climate extremes without access to basic healthcare. So next we'll hear from Dr. Purnima Prabhakaran. She's the Director of the Centre for the Environment of Health at the Public Health Foundation of India, and also from Dr. Baokeo Savranthong. He's the Deputy Director General at the Department of Hygiene and Health Promotion at the Ministry of Health in Laos, People's Democratic Republic of Laos. And what we're hearing from Dr. Purnima and Dr. Kao is really case studies of transformation in a developing country context. So forget about the NHS and the USA and Australia for a while in terms of their work in this area. We'd like to see and talk and think more about what climate resilience means in developing countries, and it's less about decarbonisation and it's more about decoupling development and health system strengthening from emissions. So first, thank you, Dr. Purnima.
Yeah, thank you, Trish, and hello everyone. Thanks for being here to listen to us. So I'm going to bring you a little bit of the story from India, a country. If you look at the Global Climate Risk Index, we are one of the most vulnerable countries. If we look at our health systems, we are nowhere near the NHS, not an NHS model at all. Our health system includes a public health system, a private health system, several levels of governance, several tiers of healthcare, and we are still doing the balancing act. We haven't reached universal health care. So we have to strike a balance there, and really, yes, decoupling development and access to health care in India with the story for building resilience to climate change as well as the decarbonization story. We can't afford to be complacent. We may be not contributing to the global greenhouse gas emissions per capita if you look at it, but we cannot stay complacent as well. So our story actually began a few years ago when my story began with the private health sector because of my work with healthcare without harm. So the Global Green and Healthy Hospitals was a story that I could bring to India and start my work with the private health systems. And if you're looking at the visuals over there, we have some exemplary case studies of activity in the private health sector in India. And this is a visual from the Arvind Eye Care Hospital in Pondicherry. So this is a story about sustainability in eye care. You know, you wouldn't think about something like that. We're talking about entire healthcare delivery, but even within the delivery of eye care services, there is a whole health system that is talking about building resilience, bringing eye care to everybody that matters through very many different initiatives. They have vision centers in the peripheral parts of the geography that they serve, and they are reducing the carbon footprint by having this one-stop shop in very many different parts of their base hospital. And whether it's the rainwater harvesting, the solarization, turnaround time in terms of surgery, they do like 6 cataracts every hour. And that is a story to be built upon in India for eye care. Beyond that, that is a story that I'd also like to talk to you about. During COVID too, there were these wonderful initiatives, a hospital that just came up during COVID. And that also talked about sustainable building on natural ventilation, depending upon renewable energy for their health services. So there is a story even in the throes of a global pandemic that decided to think about sustainability in healthcare. So really case studies that have been exemplary in showing the way, in showing healthcare leadership in both the resilience as well as the decarbonization story. So far as the public health system is concerned, we had a Council for Climate Change that was established by the Prime Minister back in 2008. It was only in 2015 that a Commission on Health was initiated. And even then, there wasn't a focus on the health system in terms of strengthening health infrastructure, building climate resilience, or even the mitigation story. And that happened only like 3 years ago. So it's been a learning experience for us as well, that I could bring the story of climate smart healthcare, which started with my work with the private health system, into the National Program for Climate Change and Human Health with the Ministry of Health. And through that, I've been able to take it sub-nationally to every state. In India, we say we are countries within a country. Different parts of our country have different climate vulnerabilities. So really, the climate smart story in the sub-national level means that every state starts with a vulnerability assessment. They decide, are they vulnerable to floods, are they vulnerable to heat waves, and take it from there. Like Dayamid said, an incremental approach. You cannot do everything. My framework for them for building climate resilience and mitigation is a 10-pillar story. But we tell them, use your resources, use your vulnerability to decide what you want to do first. So whether it's solarization, rainwater harvesting, waste management, procurement, sustainable procurement in healthcare, do what works for you. Nobody is under pressure to do everything because we are still on that balancing act. We want to ensure access to healthcare, but we also want to play our role in building resilience and the road to decarbonization as well. So I think we have a lot of work to do, but there is commitment, there is passion, and there is the will to do. And I think we have a whole lot of resources that we've been leveraging, whether it's the WHO framework for climate resilient healthcare, or the decarbonization roadmap that Healthcare Without Harm has. We've been leveraging all these resources to talk to different levels of healthcare. And in India, we are a unique country. We have multi-tier, multi-speciality hospitals that are accessible to some sections of society. And if you go down to the front line, you have primary healthcare centers that often do not have access to electricity. So, so that has impacts for health outcomes, for neonatal and maternal morbidity. If you're not going to have a labor room, for example, which has no lighting, or a neonatal incubator which can keep the baby there warm and ensure survival, we are not going to get anywhere along the path to universal health care. So we are still fighting that balancing act, but I think we have a lot of exemplary stories. That is a story from the state of Kerala, which was hit by floods in 2018. But with a real commitment from the government, there was a Rebuild Kerala initiative. Primary health centers were literally washed away by the floods. And with the Rebuild Kerala initiative, they were able to build back the primary health system taking into account the historic flood levels, moving the healthcare facilities to safer zones, moving their essential care services to higher levels of the healthcare facility, putting their blood barriers. And I want you to pay attention to that one. That's from the northeastern part of our country. These are boat clinics. So this is a part of the country where the access to healthcare is still a difficult story. But here is a boat that is powered by solar, delivering healthcare from one point to another along the geography to the vulnerable populations that live along that river. So I think we are building a little story over there, and with all the commitment and all the resources that we have, I think we have the ammunition to get into firefighting mode and fight the climate story. So I'll stop there. And
So, good afternoon. My name is Boakel Suanpong from the Lao PTR, MOS Ministry of Health. So, if we talk about the health system in Lao, we have the, how can I say, in our country, we have the, look like the long country. If compare the alternative with a small country, population is very small. Every year we have climate change impact for the health system. For example, in the health center, some health center burn down when the flooding and landslide. Mostly disease the same in the other country about the diarrhea disease and dengue fever disease for every day. For health center, we have lack of the water service was and lack of the sanitation system. Government try to how can to achieving about the water sanitation and how can the good supply health facility in the rural. Mostly we focus about the waste management and wastewater management. We starting in Lao country. Now the Prime Minister commitment COP 76 already. Our country should be the remove about the wastewater and solid waste, not need use incinerator, only to the autoclave and to the mixing about the waste, solid waste, hazardous waste. Mostly we have the many strategy about the waste management, the standard about the waste management. Now we started about how can to achievement in the future 2025. Now we start about the training for the nurse and doctor. Mostly we working closely with the nurse doctor. For my side, we working for the hygienist, the Department of Hygiene and Health Promotion. We should be coordination with the doctor nurse is important because they have the IPC system. In our country, we have the two parts. How can the working? These are very important. We can following about strategy and the guideline for the implementing in the health facility in our country. So I think for the climate change and health impact in our country, not similar in your country. You have explained. Mostly we would like to sharing with the counterparts with or from your country. Maybe you have more experience. We would like to learning more about the how can the solution, how can the climate change adaptation and mitigation inform your country. Yes, I would like to say something about it. Thank you so much.
Thanks so much, Dr. Ko. And it's great to see those examples from developing countries. I think before COVID and COVID being a black swan event, health systems were assessed to see how they would respond to the pandemic, and there was kind of this assumption that high-income countries would do better, make us think that a system is resilient, and those indicators are very different in different parts of the world, but there's certainly a lot that we can learn from developing countries in their response to COVID and also their response to climate change. And I also really liked what Dr. Panema said about we cannot stay complicit, because that seems to be a bit of a shift in the discourse. Like, it used to be we don't emit, therefore we look to others for the solutions. But now it's much more thinking, let's not just think about historic emissions, let's think about future emissions. And then that really changes the conversation about responsibility and what are we waiting for? Like, we actually we have our own solutions, and we can start now and we can scale them. So we're going to move into a bit of a facilitated conversation now. I'm going to ask you guys a few questions. So starting with Steve from MSF. MSF provides healthcare to migrants and refugees in over 80 countries in the world, and that's a big part of MSF operations. Climate change is going to reshape migration, and part of that reshaping will be an increase in the number of people on the move, also the number of people that will be trapped in a mobile, but definitely will increase forced displacement. Do you think MSF is ready to meet this challenge, this amplifying threat that is climate change, with respect to delivering healthcare to migrants and refugees?
Well, we're certainly not ready for the scale of movement to come, but we do have some very good starts, and we've changed a number of the ways we operate in order to better respond to the health-seeking behavior of people on the move. We start that right from the get-go now in our programs to ensure that we're working with communities, things even like community first aid when it comes to mental health, so that the community members themselves are able to identify the signs and symptoms and to be that first voice for the community members, and therefore they're taking the mental health care with them as they move. We've done the same for many years when it comes to treatment for HIV and TB, for example, in areas that we know the population may end up being forced to move. We work with the patient groups to ensure that there are leaders of those groups that can oversee the medical distribution, that can follow the lists, and that can move with the community to ensure that treatment isn't interrupted. But we have to go much, much farther than that. We are looking at e-records and different types of ways that a patient's history can move with them across the way. In Central America, we've changed how we work and where we work to ensure that we have either our own clinics and or supported clinics all along the migration route from Colombia all the way to the United States. Along the way, we provide information, mobile hotlines where people can call into to get additional information, and we adapt the type of care that we are providing, because the health-seeking behavior has also changed. People will look for things like chronic disease medicine or look for wound treatment, but they're not going to look for other types of longer supports when in fact the primary objective is either to flee violence or to arrive at another location. What we're really concerned about, though, and Patrick, you mentioned this, is the nexus with conflict. And when communities are on the move, they're going to come into play with other communities. And we're seeing more and more now in refugee camp settings and in other areas where the hosting population is suffering the same effects and the co-effects of the changing climate. And they are increasingly more vulnerable, have less food security themselves, and so their ability to extend solidarity and to welcome others is being sorely tested. And there we'll need to work with, likely with peace builders or others. We'll have to look also for financing and funding to see how can we find even the land where people can resettle. Just recently, when I was in the south of Sudan along the Ethiopian border, we were looking for areas to be able to welcome more refugees. And the elders from that region remembered 30 years before when people had come across and they had deforested the whole area looking for firewood. And so they were very reluctant to lease or to lend the land because they didn't want this reforestation to happen. So we have to learn the lessons from before, partner with many more, look for more technology, and then we'll need something much greater than all the humanitarian systems combined. We really have a crisis now of solidarity, where we in the north are building fences, building walls against migration, and we're going to need to come through with the supports that will help communities not only deal with disasters in the rapid onset, but also deal with all of the recovery needs. And that's one of the central themes here at this COP, around loss and damage. And we're really going to need the traditional heavy emitters to step up and to meet the responsibilities for what is to come.
Great, thanks, Steve. Yeah, it's a good point, and I think the ICRC report, The Cost of Doing Nothing, really showed that humanitarian needs are going to double by 2050 unless we really step up action on mitigation and adaptation, and at the moment they're severely unmet. So we aren't, MSF or no system could be equipped for this, and that's part of the reason why MSF is here and is advocating for mitigation, because there's only to an extent that we can adapt. Patrick, I'll move to you now. What does ICRC's contribution to health look like, and how do you think about the nexus between climate change, health emergencies and conflict?
Well, I think if we put ourselves in the shoes of those living in situations of armed conflict, the evolving needs around their lives and livelihoods are things that we observe and become extremely worrying. I think the ratio between humanitarian aid and humanitarian needs is increasing. And if we are truly honest about our work collectively, I think we are still a small drop in the sea of needs. So one has to be also modest about how much we can accomplish. We are truly saving lives, and we've been saving lives as much as access as possible. But I think on the larger scale, on the macro scale, we are still a band-aid on an infected wound. We have to admit that and show some modesty collectively to start seeing the right approaches and exactly see who is missing from the environments we occupy. And therefore, I think looking at this nexus between the delivery of the continuum of care, from primary health care to physical rehabilitation to mental health and psychological support, is something that requires some form of stability. Again, I mentioned before the climate, the impact of climate on everything around social cohesion, and health is certainly not an exception, especially when you know that health workers are simply abandoning the locations where they are. And in addition, because again, inciting displacement comes a very heavy price linked to climate change. And I think there, maybe to answer your second question, the links are very clear. Unless we start treating the root causes of conflict, the lack of social services, the marginalization of those communities living so far away from those services that are, well, up to standard in the capitals. And I'm here referring to so many places in the north of Niger, or in Somalia, or today's Tigray, or in Amhara. I think the divergence is one of inequalities between the people who unfortunately are living the impacts of climate change. By the way, that's why both organizations are here, is to bring those voices up to those decision makers who still believe that by decarbonizing in a number of years, people living in armed conflict will benefit from these. Honestly, not. Let's be honest and provoke, indeed, and speak our minds. The truth is that Africa today is responsible for that much of carbonization, while it's not receiving that much of all the deeds that should arrive to those locations where we witness the differences between treatment between people living there and living elsewhere. And I want to maybe conclude with a positive note. I think the more information is shared with those farmers, herders, and populations, and use information as aid, as you've mentioned, I think we are creating agents of change within the communities. Agents of change who have internet connections, who have access today to information which we in our generations didn't have in the past. And you'd be amazed by the number of locally and organically grown solutions that truly require support from international organizations. So I think a combined response can truly benefit and make sure that the connections between climate, unfortunately, climate, health, and armed conflicts is one where we not only speak the truth, speak about impact, but also see where sustainable humanitarian impact is favored. And here, again, as I mentioned in my earlier response to your question, it's probably also bold to ask those actors who still fear insecurity to step up their game and see that we are not aliens. Organizations, humanitarian organizations are not aliens, they're not just risk takers. At the same time, unfortunately, these actors are becoming more keyboard activists rather than frontline workers. And hence, the combination or the equilibrium between this and that would probably get us to a better place. Because what we're living today, I think, in Africa, on the food security front and on the climate shocks, has never been seen, at least in my 17 years at the ICRC.
Thanks, Patrick, and thanks for talking about solutions as well, because I think like the vast majority of climate change and health research is about the problem, about impacts, and we are living in the adaptation era. There's much less research about climate change adaptation for health, and we need to start talking more about solutions so that we can kind of build momentum. So speaking about solutions, Dr. Purnima, you mentioned the balancing act between achieving universal health care and also climate resilient, environmentally sustainable health systems. And so it's a bit of a trade-off, isn't it? What are the guiding principles that you've learned, and also that India and India's neighbours have learned, that can help other developing countries deal with that balancing act?
Thank you. Yeah. Yes, it continues to be a balancing act because it's very inequitably distributed. For example, the access to healthcare is still an issue, and while we recognize that ensuring universal healthcare should become a priority, and strengthening public health infrastructure, especially after something like COVID hit us, it is a top priority. But we've also recognized and managed to convince the powers that be that we also need to play a role in building climate resilience. And as we speak, we talked about a green and healthy recovery for the health systems as well as the health of populations everywhere. So I think it is a balancing act for sure, but we have been able to convince people to say that yes, we need to distribute our limited resources, prioritize, take an incremental approach, and see where we go with different tiers of healthcare. So maybe we have to redistribute our resources and prioritize what we need to achieve, step by step. And I think we are getting there, and I understand that there's limited time, but I could come back maybe in the next round. Yeah, thank you.
Thank you so much. So we might wrap up this session now just with one message from each of you, like a recommendation, like if you could put it in a nutshell, a take-home message about building climate resilience and environmentally sustainable health systems, facing the challenges that climate change is going to present to us in the next decades. I'll start with Patrick and then we can pass it on.
I think my lesson from COVID, everyone has mentioned that we're never going to be safe unless everyone is safe. Exactly that. Africa is bleeding. Half of the continent is at war. Over 14 countries are indeed in a dire situation. If we don't focus on having an equitable access to health services, but also to climate adaptation and climate financing, I don't think we will survive as a whole, as a community, as a globalized world. That's what I want to take, and that's the message I want to pass here.
So from our government policy for the health system is, I think for the primary health care is very important for the everywhere, because population mainly in the local level. The local level can be participation and involving about the healthcare system. That's the first should be the success. If the government or some UN investment a lot of money, maybe not so success. I think about the primary healthcare, the first should be important for the community, should be awareness and taking about this. Thank you.
We have no time to waste. So utilize the limited resources, optimize your priorities, and transition ourselves to the board. And we have the ammunition to do. Have to waste any more time developing more resources and use what we have already and get the act together. Yeah, thank you.
I'd say communities are ingenious and resilient, and they are the first line in responding to disasters and to health, but there's a limit to that resiliency. We can't expect them to recover from cyclone after cyclone after cyclone. The true crisis right now, crisis of empathy and of solidarity, and the time to act is now. We need to pay the bills on having caused the climate crisis, and right now we need to see the loss and damage facility put into turbocharge, funded up so that those communities will have the means to build their own climate resilient future.
Thank you so much to the panelists, and with that I'll hand over to Diana.
Thank you, Trish. Thank you, panelists. Next. Going to change microphones. Thank you so much for that. And next we have a recording by Antonella Rizzo, who will speak about Healthcare Without Harm's Carbon Impact Checkup Tool, the calculator of greenhouse gas emissions and Scope 3 hotspots being used by members of our global green and healthy hospitals network around the world. Antonella?
I am Antonella, and I want to share with you some results that we have at Healthcare Without Harm this year. Maybe some of you know that we have developed a tool that we call Climate Impact Checkup. It is a carbon footprint calculator built to be used by healthcare workers. So there's no need of being a special engineer or someone trained in GHG protocol to be able to use it. It is based on a previous tool that we developed in Latin America, and we launched it globally last year in July. All Healthcare Without Harm offices and partners participated, and we implemented also a pilot from all geographical regions to develop this tool. And here in this image you can see a picture from 2019, from 2020, March 2020. This is in Mexico. Here you have doctors, engineers, and quality staff people, nurses, that were learning how to use this tool, and now all of them are calculating their emissions and have done it more than once. By November 3rd, we had 429 reports. The dots here are less than that because every dot is an institution. And we also added a feature this year that are test submissions. So if you feel this it is a bit scary to calculate and report, you can start a test submission, just learn, test it, and after that you change everything and you set your baseline and start reporting. So we have 89 of those test submissions by today, but in draft stage, like some they're doing, like 46 today. These are the sources that the tool tracks. We are dividing them in scope 1, 2, 3, like in the GHG protocol. And we added this year an extra supply chain section that has a different method that we're going to explain a bit. But the tool tracks stationary combustion, mobile combustion, waste on-site treatment and off-site treatment, because you can have both. Fugitive emissions for scope 1, scope 2, we have purchased electricity and also purchased steam, heat and cooling for those countries where this actually happens. And for scope 3, we have the inhalers, patient and employee commuting. We calculate the electricity transmission and distribution losses, business travel, and the waste of site treatment. And for the extra supply chain, we have 11 categories. We have just here 5 to simplify this, but that's where we have construction, food and catering, and other procurement, medical instruments and equipment, and also pharmaceuticals. Sorry, again. Just to explain this a bit, Healthcare Without Harm developed a roadmap a few years ago and a climate footprint report, and others have researched and are identifying national carbon footprints. And this is a carbon footprint tool for facility level and also systems. Some systems are using it, but we calculate the emissions of the sector, like integrating both this bottom-up approach and the top-down approach. We are working on both, But these results come from this bottom-up approach, from the facilities where we have data usually that comes from surveys, from spend for the supply chain, and from activity, we're calling it when you're talking about liters or gallons of gasoline, for example. I can do this one. Just a reminder, as you are in a session integrating resilience, low carbon, and sustainability, and attach is about that. We are building this. It's not finished, but resilient, low carbon, and sustainable healthcare facilities incorporate at least this. Sustainable procurement as a key, carbon mitigation, and other sources, of course, not only carbon. Resilience, to work towards building resilient healthcare systems. It means capacity building, because we know if you are working on this, you know that there's a lot of capacity that we need to build, that we have the commitments that there's a lot of capacity that we need to build, that we have the commitments that many countries and healthcare systems are committed to going to net zero and to building resilient and sustainable healthcare systems, but they don't know how or don't have all the capacity yet. So we're collaborating and we're helping them to build that. And all that leads to healthier environments, of course. Some preliminary results that we have not done a complete analysis yet, but preliminary results that we have by October 3rd, the last time we extracted all the data, we had submissions from 21 countries and 237 facilities. It's important, as the tool was developed in Latin America and there's a whole strategy in the region already implemented, most of the data today still comes from Latin America. So we have data from other countries, but most of the data or most of the reports come from that region. 73% of all the reports come from Colombia and Mexico only, and 88% of all the reports come from Latin America. So it is important to notice that we have data from 21 countries, but from many countries we still have a very small number of reports. Checkup has allowed to a lot more healthcare systems and hospitals to start tracking greenhouse gas emissions, and Indonesia had, that you have there representatives from Indonesia, 10 test submissions, like in a draft stage, like last week, and 1 submission this year. And that is a result of JIT and others in Southeast Asia that you have there in the room today. We had 105 first-time reporters with 2020 data and 34 in 2021. We see a higher reporting rate on anesthesia, inhalers, and cooler than we expected. Actually, up to 2021, 42% of the reports included inhalers, 65 anesthetics, and 65 cooling gases. So these are good news. So these preliminary results, what we have in reports, before 2017, we have a very small number of reports, institutions that had data before that and that are reporting that data to healthcare harm. So you see how this is moving. These are the year of the report, right? The year of the data, not when they submitted it. So in 2020 is the year that we have the highest rate of reports. And for 2021 is the data that they are submitting this usually during 2022. So this hasn't finished, but we have, it seems, less reports. But in total, this adds the 407 that I mentioned before. In these preliminary results, just some of the things that we're seeing that, for example, we wanted to see, like in the fuels, mobile combustion disease, like how much of what we're seeing that they are reporting, it's gasoline, how much is diesel. Those are the things that we are trying to see in emissions. For example, in 2020, it's like a bit more than gasoline than diesel. We're trying to see how much biodiesel or biogasoline they are reporting. We cannot track hybrid cars yet because this is a carbon footprint calculator. But these are some of the things that we're starting to analyze. To continue with the results, for example, emissions from inhalers. Those are unique of the sector and are more and more research is being produced around this. But one of the things that our tool can show is this, what you see here, not occurring, not available, estimated, or complex, This is analysis from notation keys. This is something that is used for inventories, for greenhouse gas inventories, that we incorporated in the tool. So for each source of emissions, the user needs to say if they are going to estimate or they're not going to estimate that source. Let's say inhalers. And if they're saying estimated, they put the data. And if they're saying that they're not estimated, they are saying that it's not occurring. Could be like you're not prescribing inhalers because of your level of complexity. Would be weird, but could be. Happens, it seems, in our members. Not available, you don't have the data, or too complex. But no occurring, for example, happens with composting. Could be. You're not doing compost, so that you're not composting. So this is the analysis of the notation keys of inhalers, only per year. And we have many members estimating inhalers, that's good. And the reports, including MDIs and DPIs, you can see here, MDIs and DPIs, you can see that in the reports, in this preliminary analysis, MDIs the DPIs, are going up, so that's good news. And we will be able to go deeper in the following months, but so far we can see this and it is good. Anesthesia, what we have so far is you see that in 2018, the reports from 2018, we have 50% of the members reporting, but in the data that we have from 2021, we have more than 70% of the members providing data on anesthesia, so that's good. We will have more in the following months, but this preliminary analysis is good. So we expect to continue learning about this. We just started digging really into the data, and we expect to tell you more about this in the following months. In cooling, what we have, it's similar. We have a very high rate, actually, in 2021 reports, 80% of the members estimating cooling, so that's really good. That when we started with this, it was lower, but members started, actually, they didn't have the data when we started, but they went and changed how they were collecting the data, and actually what they had to change in Latin America mostly were the contracts, because the contracts with the maintenance companies were registering that they were refilling equipment, but not how much. And we needed to know how many kilos of each gas, we needed to know the quantity to be able to calculate. So members were trained and they asked for the data, and now we have it. And it's complex because those are many gases, but we are starting to learn about that too. Sorry, no, good. And about supply chain, just for you to see what the tool does, this is new. We launched the hotspot supply chain tool in September, so this is really, really new, and we have just a few reports, including the extra supply chain categories. And there is a table, and these are images from the online report that the members receive. They receive a PDF with the graphics and with the data. In scope 3, in this case, you see that the extra supply chain, that what they reported represented 11% of the emissions. That's interesting because we know that in general it can be up to 70%, more than 60%. But when you go to the facility level, that depends on who's buying, in which level pharmaceuticals or the medical equipment is being procured. In public systems, or even in the private, depending on how they work, it depends at the facility level how this is going to be. So in this report from Colombia, this was a high complexity hospital, but we see that the highest in the supply chain, in the extra supply chain, was actually construction. And medical equipment comes later, like in 4th position on the hotspots in the supply chain. So we expect this to be helpful for the systems that are committing to zero or no, they just want to reduce their emissions, regardless of the country, to create their action plans, understanding what is the priority for them and where they can actually act and do something. And in this case, you're going to see this is an institution that tracks employee commuting. There are not many doing it. When we see this, that when they are tracking employee commuting or patient commuting, really, when we see the pie and the share of every source, it changes a lot. In this case, employee commuting was 43% for this institution, of course. And we see the notation key, as I mentioned before, for patient commuting, it says not estimated because it's too complicated, they just don't have it. And And inhalers in this case, you can see there, just because we're seeing this, MDIs they're using, DPIs they're not using. As I was mentioning, the notation keys. The members, when you submit a report, you see this treatment summary. So you see all the emissions that you have estimated, that the tool has, and then the ones that you're not estimating because the data is not available, because you think it's too complex, or because it's just not occurring, as in this case, composting. In this case, business trips, employee commuting, and patient commuting were considered too complex, so we expect this to be used when you're developing the action plans and to include in your action plan to develop a system so you can start tracking these emissions. And we actually think that employee commuting, it is important to see the impact of telehealth. We are already seeing that. And for patient commuting, that it is interesting to think about resilience, to think about the community, and to work beyond the walls of the hospital. And in this case, you see one of the reports, in this case, that doesn't include employee commuting. And in this case, purchase of electricity was huge. But this is an institution that is not tracking supply chain yet, and it's not tracking most of the scope 3 actually either. And this is when we can see a difference that as I was saying, when someone is tracking employee commuting and an institution that is not tracking. And we expect to see this in the future with supply chain too. So how the distribution really changes a lot. In this case, on the left, we have employee commuting with 46%, and on the right, one that doesn't have it, and the electricity was the highest. So we are also talking about this a lot with our members to see, so they can actually see that the share of the emissions when they make their baselines is going to change when they add more sources and when they start tracking actually all the emissions. And you can see here, like cooling in this case was more than 5%. That's interesting. That's happening in many institutions. Inhalers, 9% for them. So these are relevant. Anesthesia, inhalers, cooling, we're seeing that they can be relevant for many of these institutions. What's coming next? Here we have a picture of a training session in Indonesia. That's great. You can see actually some of the graphics in the back. Most of the work here is done at the regional level at the offices of Health Without Harm. So you have JIT on the floor today. We are creating community of practice in Latin America, in Europe, in the United States, in Southeast Asia, and we are starting really to deploy this further everywhere. We have some collaborations already with universities and researchers, so please contact us if you are interested in that. We are developing an online course in English and in Spanish that is going to be ready in the following months. We expect to have data on supply chain hotspots soon, next year. We are working with WHO and with Attach. And our next step is actually to make a deeper analysis of all the data that we have and to write and publish some scientific publications. So thank you very much. And as a last reminder, the mitigation hierarchy, this is something that we developed for the online course and that we are using in our trainings. And a friendly reminder that to tackle climate change, we need first to avoid emissions, to prevent them, to reduce, and after that comes the compensation. So thank you very much. Here in the QR code, you can go to the website where the preliminary results and a report are going to be there sometime today or at Monday at last, the preliminary results that we have, and later on, of course, the publications. There's my email and the team that work on this, that Sol and Lucila, they work in the development of the tool and also in the analysis and the report that you're going to see. Thank you.
Thank you so much, Antonella Rizzo, for that presentation, as well as to Lucilia Sissoglio and to Sol Aliano for doing all that data analysis to get it ready for today's event. We have our second panel to discuss more about what capacity is needed, what leadership skills are required for a low-carbon future of the healthcare sector. And to lead a discussion, we have Jit Sohal. She is the Regional Climate and Health Manager for Healthcare Without Southeast Asia, and she will be leading the panel today. Thank you, Jit, and please go ahead.
Thank you, Diana. I hope you're still awake. We have some snacks and drinks behind you. I hope that will help you wake up and get excited. Thank you so much. As we have heard earlier from our speakers from the previous segment and from Antonella, regardless of the context, the role of leadership and building capacity are very crucial to drive the organizational changes required to build a low-carbon future, while also strengthening our resilience to the impacts of climate change. So Healthcare Without Harm and the International Hospital Federation through the Geneva Sustainability Center are working closely with its partners and its members, including ministries of health, to take action and leadership towards sustainable, resilient, and low-carbon net zero future. Same as the previous segment, we wanted to show in this session the different contexts in building capacity and developing leadership in healthcare systems and facilities. We have 3 amazing speakers in this segment. We're going to start with Sonia Roshnik, the Executive Director of the Geneva Sustainability Center, who's not here right now in person, but is joining us virtually. Sonia, are you there? Okay. Sonia will share the highlights. Currently, right now, she's in Dubai, and she's holding the 45th World Congress, World Hospital Congress, and she's going to share some highlights, including ways of accelerating change in health systems. Sonia?
Hello everybody, I'm Sonia Roshnik from the Geneva Sustainability Center. We're a part of the International Hospital Federation, and I'm talking to you from the 45th World Hospital Congress in Dubai. I'm sorry I can't be with you in Egypt, but this is the next best thing, and I am very keen to be transmitting some of the messages to you about what's happening here. The Geneva Sustainability Center is really all about trying to make sure that we can support the leadership of hospitals to drive organizations to be more sustainable. And of course, we in healthcare, this is more important because we are dealing with the health of patients. The healthcare sector has got some special responsibility around that. We've got a unique responsibility, particularly because there's certain things in healthcare that if nobody else does, it just won't happen. You know, we're talking about medicines, medical devices, the way we deliver healthcare. All of those things are specific to healthcare, so we need to take the special responsibility to address it. Now, I'm delighted to tell you that at the World Hospital Congress in Dubai, we've had the General Assembly has signed up to a statement on sustainability which encourages every hospital everywhere. This is a really important moment. This isn't just about a few hospitals doing this. It's about scaling and accelerating action everywhere. So the things that we're planning to do really is to look at supporting hospitals with a maturity diagnostic. We're calling it the Sustainability Accelerator tool to help people on the journey. But this is going to be a long-term journey. We're going to be going for some time. The other element is that we are making sure that we can support the leadership of hospitals. And leaders in today's world have to do with so much complexity and so many emergent issues, you know, dealing with some of the impacts of climate change, but also trying to make sure that we're improving health whilst we're transforming services. And that is a skills that is so difficult to achieve in the right way. So we're here to support those leaders to feel the confidence, build the skills and the competencies to be able to take that forward. And the International Hospital Federation Leadership Competencies Framework is being updated to include those competencies. So I'd like to thank you for having us at the Health Pavilion in COP27, and we've got a member of the International Hospital Federation that is with you to speak to you, Beth Schenk from Providence, who's going to talk to you about what it's like trying to take this journey in a country like the US, where on the one hand you've got, you know, they're responsible for 27% of carbon emissions globally within healthcare, but also where there's a lot of inequity issues, probably more so than anywhere else in the world. So thank you very much to Beth and to everybody else that's here so that we can all work together and deliver a better world that is healthier, more climate resilient, and totally decarbonized. Thank you so much.
Thank you so much, Sonia, and it's great to hear about the highlights and outcomes, amazing outcome at your World Congress. And I'm happy you've already introduced my second speaker. So Beth from Providence here is the Executive Director of Healthcare, Providence Healthcare Environmental Stewardship. So Beth?
Thank you. Hopefully you can hear me. I can barely hear myself. It's loud out there. Okay, thank you. And thank you, Sonia, for that welcome. Just to follow up on her comments, our president, the president of Providence, and I'll tell you more about Providence, has been in Dubai this week speaking about this topic at the International Hospital Federation. That's an example of the kind of leadership commitment that we're seeing after years of not seeing that. You know, the years that we've all been working on this, but in the past 2, 3, 5 years, we're really seeing a shift. So let me just say a bit more about Providence. Obviously, in the United States, a private health system. We have about 20% of our health system is public, the rest is private. Then we have for-profit and not-for-profit health systems. Providence is a not-for-profit Catholic mission-driven health system, large, 52 hospitals, over 1,000 clinics. It operates in 7 states along the west coast of the United States: Alaska, Washington, Oregon, California, Montana, New Mexico, and Texas. 5 million patients seen a year, 120,000 employees. Large footprint in terms of our environmental impacts. So we have made a significant climate goal as of 2 years ago, and that's to decarbonize all we can by 2030. We put a very ambitious goal out there so that we have a better chance of making significant progress. Furthermore, we were listening to the scientists who said this decade really matters. So we've taken that very seriously. So I'm going to tell you just briefly about the 2 arms of our program: mitigation and adaptation, and another one that we add, which is advocacy. So for mitigation, we work on this in all of our health systems, hospitals, and we've developed a framework called We Act: waste, energy, water, agriculture, food, chemicals, and transportation. Just a note briefly on each of these. Waste. Healthcare waste is enormous in the U.S. In our hospitals in 2021, we created over 90 million pounds of waste. That's just us. 30 waste streams that we manage and try and reduce, and we track on our scorecard. Energy and water. We're moving as fast as we can toward renewable electricity. We're in states that are working on this, which is really important because the public sector driving this is key. The IRA, the recently passed law, will help us in the United States. Washington State, for example, has a goal to become agriculture and food pledge. Also to decrease waste through composting and packaging, and to keep healthy, local, sustainable foods that we serve healthy. For the C, for chemicals, we really work on those that are unique to healthcare. Our anesthetic agents that you heard about, nitrous oxide, which is kind of a sleeper issue, leaks a lot, almost universally, high impact. We have more emissions now from our nitrous than we do from our anesthetic agents. And then the inhalers. And then the T is for transportation, and we work on that from our business travel, even though I'm here on business, and also our employee commuting. And we're really depending on the transition to electric vehicles. Again, a public sector push. Okay, so that's mitigation. Now, adaptation. Our health system, as I mentioned, is Catholic, and this work is based in our core value of justice. And that is justice for people who are more exposed, justice for future generations of people, and justice for other species. So we have a broad commitment to this, and we've been working on this for quite a long time. But now we are also working on it from a more climate-specific perspective, and I'm going to give you another acronym, and that is, so as We Act is our mitigation, We Reach is our adaptation, and that's for resiliency, equity, adaptation, climate, and health. We have taken from Alaska to Texas, we have looked at the environmental determinants of health in each of those communities to see who is impacted, and then to see enormously important work. But this is a piece that requires culture change internally, because we're used to helping with the social determinants of health: food insecurity, housing, poverty, of course. But we're asking our caregivers who do this work to think bigger, to think at the planetary health level, so that we can incorporate these massive changes that we're seeing, not only from climate change, but also from novel entities, the plastics, the pollution, the other aspects of planetary health. That's hard for people to do because they're used to doing things the one way. So we are reaching with our ReReach acronym to stretch our thinking, reach further into the future and further into our communities. Let's see, I wanted to just say a little bit about, or maybe I should stop there and wait for the questions, because that gives an idea of what we're up to at this large health system in the US. Thank you.
Really, I'd like to hear more maybe later in the question and answer about how you're integrating advocacy into your mitigation and adaptation work. And thank you for sharing about We Act and We React. I think it's amazing work that you're doing at Providence. Thank you so much. And I'd like to move on to Dr. Anas Maroof. Dr. Anas Maroof of the Ministry of Health in transforming your facilities and your systems. If you do not know, Indonesia is one of the COP26 health program countries who've committed to the COP26 health program, and they have a net zero commitment by 2030. So they're doing a lot, and they're very ambitious. And Dr. Anas, if you'd like to share some of the work that you're doing.
Okay. Thank you, Chit. I'm very happy to be here to share the in health system in Indonesia. I think that we know the climate change is recognized as one of the most complex, multifaceted, and severe threats to humanity. And as a commitment of health program and also has condition to start to carry out the related activities. These modalities are or condition are we already some regulation. Yeah. So based on the regulation, we build and develop the health relation and low carbon in health system. Also, we have a team. Yeah, we have a technical team to implement these activities. We also have a national health plan regarding to the climate resilience. Yeah. National adaptation plan 2020 to 2030, and we are updating periodically. Also, we have curriculum and modules for community empowerment training, also for train the health worker. And we also have some of the module of preventing some diseases like dengue fever, malaria, also pneumonia and diarrhea. Also, we have a web portal, and we also have roadmap national determinant contribution on adaptation and mitigation. Some activities that we are carrying out in building a climate resilient and low carbon health system that was conducted together with the local government, with the partners, and also with NGOs, domestic, national, and national and international, like WHO, UNICEF, and also Healthcare Without Harm. Yeah. And some training will already we conducted. Yeah. We conducted training, advocacy, and dissemination. Now, especially for training regarding the health resilience and low carbon, we supported by Healthcare Without Harm. Yeah. We conduct training in Sukabumi, one district in West Java, on August 2022. And this workshop attended by 30 selected hospitals around Indonesia. This workshop to discuss about how to implement the climate impact checkup tool, yeah, that developed by the, from Healthcare Without Harm, yeah. And then, in terms of using this tool, we already conduct a coordination with Ministry of Environment and Forestry to get permission to using the tool as a mechanism of greenhouse gas inventories in healthcare facilities. And then the result of this coordination for the initial stage, the tool, I mean the climate impact checkup tool can be used while waiting for the development of a tool that has been used nationally. And I think this is very good good news from Ministry of Environment to support us to using this tool. We also identify need and implement priorities in order to effectively achieve the target of a net zero commitment by 2030 in Indonesia. Some of the priority of the activities are first, to evidence base for enhancing existing policy and regulation. Also, we conduct advocacy to the policymaker in MOH, also in related sectors, and we will scale up the capacity building among the health worker in the health care facilities. And the last, we will spread implementation of using climate impact checkup tool in healthcare facilities. So I think like that I will end our sharing in implementing the development of climate resilient and hollow carbon health system in Indonesia, and we look forward to cooperation between countries in smaller forums such as in Asia Pacific, where Indonesia is a chairman of the forum, Asia Pacific Regional Forum on Health and Environment, and also we also look forward to cooperation between another forum to create higher healthy in Earth where climate change has occurred. Thank you very much.
Thank you so much, Dr. Anas. I think the Ministry of Health of Indonesia is very aggressive because of the very ambitious plan that you have and the very ambitious commitment that you have. And I think it's amazing leadership that you're showing, showcasing to the world, to other COP26 health program countries and other developing and developed countries around the world, that if Indonesia can do this, then you can also do it. Thank you so much. Beth, I'm now going to move towards the facilitated conversation where I'm going to ask you some questions, and I'm going to start with you, Beth. Beth, Providence is also not just an IHF member, but also your GGHH member under Practice Green Health. And I think, if I'm not mistaken, Providence also collaborated with Healthcare Without Harm in the development of the checkup tool, Ella presented earlier. And so I wanted to ask you, Beth, in your experience, what are the best ways of ensuring that hospital leaders are fully on board with this agenda? And how do we collectively encourage them to go further and also faster, because we don't have enough time?
Thank you for that question. I spent about probably 10 or 15 years wrestling with that, because as I said earlier on in the climate crisis, people didn't really connect the dots. There was always something more important, more pressing. And that has really changed for us in the Western United States in the past, I'd say, 5 years. And so I think in our case, we're kind of blessed to have leaders who get that, to have a whole lot of employees who push on leaders, and our leaders will tell us that it's the grassroots people who continue to push that makes the case. Also, the public pushes on our leaders. And if the public is concerned about this, then our health plans, our strategy becomes, well, we have to address their needs, not just their health needs, but their concern, their, where their heart is. So I think those are important dots to connect in terms of how leaders see this. Now, that's not everything, because what I've learned again and again is no matter how strongly I might feel about something, and even if someone agrees, if they don't know a way to do it, that becomes a problem. So at this point, we don't need to convince people anymore in my world. I've been working on that a long time, but we have to have the solutions. So now it's about the how. So I think by demonstrating the how and demonstrating with data, that convinces leaders further, especially when we make the business case again and again about in the United States where healthcare is so expensive, we're saving millions of dollars a year from our conservation work because we're using fewer resources, less energy, less products that we buy, etc. So it becomes a circle then. But you really need leadership support at some level, but then you can drive through action and through success.
Thank you, Beth. I like that you, the kind of leadership and the action that you take are also driven by the community that you serve and the people that work for your hospitals, and that's, I think that's an interesting thing that we don't see in a lot of hospitals and health systems. Thank you so much for sharing. Dr. Anas, you've mentioned earlier about the work that you do and the collaboration you have with the Ministry of Environment and Forestry of the Republic of Indonesia. And I think that's something that we've heard for quite a few times already, me personally, about how some ministries of health are having difficulty breaking that silo.
Yeah.
So what will be your advice to other ministries of health who are experiencing that challenge of breaking that silo and having that collaboration with either the Ministry of Environment or Ministry of Climate Change?
Yeah, thank you for the question, Chit. Yeah, I think like in another country, Ministry of Environment as a national focal point, yeah, regarding to the control climate change and its impact. Also, Ministry of Environment and Forestry in our country, in Indonesia, as a national focal point for UNFCCC. So, they coordinate among stakeholders in Indonesia regarding the activities to control climate change and its impact, like mitigation, like adoption. I think Ministry of Environment as a coordinator. So, in terms of the using of the tools, check-up tool, we also collaborate with Ministry of Environment, because all of the control regarding the climate change to be coordinated by Ministry of Environment. Yeah, include to use the tool. Yeah, we coordinate with the Ministry of Environment, and they have expert team. Yeah, to discuss about the checkup tool. Yeah, and the result they give permission to Ministry of Health or to sector health to use the tool, yeah, to account the emission of gas in hospital and in another healthcare facilities. And I think as long as the coordination between health sector and the Ministry of the Environment is very well. So in another next time, I think we will enhance the collaboration and integrate it between Ministry of Health and Ministry of Environment. Thank you.
Thank you, Dr. Anas. And I look forward to seeing that flourish and develop more next year. As you said, you're going to scale this up with the help of the Ministry of Environment. Because I think it's important that we collaborate with our communities, with our health professionals, and with other sectors and with other ministries that work on climate change. And we cannot do this alone. Right?
Yes.
So we're almost out of time, so I'm going to ask each one of you to give a statement on how do we build capacity in our health systems and in our health facilities to ensure that we achieve our goals of having a low carbon, climate resilient, sustainable future. What will be like that one advice that you would have?
I'm going to turn one into three, but I'll be brief. Ambition, data, and equity. Ambition, our goal is like your goal by 2030. I think you just go for it. We don't have time to be incremental. The more ambitious goals, I believe, are also strategic because you bring in more people. There's more energy. There's more willingness to do the work for a big, significant goal. A lot of healthcare in the U.S. is pretty cautious about this, so I say go for it. Data, just like you're doing. We have to have data to tell the story. That makes the business case. It lets you track what you're doing, lets you set technical, feasible, incremental goals to get to your big goal. And the third is equity. We must always have that in our minds and in our decision making. As I mentioned, this is in our core value of justice. That's a terrific location in an organization that's mission driven, because every decision goes through that lens and other lenses, so that we're not making the problem worse through our choices, because we can't afford to do that either. Thank you.
Yeah, thank you. I think about in Indonesia, yeah, we face problem, yeah, because Indonesia has largest of the healthcare facilities. Yeah, we have more than 3,000 hospitals, more than 10,000 primary healthcare, and more than 50,000 clinics. Yeah, and we illustrate how to using the tool, yeah, to implement in all healthcare facilities in Indonesia. So we must do step by step, and also we must collaborate and work together with another sectors. Yeah, like academia, like non-government organization, so UN or United Nations organization. So we must work together to how reduce the low carbon in Indonesia. Thank you.
Well, thank you so much, Dr. Anas, Beth, and Sonia, who's having technical issues right now. Thank you so much. Thank you, everyone. And back to you, Diana. Oh.
Thank you, everyone. Actually, we're going to pass it to Dr. Darmit Campbell-Landrum, or Darmit.
Thank you for the correction on the formality. Thank you. Thanks for starting off formal and coming back informal. I won't keep you very long. I first off like to compliment you on your patience and perseverance. We've had pretty much every challenge that could be thrown at us in terms of the technical challenges of having links outside, the coinciding with happy hour at neighbouring pavilions, and the food that's being taken to neighbouring pavilions. So thank you once again so much for staying here late in an evening to discuss this really important issue. It's been a long discussion, and I found it a really fascinating discussion. And the reason I found it fascinating is because of that breadth that we alluded to at the beginning. We started off in some of the poorest, hardest hit situations in the world with our colleagues from MSF and ICRC talking about the impacts of climate change in places where they were already struggling. They were already had massive problems in just meeting unmet needs, and now climate change is throwing additional challenges at them. And then we ended up going through some of the rapidly emerging economies, hearing from India, from Laos, from Indonesia, about their work on, yes, working to increase resilience, but also thinking forward to decarbonize as well, recognizing they have a role in decarbonization, not just because there are emissions associated with it, but also because that is the future of healthcare now, because many of the things that we need to do will save money in their healthcare system, allow you to provide better services, and by the way, reduce emissions if we do it right. And we ended up in the US, the biggest economy in the world, some of the richest, certainly the most expensive health systems in the world, also talking about these same issues. And nowhere in that spectrum did anybody say, yeah, not our business, that's not relevant here. It's relevant in different ways in different parts of that spectrum. And even the issue of decarbonisation, which the poorest parts of the world and those most hard hit that we heard at the beginning, even there are things that can be done, and there it's not about decarbonisation for decarbonisation's sake, but it's because answers like solar energy on healthcare facilities are just a better answer than trying to improve energy access through diesel generators and so on. Even there, those aspects are relevant. There are another couple of common themes that I saw across this particular spectrum. So we heard about the importance of data. So that's relevant, again, whether you're in the US or even in, maybe even more important in those most desperate situations where resources are at their most scarce. If you're having to pay people with food rather than money, you really know about information and the importance of managing resources. So that information is always going to be really important. We also heard about the importance of community action as well, whether that's the affected communities or the health workers, which, again, in the poorest parts of the world, that's often the same people. Basically, you have people embedded in these situations. And we know that even in high-income countries, you don't get real action on climate change mitigation or the decarbonisation of health systems or anything else unless your workforce is motivated and empowered and feels they can do things in their day job. Because we think we're seeing a really important, a transformational shift from a passive support by the health sector for climate resilience and decarbonisation to an active support. Basically, we're fed up with not enough action by others. We're going to have to step up, and there are things that I can do in my day job, and that then creates the virtuous circle that you referred to. So I think we have all of those common messages. I'll just do a little bit of advertising, but it's advertising you've heard before. Many of the words that you see on that slide are embedded in our Alliance for Transformative Action on Climate and Health. We say ours because WHO convenes it, but again, it should be everybody's. We want this to be inclusive. And that's about following up and supporting the countries who made the health commitments at COP26. So we encourage countries to sign up to decarbonise their health systems or to work towards it and build climate resilience. We didn't want that just to be on paper. We didn't want them to be left unsupported. So that's the purpose of the attach. And so that should be, we're setting that up as a meeting point where everybody can come together, again, across this wide range of stakeholders, because we do need everybody wherever you are, and we really do have a common mission. The final thing I wanted to say is basically the core values that drive this, and it was something that that Stephen Cornish said from MSF, and I saw sort of reflections on it a little bit on the slide that Antonella presented, and she had that triangular slide about, and basically it's the idea is you want to prevent things, and then if you can avoid it completely, better, and then you manage and compensate and so on, and it rang a couple of bells with one of the ways in which we think about the climate crisis. Now, I don't know if he was the originator of it, a professor, a colleague and a friend of mine, talked about the need where there are three things that will happen with the climate crisis, three responses to it. You can mitigate, you can adapt, or you can sponsors to it. You can mitigate, you can adapt, or you can suffer. If you don't mitigate, well, you're going to have to do more adaptation. If you don't mitigate and you don't adapt, you're going to have to suffer more. So we want to try and, again, move up that kind of triangle to do absolutely as much as we can on mitigation. We know we'll need to adapt because we need to reduce the suffering. And the final point I wanted to make, which also came out, the one that came out of Stephen's remark, but we also heard at the end, is the issue of equity and fairness. It drives everything we do, and it should drive everything we do. And there are certain things, as Sonia said, that can only get done within the health sector, that can only get done in a hospital or elsewhere. We need to take care of our own business. But we also have to recognise that this is an equity issue. It's basically a fairness issue. And that is something that I think most people who work in health identify with. So we need to do what we can within our own sphere, but we also have to support all of the other people, all of the other pavilions that you see around here, even the ones having a drink and making noise next door, they're probably celebrating some great win on agriculture or something else, water and sanitation, something else that's also important for health. So we do need to keep that equity in mind and keep that allyship in mind as we go forward with our own mission. So I think, if I understand, there's been a slight change in program. Q&A will take place over drinks and snacks, I think, but I'll leave you to make that announcement, Dan.
Thank you, Dermot, and thank you every panelist that came up here to discuss their experience. Purnima from PHFI, the Ministry of Indonesia, the Ministry of Law PDR, MSF, ICRC, and Healthcare Without Harm, as well as Providence Health System. And thank you to WHO for hosting us tonight. As Dermot said, instead of having a formal Q&A, we are going to do it informally. We have some snacks and refreshments over there for everyone who's in the room. And if you'd like to speak to the panelists and the moderators and speakers, please do so at your leisure now. And thank you everyone who's joining us from online. And thank you also to Sonia Roshnik and Anto Riso, who are online and recorded also their messages to you today. Thank you.